4 terms that reflect the spirit of motivational interviewing. Most importantly, we want to educate and inspire you to help your patients or clients to change their behavior around smoking. The agendas are going to be a great agenda today, jam-packed. We started with the welcome. I'm speaking now from Smoking Cessation on the Smoking Cessation projects in Los Angeles County, and I'm summarizing the CME and CE processes. And Norma Matumbe will give a little presentation shortly. From 8:30 to 9:15, we have Catherine Benoit, the Deputy Director of UCSF Smoking Cessation Leadership Center, talking on some smoking cessation and behavioral health in California. From 9:15 to 10 o'clock, we have a great talk by Peter Selby, Milestone Approaches to Smoking Cessation. We have a short break from 10 to 10:10. From 10:10 to 11 o'clock, we have pharmacotherapy and tobacco dependence treatment with Frank Vitale, Director of the National Pharmacy Partnership. From 11 to 11:40, we have a fascinating talk that's really going to be influential in how the FDA views smoking, on titled Low Nicotine Cigarettes and Their Potential Role in the Tobacco Control by Neil Benowitz, who's one of the pioneers in this area from UC San Francisco. We have a panel on tobacco-free recovery perspectives from the field. We have another short break from 12:15 to 12:25, from 12:25 to 1:25. We have conversations about changing the use of tobacco products with Brian Hurley. And then from 1:25 to 2:10, we have Tasha Dixon talking about helping others quit. And we have a wrap up and closing with the CME and CE recap at 2:10. We have 3 fantastic keynote speakers, Catherine Benoit, Peter Selby, and Neil Benowitz. So people are really in for a treat today. These speakers are outstanding. So TRDP stands for the Tobacco Related Disease Research Program. It's funded by the University of California Office of the President. It's funded by tobacco tax. In 2018, there was 3 projects funded under the Community Practice-Based Research Implementation, including our grant. The other 2 were from UC San Francisco and UC Davis, and we've been in touch with the collaborators on these grants. The goal of the TRDP Implementation Science Award is to connect health service researchers that can lead to system changes in delivery of smoking cessation services for low-income smokers, including Medi-Cal population. And our program officer is Norval Hickman, who's been absolutely very helpful in getting our grant to fruition. Our grant is entitled DHS DMH, Department of Health Services and Department of Mental Health, TRDP funded Smoking Cessation Implementation Project. We're embedding comprehensive smoking cessation programs into LA County clinics. So we're not like creating new clinics. We're trying to have existing clinics in Department of Health Services and Department of Mental Health give smoking cessation services. Our grant provides assistance in these community clinics. It expands integrated clinical programs with smoking cessation medications plus smoking cessation counseling. It's Department of Health Service IRB approved and DMH HSCR approved. We have several smoking cessation sites. We have 11 in the Los Angeles County Department of Health Services in the patient center medical homes, and 7 in the community mental health centers of the Los Angeles County Department of Mental Health. There was randomization. The intervention arm has 9 primary care medical home DHS sites and 6 Department of Mental Health sites. Treatment as usual means they are their control group. They get what's currently going on. 2 of them are the PCMH sites, and 1 is the CMH health science sites, health center sites. The ones listed are here. Martin Luther King, LA County are the 2 treatment as usuals. Roybal, Harbor, Carson, Harbor, Lomita, Hubert Humphrey, Mid Valley, Long Beach, Claude Hudson, High Desert, and Olive View. And in the DMH, the sites, the treatment as usual is Arcadia Mental Health, East San Gabriel Valley Mental Health, Harbor UCLA Mental Health, South Bay Mental Health, West Central Mental Health Center, West Valley Mental Health Center, and our newest one is the American Indian Counseling Center. Patients at any of these DHS or DMH, any of these DHS sites can go to the treatment sites near them. Treatments in PCMH or in DMH mental health will go to their existing clinics for the services. We do, the intervention is and includes expected practices and policies permitting evidence-based treatments. DHS has behavioral health clinicians that are delivering most of the delivery of the smoking cessation services. DMH clinics have also offered, leadership has offered smoking cessation services. Both systems have access to medicines, nicotine replacement therapy, bupropion, and varenicline. There's ongoing training, technical assistance, and decision support from the DPH Tobacco Control, Department of Health Service, Addiction Medicine, and our TRDRP funded clinical experts. So there's a lot of ways people can get help with getting their patients or clients to stop smoking. The study that we're involved in is wrapping up. Our recruitment's ending in November 2022. Incentives include up to $50 per year. You have to be 18 years or older, a patient at either Los Angeles County DHS or DMH, and smoking at least 3 cigarettes a day. And the patient or client wants to reduce or eliminate their tobacco products. So our progress includes that we've enrolled 338 study patients. We have over an 80% follow-up rate for the 3 and 6 months and a 79% follow-up rate for the 12 months. So most of the patients do stay in our study. Our recruitments have continued even through COVID. We have an expanded referral source, which includes patient self-referrals, pre-screened patient list generated from the record system, referrals from clinical providers, and the referrals can be sent 3 ways. One is by messaging the navigators through the DHS patient management system, which is named ORCID. A second is to send an email to the navigators' DHS email. And third is to use the multi-patient task list, or MPTL, for smoking cessation services. We have a new colleague who's extremely helpful, Rishi Balani, MD, at Huber Humphrey, and he's worked with DHS leadership and a lot of the DHS primary care providers to get them to increase the referral here, including we started a competition for the most referrals. So this shows the numbers, and it's a large amount of numbers that we start with, but we get a little less for the study. It turns out that we had enrolled in the intervention sites in DHS, 155 patients, 74 in the treatment as usual sites, for a total of 229 in DHS. In DMH, Department of Mental Health, we've enrolled 83 in the intervention sites, 22 in the treatment as usual sites, and 105 total. So our total comes out to 338. This shows the amount of cigarettes smoked as measured by per day, as measured by this timeline measurement. And you can see on the left, the first column, the group 0 is the control group. So these are the treatment as usual group. There was a slight but significant decrease in the amount of smoking even in the control group. It went from 10.8 to 9.5, and that was slightly significant. However, in the intervention group, there's a big drop in the amount of cigarettes smoked from 10.1 at baseline, 8.5 at 3 months, 7.2 at 6 months, and 6.4 at 12 months. And these were highly significant, as shown on table 4 on the bottom here. So I think we might have expected people to start re-smoking and increasing their cigarettes after like 12 months. It turned out they continued to stop smoking after as the months went by, which is a good sign. We've engaged in clinical staff and trained providers and staff to facilitate the 60-minute cognitive behavioral therapy smoking cessation counseling group, which we call KICASH. We've trained providers in both systems to deliver smoking cessation medications at all participating clinics. We've had a bi-monthly medical management for smoking cessation webinar led by our study's co-PI, Dr. Brian Hurley. This webinar is open to all DHS and DMH providers and gets a nice attendance. The clinics work closely with smoking study coordinators, which are known as smoking cessation navigators, to connect patients with KICASH and medication prescribers to ensure that patients receive the desired smoking cessation services. This shows a little bit more data, which I think, again, shows sort of the effect of our intervention, especially with medications. The graph on the left shows all the medications prescribed with time from when we started the study till now. The red is the control or the treatment as usual group, and the blue is the intervention. You can see that there's an increase in the amount of medications prescribed, more in the intervention group than the treatment as usual group. On the right side, it breaks it down by the different types of treatment, especially the nicotine gum seems to be increasing the most. The varenicline tablet is going up next, and the nicotine lozenge is going up third. So the nicotine gum is increasing at a faster rate, but in general, more prescribers are using smoking cessation medications in our systems, which I think is a very good sign. We've had 5 publications reciting the grant. They're listed here. And these have, I think, have been high impact articles. Okay, I'm going to turn it over to my dear colleague, Norma Stoker-Matume, who's going to be talking about looking back, moving forward. And you,
Hi, I'm Norma M. Toomey, and this is my story regarding community engaged research. More recently, I've been thinking about medical care in South Los Angeles from a historical perspective. I grew up in Los Angeles in a poor neighborhood. From childhood to early adulthood, I received some basic primary care at a local doctor's office. However, when we didn't have insurance and cash was low, it was off to the old county hospital where a basic visit would take an entire day. I remember traveling a long distance to see a doctor, especially for specialty care. We would take 3 buses to get to the hospital and the clinic until a county facility was built in our more immediate community when I was 22 years old. I remember smaller local hospitals where my siblings were born and some county clinics, but they didn't provide the care we needed. Only recently did it dawn on me that many Black doctors lacked the admitting privileges in major hospitals. Consequently, after providing prenatal
Folks can't hear Dr. Friedman.
offices, they sent their patients to hospitals where they were allowed to practice.
can't hear?
No,
No, I can hear it.
I'm getting the chat that's very low.
Math and life science in school.
Yes,
I
very
loved
well.
education and running street races with the neighborhood kids. I decided that I wanted to teach math and physical education when I grew up. Consequently, I began Cal State University at Los Angeles with a physical education major and a math minor. As time went on, I realized that it wasn't just the body I was interested in, it was overall health. Not much had changed since I was a little girl. I wanted to help make a change to ensure poor people could be well. In my sophomore year, I became involved with neighborhood social services and helped to start and direct a free clinic in South Los Angeles. My interest grew to include a more holistic approach to healthcare, and I returned to graduate school to study more about health and mental health. During my career, I helped to establish and serve in leadership for 2 other community medical and behavioral health clinics in Los Angeles and Berkeley, California. 8 years ago, I became involved with Charles Drew University and the University of California at Los Angeles Medical School's research endeavors around community engagement. I was invited to work with the schools and their students to help them develop best practices to engage with their patients in the community. I work with basic science researchers who are hard at work looking for causes, developing treatments, and hopefully finding cures for many illnesses and diseases that plague our poor and under-resourced communities, like those in South Los Angeles. Here, research is being conducted with and not on communities. As an individual with a diverse background, I participated as a full partner on non-traditional research teams in what is called community engaged research. I serve as a community representative on advisory boards that oversee the overall projects. I have conducted interviews, facilitated focus groups, and participated in planning events to disseminate research results back to the community. Unfortunately, things still haven't changed much since I was a child regarding poor health outcomes in my community. Poor people still have the highest rates of disease, disability, and preventable deaths. For instance, the decrease in smoking cessation rates across the nation still are not translated to lower rates of tobacco use in African American communities. My work over the last 8 years has culminated in my latest project, where I will be working with a research team to implement smoking cessation services in Los Angeles County mental health and health services clinics. I no longer consider research as something mysterious, but it's something that warrants my attention and involvement. I work now to help with educational and health systems change to reverse these trends to ensure a longer and better quality of life for those in my community. Health science research studies are important because they help us to better understand illness and disease and what prevention, interventions, and treatments might work best for various populations.
Most community engaged research is paid for with your tax dollars. So why not join me? Learn more. Get involved.
Okay, thank you. Just a couple of notes following that. First of all, it's a little dated. It's been like 12 years since I started working doing this type of community engagement. And when I mentioned that the rates for decreasing smoking didn't happen as much didn't happen in the Black community, it did happen, but at much lower rates than other communities. So thank you all for joining us this morning. And those of you who have been on these trainings before, you've heard me talk and say pretty much the same kind of thing. But I keep saying it because people in my community are still dying and suffering. And I wanted to just say that we want to help set the stage for what we're going to be thinking about today, what we'll be learning, and how we will take that back and put some of this information that we're receiving and use it to put into practice, helping. Okay, sorry, I was a little distracted with that movie. Helping our patients and our clients to be able to reduce and change their behavior around smoking so that they can live longer and better and healthier lives. I spent most of my career building and helping to run nonprofit organizations in South Los Angeles and similar communities. And by similar, I mean communities where health disparities abound. As you all are probably aware, smoking has been shown to have a direct causal or significantly exacerbating effect on many illnesses and diseases. Moreover, research shows that smoking can be detrimental to all systems of the body. As a community engagement advisor, my key role in this project is to help ensure that we keep the real goal of our work at the forefront. We do the work we do to help our patients, our clients have a better quality of life. Bottom line, we want to help save lives. But some days I still feel like I'm a casualty of trauma and disparities. These are some of the reasons. My maternal and paternal grandmothers died from strokes, and one also had diabetes. One of them smoked. My mom was killed in an accident while working for Los Angeles County. An elevator crushed her. One brother was murdered about 6 months after mom passed away. One brother, a smoker, died from colon cancer after a botched surgery while incarcerated. One more brother had a series of strokes, and we suspect it was a stroke that caused him to crash his car on the freeway one day, and shortly afterwards, he died from internal injuries. Oh, and I'm just getting started. My sister died at the age of 50, around 7 years ago. She had Parkinson's, diabetes, hypertension, and asthma. Oh, but did I say she smoked? Her husband passed away about 3 years ago from cancer. He smoked. And I haven't even touched on the mental health and HIV/AIDS cases in the family and dear friends, most of whom also smoke. My dad, who was always my biggest cheerleader and hero, died from lung cancer 13 years ago. In 6 months, I watched him go from a robust 185-pound, fun-loving grandpa to 95 pounds and too weak to stand on his own. He covered the mirror in his room because he couldn't stand to see his reflection. To emphasize the addictive quality of nicotine, he had 3 heart attacks before he stopped smoking. By then, and unbeknownst to any of us, the lung damage had already occurred. Also, one of my dearest friends since 7th grade died 2 years ago after a bitter battle with lung cancer. She also smoked and had the hardest time quitting. And this year, I add another casualty, my first cousin who passed away 6 months ago from lung cancer. We were childhood playmates. So you see, my work with this smoking cessation project is personal. I realize that I am but a step away from being one of the statistics will hear about today. I want to help see that others don't have to watch family, friends, and friends suffer and die from smoking-related illnesses as I've done. The best plan is to prevent ever starting to smoke. The second best plan is to intervene as soon as possible. I believe that integrating smoking cessation services into medical and mental health clinics is moving Los Angeles County in the right direction. I'm proud to be a part of this team and look forward to better outcomes for patients struggling to change their behaviors around smoking. And I figured out I must be still standing and have good health at 72 years old for some reason, and so I continue to do this work. Again, thank you for joining us. Welcome.
Great. Thank you so much, Norma. Any questions for Norma or comments? Okay, so we want to especially thank the California Tobacco-Related Disease Research Program, TRDP, for funding us. The great Norma Matume, Brianna Lopez, who's did all the AV work and helped a lot with the slides, and she's one of our other study coordinators. The grant, we have Catherine Benoit from UCSF Smoking Cessation Leadership Center, Peter Selby from University of Ontario, and Neil Benovitz from UCSF. Those are our three keynote speakers. We have Frank Vitale, the Pharmacy Partnership for Tobacco Cessation, Friends Research Institute, which is our agency, great agency where we our grants funded through. It's headed by Frank Voci, and great institution. Our CME is given by Beth Rutowski, Gloria Miele, Kimberly Valencia at UCLA's ISAP, and we thank the panelists, other presenters, and you, the participants. And with that, we'll go on to the speakers. I think, okay, we'll talk about this in the end, but remember to stay to the end for your for the evaluations and the CME and CEs.
You ready for presentation?
We are.
Okay, let's see if I can pull this up here. Can you see that?
Yes.
Yes.
Make it full screen. I think it's
Yeah, almost. There we go.
okay.
Well, that was, first of all, hello, everyone. I'm Catherine Bonio, and I am the Deputy Director, as you heard, of the Smoking Cessation Leadership Center. And I am also privileged to be the director of the National Center of Excellence for Tobacco-Free Recovery. And I just wanted to say, amazing story, Norma. I had no idea. I just am so in awe of how you're continuing to champion the cause. And then with Dr. Friedman, the work in LA, just to think that you all have done so much to bring sort of that equal access, right, to cessation resources for everybody in the community, and just sort of saturating. If we can get that done in the nation, in the state, I'm sure we're going to be saving lives, continuing to save those lives. And apologies for the sun, but you know, if my glasses go a little dark, you'll know why. It's a sunny day here in San Francisco. All right, so I've been tasked with talking to you all about tobacco use and behavioral health, and specifically getting into an initiative that we had here in California and how it can relate to you and your work, and then highlighting a new bill that is across the state, and then ending with a great set of resources so that you can go out there and do good work. So get going here. To give you a quick idea of our center, we've been around for quite some time. As you can see, since 2003, we're a program office of the Robert Wood Johnson Foundation, but we are housed at the Department of Medicine at UCSF. And if you look off to the side there, you can see we have new buildings down in Mission Bay. That's the hospital, the Children's Hospital. But we are very, very proud to be right across the street from the world famous Chase Center, where the Warrior Champions are. So we're just as proud to be by the hospital, but also proud to be by the Warriors.
Yay, Warriors.
I know, I was going to say, maybe I shouldn't have said that, because I know you all are probably Lakers fans. Anyhow, so our group focuses simply on increasing successful quit attempts and reducing that smoking prevalence. And one of the main strategies has been to help providers do a better job at working with their patients and helping them quit, as well as advocating for equal access to cessation services, which is what LA County is doing right now. So we're really happy to be working with them. And you can see we have a new partnership with Los Angeles County. I'll talk a little bit about that later. The National Center of Excellence, and this is kudos to SAMHSA and thank you to SAMHSA for finally recognizing the importance of really tobacco-free grounds, integrating cessation into treatment practices, both behavioral health and primary care, and our goals, as you can see here, educating as many behavioral health and primary care clinicians as possible. One of the other things that we do is we work with states, and we help each of these states that you see here, we're up at about 24, to create action plans to reduce the prevalence of smoking in the behavioral health field. And you can see we haven't yet gone to California, but we do have other work, and I'll be talking about that. We're also a national partner of the CDC TIPS campaign. I want to put this up here. You're going to get these slides so you can scan and get all these great resources. And this is Rebecca. She is the one of the tips from former smokers that is talking about her depression and how quitting smoking actually helped her with her depression. All right. So now I'm going to sort of bring us all up, I think, to an equal playing level here and understanding of tobacco use in the behavioral health community. Yes, we all know, especially living in LA County, I'm sure, and in California, smoking rates are down. You don't see as many people out there in the community, but just to kind of highlight the deadly toll that has come from, earlier years, since 1964, cigarettes have killed about 20 million Americans, and 2.5 of those never smoked. And then you can see this awful statistic here about 100,000 infants. This currently accounts every year to over 500,000 deaths, right? And of those, you're looking at about 40,000, again, who never smoked. You can see the cancer rates. 16 million adults live with smoking-related illness. And this is, for example, as you see here, COPD, chronic obstructive pulmonary disorder. A lot of people, when they smoke, think, I'm just going to keel over one day and die, have a heart attack or something. But unfortunately, what happens is there's a much longer, drawn out list of debilitating diseases that people have to live with. And that is actually one of the points of the CDC tips from former smokers ads. And then you can see ultimately that cost, an economic impact when you think about the healthcare expenditures, the lost productivity of $300 billion a year, right? And then, yes, currently we're doing pretty well, but we still have about 31 million smokers out there. I think that may be going up slightly since the pandemic, but 75% daily smokers, 14 average, and that also has been going down. So that's kind of good news, but it's still a lot. I think you probably all know this, but just having this visual, smoking really does affect pretty much every organ in the body, including the brain. And with secondhand smoke, this was from the Surgeon General's 50th anniversary report, we have found out that there are even more areas that smoking affects. And on this one for secondhand smoke, the more recent discoveries is childhood depression and bruxism in children. So there's no safe level of smoke. So moving on, this is the data as it relates to behavioral health and smoking. And remember, when I'm talking about these numbers, a lot of the times it's actual souls, right? Individuals who've passed on, but at the same time, it's individuals who are addicted to nicotine. So just keep in mind, it's not just statistics. So we've got about 25% of the population here in the US that has a behavioral health condition. You can see those who have more, two or more. Or one or more. And then with that particular population, so if you're looking at 25% of the population, that group smokes 40% of all the cigarettes sold in the US, 2 to 3 times higher than the general population. So somebody's making quite a bit of money off of this group. I mean, 40%, 25% of the population smokes 40% of the cigarettes. That should tell you something right there. And then in addiction treatment settings, so addiction treatment settings where people go to feel better, get better, recover, you're looking at 53 to 91% of individuals smoke within these settings. That's sort of an oxymoron. And then unfortunately, they're more likely to die from tobacco-related illness in treatment for the drug that they're in for rather than that drug. Does that make sense? So more deaths than alcohol or drug use bringing clients to treatment. And those death rates among tobacco users are 1.5 times the death of other addiction-related causes. So all put together, it is a minimum of 10 years life lost, individuals dying early. There are studies that are up to 25 years earlier than the general population. You can see about 250,000 deaths. Adding to that, of course, right? Cancer, smoking, you're probably thinking, of course, but with mental illness as well, it's another heavy hitter. In general, lung cancer is the biggest killer for both men and women. In addition, cigarette smoking is that #1 cause of cancer, lung cancer. So if you piece it all together and you think about these individuals in the behavioral health community that smoke, 50%, more than 50% of individuals with terminal cancer have at least one psychiatric disorder. And then those individuals with mental illness may develop cancer at a 2.6 times higher rate. And this is mostly because of that late stage diagnosis. They're not getting the treatment that they need, whether that be the providers that aren't asking, or they are not going in, or they don't have access to that treatment. So ultimately, you've got individuals with mental illness that have a higher rate of fatality due to cancer. Another reason why their loss of life is so early. And then we've got, what do you want to say? The triple whammy here. COVID comes along, and yes, of course, here we are again with those with behavioral health conditions also being more likely to contract COVID. Cigarette smoking definitely compromises the immune system, if you didn't all know that, and it's associated with an increased risk in general for pulmonary infections. So COVID comes along, it's going to increase the severity of illness among COVID-19 patients. They're more likely to go to the ICU, be put on the respirators, and unfortunately die. And you can see here the recommendation from CDC, basically, if you smoke, quit. If you don't start again. Don't ever pick it up. So this is just a different way of looking at things. These are literally preventable causes of death. So what we could have done to prevent people from dying in these different arenas. So to the right there, you've got weight, obesity, you have drug-induced suicide, motor vehicle, alcohol, homicide, HIV. You add all of those up, and you still do not equal the amount of deaths that occur that are attributed, that could have been prevented every year, over 500,000 deaths every year attributed to tobacco. I think this is always a shocker. And then just for perspective, in 2020, you can see about 375,000 individuals died from COVID. So you keep every year for tobacco, unfortunately, even since my whole career here, it's pretty much been steady. Hopefully it'll start going down, but we're looking at over 500,000 and every year, and not just in the past 3 years. And then that second line there, that little sort of flowery line there, is represents the individuals that die every year with a behavioral health condition who smoke. So that's about half of the half. So yes, I think that just sort of tells you all where we're looking at. And we do have progress. We're happy to say, in working with the NASHPID, the National Association of State Mental Health Program Directors, we're now looking at psychiatric hospitals going free. We're up at 96%, nearly 100%, all doing this on their own accord. Now, the psych hospitals were left out of the Joint Commission measures that said all hospitals have to be tobacco free. And there's a whole backstory to that I will refrain from at this point, but just suffice to say, there was a little bit of tobacco industry marketing and advocacy work going on behind the scenes, but they were left out. So this is actually a really big deal that they are now going tobacco free. So kudos to them. And you can see the prevalence is going down, and this is in the behavioral health community. So those who smoke with a behavioral health condition is now going from, back in 2008, 41% down to 25%. But as you can see, I've highlighted there, you've got still that 2 times double the rate of those who don't have a behavioral health condition who smoke. So it is a disparity. And all of these populations are affected by tobacco use, and smoking is among the marginalized, and it is a social justice issue. There's no reason why all these individuals should be at the highest rate of smoking. It's what you heard from Norma talking about at the beginning in that video. It's just, there's something we've got to do here. We're looking at a social justice issue. So I gave you like a bunch of data, right? The individuals, and you kind of understand where we are as a nation. But at the same time, I really want to emphasize that there are reasons behind this. We don't want to just point the finger and say, hey, they just smoke a lot, right? We're going to have to help them quit. But no, there are so many reasons behind this, as you can all imagine. First of all, nicotine is highly addictive. It's more addictive than heroin. And we're looking at one of the most difficult things to quit. And this population, unfortunately, has had industry-funded research that has pushed cigarettes towards the community. Funding paper research that says, nicotine or smoking will ease your client's symptoms and make them feel better. And you can, in essence, control them a little more and help them through treatment. And going in to communities that are serving the homeless population or the LGBTQ population and bringing cartons of cigarettes to these organizations along with the papers that, say this is going to help your clients. And so therein starts the process. Oh, we need more cigarettes. Can you get us more cigarettes? This is great. It is working. And it became this whole cultural norm. And that up on the upper left there, Project SCUM, is from PM Philip Morris, and that stands for Subculture Urban Marketing. And that was literally the title of their service going into these, underground kind of communities that they felt they could work with. And really what was happening is it was just masking symptoms. And unfortunately, somebody ends up really trying to smoke more and more and more and more to keep it steady, and unfortunately becoming more addicted, getting more of the tobacco and the toxins in their system. And then off to the bottom left there, you can also see how the marketing is always said, if you smoke, it's going to ease you, it's going to relax you, and even going so bold with merit there in the schizophrenic ad for getting your symptoms down. One of the bigger pieces I'd say for this community, everybody's been target marketed, right, by the industry, but in addition, they're faced with lots of trauma, and exposure to all sorts of trauma will, especially prior to the age of 12, will increase that person's chance of taking up smoking at an earlier age. And there's ACEs, adverse child experiences. The more they have experience, it can be anything from, living in an abusive relationship or witnessing abuse or divorce or death. But the more ACEs that an individual has, the more likely they will to take up smoking early, to smoke more, to smoke longer, and to suffer from the consequences. And you heard, we were talking earlier, but the delays at accessing care and quality care, and which is so great to know that LA County is really working at trying to get out there in the field and offer these options for people. It's very important. But excuse me, social determinants of health is what ends up happening, right? You've got where you live, work, play, get your care or lack thereof, has a huge part. And that's where you see those disparate communities and the marginalized. Adding to that, you've got stigma from providers, stigma from the community, and you might have a clinician that's like, hey, I have tried so many times and you still can't quit. What is wrong with you? And really what we're trying to do is turn it to what has happened to you, right? What has brought you to this situation right now? And having an empathetic tone and believing in that individual that they can quit. And that is where you're getting more into a trauma-informed care approach, which is essential. I'm going to dig in just a little bit to each of these things that I was just saying. But here's just a different way of looking at the adverse child experiences. So you can see there with the 5 or more, 21% of those with a 4+, I meant to put 5, ACEs report the early initiation of smoking compared to only 5.5 without. So that's just proof is in the pudding. And then the myths. So I want to go quickly and make sure that you all pay attention here so you don't believe any of this stuff that's been put out there. So the first one is tobacco is a necessary self-medication, right? Oh, it's going to help individuals, or the person who smokes feels like it's helping them. So what is happening, and as I mentioned earlier, it literally is, tobacco is masking, or nicotine is masking their symptoms, but it's very short-lived. And so an individual, say, who has schizophrenia or even is just in chronic depression may feel like it's making them feel better. But it's literally masking for such a short period of time. And that's one reason why you may have somebody who smokes heavier, wanting to keep that feeling, keep it going, end up becoming more and more addicted. In addition, people may think, oh, it's making me feel better. I'm so stressed out. I want to have that cigarette because I know it eases my symptoms. It makes me feel more relaxed. where in fact what's happening is that part is short-lived, and what ends up sort of happening to the individual is they're just responding to withdrawal, and it becomes sort of this vicious cycle where they think it's the cigarette, but instead they have withdrawal symptoms and they have that cigarette and it makes them feel better. So it's vicious cycle. Industry has supported this whole myth that it actually does help, where in fact it doesn't. They're not interested in quitting. That's just been refuted. It's the same percent that wish to quit as the general population. You're looking at about 70%. And they can't quit, right? Oh, I've tried everything, nothing works. Let's just treat them for something else. And this is also wrong. You're looking at quit rates that are the same depending on where you are, maybe slightly lower than the general population. And that could just be because they're not given appropriate treatment, need a little bit of longer duration NRT kind of thing. Now, this is another big one. Quitting worsens mental health and addiction recovery, right? It's going to mess them up. They need to be stabilized. We don't want to do this. Let's just let them have their cigarettes because they're already being treated. They're already going through withdrawal from alcohol. We don't want to do this to them. It's actually the opposite. It's the opposite, folks. So quitting actually improves mental health and increases sobriety, especially for alcoholics, by 25%. That's long-term sobriety as well by 25%. And it is literally the opposite. So we just had a webinar, I think it was last week, where the whole presentation was how quitting actually can improve mental health. And so trying to flip it and think, wow, is cessation actually a way to treat mental health? Because it will increase positive moods to the equivalent of an antidepressant. And knowing if you quit at the same time, quit cigarettes at the same time that your drug you're in treatment for, 25% increase in long-term sobriety. I mean, that's another one that's been buried. And then finally, it's a low priority problem. Smoking is the biggest killer for those with mental illness and substance abuse, as I showed you earlier. So there's just absolutely no way it could be a low priority problem. This is just another way of looking at what I was saying. This was from the Cochrane review, a meta-analysis of 26 papers. And the group, all the information led to cessation decreases depression, anxiety, and stress, and increases that positive mood and quality of life. I highlighted those two messages there. The effect sizes of smoking cessation is equal to or greater than the antidepressant drugs for mood or anxiety disorder. It's equal to antidepressant if somebody quits smoking in terms of the positive effects. And then with smokers, pre-existing alcohol, you can see that there, less likelihood of reoccurrence, and then that 25% increase. So just put that in your brain and remember that one. So SAMHSA has figured it out, and their recommendation is for all of their facilities to adopt tobacco-free facility grounds and integrate cessation into behavioral health care treatment. And as such, you are going to learn a lot about all of this later in the day. So I'm only going to just quickly touch upon it, but I just want you to know there's so much out there to help you do a great job to help your patients live longer, healthier lives. There's counseling that many of you probably already know, but just haven't applied to tobacco dependence treatment. It's the same thing as, cognitive behavioral therapy, motivational interviewing. NRT is the same thing as medicated assisted treatment, which many of you probably already know. And then there are brief interventions. The 5 A's is the same thing as at screening, brief intervention, and referral to treatment, which is much more in the behavioral health community. And in the smoking cessation community, we have created an even briefer intervention, and that's called Ask, Advise, Refer to services in the community. For example, all these great clinics that are in the county, and in addition to quit lines. And those quit lines are going to double a person's chances of quitting. And you can see there, putting those great policies together is going to really enable the above. If you're going to make smoking more difficult, then you got to make quitting easier, right? So here is Kick It, California. Many of you probably already know it. I just want to make sure it will double a smoker's chance of quitting. And in addition, you can double a smoker's chance of quitting. So if you put that together, a clinician's advice, and you refer to the quit line, you're really giving that person a good chance. It's free. UCSD researchers, trained coaches, many of them are master psychologists, all sorts of languages. And you can see there in 2021, 27,000 users. You've got text, you've got mobile, you've got online, and for your own benefit, there's even a email referral that you can click and just send them your client off to the quit line. So my whole point there is that there's sort of no reason. Now you know you can at least ask your client, do you smoke? Advise them it's, the best thing you can do to live a longer, healthier life if that's the motivation. And then you can refer them to a quit line. And that could take as little as 30 seconds to save a life. And yes, the quit line does treat those with behavioral health conditions. In fact, they did a study and found out half of the individuals that were already calling over the years self-report a behavioral health condition. All right, so we're moving into California a little bit more here, and California is quite ahead of the game. So you should be proud. The state prevalence is 8.9%, and that is compared to the national, which is 12.5, which is still very good, and ranks second in the nation. So pretty good. And that's up against first, which is Utah. And Utah's done great work, but you also have to know, I think it's 60% of their population is Mormon. And for being a Mormon, you can't smoke. So they got that going for them. And at first glance, everything looks great, but I'm sure you're looking at this slide already. You're ahead of me, 2 to 3 times higher than the general population, again, for those with the behavioral health condition. So unfortunately, Stellar California ranks 41st in the US for screening in behavioral health community in the services, 32nd in providing cessation counseling, 40th in utilization of NRT, and 46th in the smoke-free campuses. So again, I'm very glad that you're doing what you're doing in LA County. You can be the poster child for the rest of the state. And here you can see a slice and dice of the facilities. So California facilities, mental health facilities, in all of these measures here, screening, tobacco cessation, nicotine, smoke-free campus, all of that are behind the nation. And I can tell you there are some southern states and some tobacco growing states that do better than California in this realm. These are the substance abuse facility treatment facilities compared to the nation, again, behind. Some of them are doing a better job at screening and providing cessation. So here comes the California Behavioral Health and Wellness Initiative. And believe it or not, this initiative was designed to help integrate cessation into services, behavioral health services, and help facilities go tobacco-free. But as you can see, the word tobacco is nowhere on this name. That was intent, right? Because we do realize that tobacco really should be a part of a wellness approach, a part of recovery. And we don't want to just have it be this prohibition, right? A rule when we're trying to change things. So that was intentional. And here's the goal. And this piece here, encourage development of wellness activities, policies to support a tobacco-free environment. Okay, so that's the piece there. There was a cohort activity where grants were given to agencies to encourage them to take steps to go tobacco-free and to strengthen their wellness policies for nutrition, gambling, and tobacco. And this, you can see the eligibility started at minimum 20 bed, later went to 15 bed. And that was because, it's difficult to find people who really want to do this, even if they're being paid to do it. But 18 months working with us. And these are the partners from the state. And I bring these up because keep in mind, we're trying to do the wellness approach. So we had Office of Problem Gambling, we had nutrition education, obesity prevention working together with us, evaluation team at UCSF, us as the intervention and the coaches, and the state for the funders. But these divisions, so NEOP and CalGETS, are in the counties that you are in. So they operate in LA County as well. And there's free services. I do encourage you to work with them. They're amazing. So the core aspects to this, and this can apply to you in your setting, is really working on the systems that exist, the promotions that exist, what is known. And here we are working with SAMHSA's 8 dimensions of wellness. All of these put together are, what makes somebody strong and healthy and, feeling good. When one of these things is off, the rest will be affected. So for example, if somebody smokes, it's going to affect all of these. If somebody quits, it's going to affect all of these. So these are very important. This is also the message that we're trying to get across. of course, quitting smoking benefits people, but it benefits all people. So even those with mental health and substance use disorders. And smoking can mess with mental health and complicate treatment, and quitting can improve that. And off to the left, that's one of our campaigns we put out during COVID, but it is providing that same message. And those of you who will be here, you're going to hear from Katie, who's the spokesperson. She's going to speak a little bit later on. We also promoted the quit line, and this is sort of as the last, it can be your first resort, it can be your last resort. But the point is, there's really no excuse to do nothing now because this does exist. And if you ask every patient, do they smoke at every encounter, and you refer them every single time, you're going to get something. It's going to start working. And again, we talked about this earlier. So just the importance of medications and integration into workflow. And then this last piece is really just understanding that the systems approach is really going to strengthen whatever policy you put into place, getting the whole care team integrating into workflow, having that clinician there when it comes to prescriptions on site if needed, implementing those screening tools. And really, if you've got it, leveraging your EHR system and creating like the click to quit or an e-referral to a quit line. And yeah, that's going to help you with enforcing your campus policies. So working together with this group, with these cohorts in the field, we were able to find individuals, leadership and staff that were interested in breaking through these barriers. How can we find those critical linkages between wellness and tobacco control that's going to help create sustainability? And we know what we know, but they also knew what they knew. And so it was really trying to come together, and I call it here the lunchroom, but at the same time, it's almost like a think tank, and working together and evolving and trying to come up with the right answers and being able to share them then with each other as well as the public. So a quarterly process, meeting and coming up with what are the achievements that you're proud of, as well as the challenges. And you can see here, everybody was kind of at a different continuum, starting off by taking their smoke shack and turning it into a Zen garden. A lot of gardening was helping to replace those smoke breaks, to people who were just, proud that they were staying afloat because of COVID. But all sorts of different stages, people already going tobacco free, getting their CEO to approve their draft policy, really starting to change their smoke breaks to wellness breaks, and starting to help individuals quit, and some of them even having staff quit. One of the big things that came away from this group was that, changing your smoke breaks, if you're starting to reduce them in order to finally go tobacco free, you have to have alternatives. And at first they're like, well, let's make them fresh air breaks and doing this and that. But then they started to realize that being outside actually was a trigger for smoking for many of them because they were so used to smoking outside. So they called them wellness breaks and made sure to have them outside as well as inside. And you can see these are some examples from the facilities we worked with. They, used some of the money to buy the ping pong table where everybody used to smoke. And again, gardening was really big. And then to the left, there was a hydroponics that everybody learned actually a skill, got to create those veggies, learn how to eat better. And all of these services were also in concert with the nutrition office. So we got all that for free. And here are some challenges that folks would come up with. And these are the facilities themselves. I think this is Grandview in LA. So ideas for, how can we do more fun things during quarantine? Again, they had some challenging times during COVID. But also, coming up with the book clubs, or how can we actually change that mindset that tobacco use is just like alcohol and other drugs, right? Or how can we work with this one person who is just ruining it for everybody who doesn't want to quit, whether it's a client or a staff member. So all these things came out and we all worked together to solve them. So here's one example. This is Progress House, and yes, went 100% tobacco free, put all of the gambling at intake, created the intake plans and treatment plans for smoking and gambling and nutrition. They had nutrition classes. You can see the stocked refrigerator of all the new fresh goods. They were able to change their menus, working with their own residents to do that. And keep in mind, these are all residential drug treatment facilities. They replaced all of those smoke breaks with, much of it was physical activity, doing outdoor therapy with their Zen walk. They created like this, I forgot, it's like a mirage, or not a mirage, a maze of sorts, and horseshoes, disc golf, baseball, gardening and outdoor activities really changed the mindset of their clients. And they again moved away from smoke breaks to wellness breaks. And you can see Cindy there, and she's the executive director, and how she was really overwhelmed at the beginning, but then was just so proud at the end, realizing this is betterment for all of their clients. They're helping them even more. So she's completely sold and really happy, and they're now doing it to all of their facilities. So not just talk, not just fluff. I want to make sure you knew there's a pretty hardcore evaluation. And spoiler alert, they did all go tobacco free and create all these nutrition policies and such. One of them was all ready, but the county actually said that they had to have one area to smoke, but they were able to do 100% vape free. So believe it or not, so hopefully they'll be able to change that. But here are the procedures for the evaluation: cross-sectional, staff data was email, client data, and then paper during COVID. You can see clients that were enrolled, staff that were employed. But the measures for clients: smoking status, client staff smoking together, receipt of cessation services, wellness behaviors, receipt of wellness services, and with staff smoking policies, beliefs and attitudes, and addressing and provision of wellness services. These are the measures that they went on. Here's the timeline. And this is just the first cohort. We've done 4, and they're in the process of collecting data for the rest. Some of them started earlier to go tobacco free right out the gate. And you can see here, which was kind of good because they were, leading the cause, and everybody's saying, wow, they already did it. But then at the same time, they were learning from that individual's mistakes, right? Oops, we went a little too early and we forgot to do this. And so others could improve in the process. And many of them went tobacco free around 10 to 12 months, and then were able to work with us in the following months. So here is client data. The policy, putting a tobacco policy in place, led to a reduction in smoking going from 54 to 26%, and an increase in NRT and pharmacotherapy from 11.9 to 25%. That's a pretty big deal. And then concurrent client staff smoking decreased from 28% to 16.7%. So this has actually not really been captured before, to show that once you put a policy in place, this can affect smoking. So that was a plus. And then with staff, it was associated with more implementation, like the sustainability of those tobacco-free grounds and buy-in, as well as more training and services to clients. And then with the wellness findings, there was an association with those who got that counseling for wellness behaviors were more likely to have lower sugary beverages consumption, more likely to have higher physical activity. And those who were smokers or had that higher physical activity were more likely to want to quit. So there is a direct correlation to that. So keep up those good wellness activities that can lead to good change. So here we are with some lessons learned that came out of this lovely think tank, trying to find that one person who might be a naysayer or who at least has respect of clients can really help get that buy-in early. Messaging and that timeline for going tobacco free needs to start early, well ahead of the actual implementation. Don't do this any more than 6 months. Give yourself at least 6 months to go tobacco free. We recommend probably even more, but don't go longer than 12. And then cessation, early. There's no reason why you can't start now, no matter what, but months in advance of a policy change. And procedures, you have to make sure that you've got your enforcement in there. So what do you do with a client who relapses? You want to consider it a relapse, or do you want to consider it a violation? And then the same thing with staff, but just being consistent and knowing that, you can be, you have to treat everybody a little differently. You don't want to have just like a black and white policy. Just make sure you pay attention to that. And then the systems change is really going to help if you've got that team working together to sustain that policy. And in general, changing that paradigm from viewing tobacco as this sort of secondary issue to really being a legitimate drug that needs, tobacco use disorder. Knowing that everybody's kind of in a different place. So making sure wherever you are in that process that you're addressing the needs. Familiar language, you don't have to start, you have to at least try and make those easy connections with the group and what you already know. So NRT, MAT, etc. And the skill set that a lot of you already have is going to be very helpful to helping somebody quit tobacco. And then that we found that staff in the behavioral health community are very interested in NRT, demonstrating how to use it, how to purchase it. Maybe this is because you're more used to this, but very, very interested in it. So give everybody credit for that. And the lens of overall wellness. So make sure that you're not just restricting and prohibiting, but really going after the wellness idea and having tobacco underneath that umbrella. Okay, so we're almost to the finish line here. So after this initiative went into place, this bill happened to pass, and we knew it was coming, and we were able to work with DHCS and really get this up and running. I'm really pleased to say, whether you're happy about it or not, that all licensed SUD facilities have to assess and treat for tobacco use. And this has just been starting to be enforced since July. So they're actually going out and visiting sites. And you can see the specifics here. You have to provide information regarding the effects of continued use of tobacco and its success and recovery, right? You just learned all about that today. And then you have to recommend treatment for tobacco use and have to have it in their treatment plan. And you can refer. So you can refer to the tobacco quit line. That counts. And we will be working with California SUD programs to help make this happen. So compliance, you have to complete and maintain this client health questionnaire. You can see the details there. You can, though, use a client health questionnaire that's been updated by the state. There's a template. I'll show it to you in just a second. But if you do not do any of this, there will be a citation. And they're serious about this. So, gosh, there were some changes I made here that aren't showing up. Anyway, if you look at number 47 here, that's the new updated template. So you can access this and you can get it through the slide presentation if you don't already have it. But that shows you what works. And so, yeah, so that's the change. That's what everybody has to do in the substance use facility. I hope you're already doing it anyway, and you're doing it in mental health facilities as well. These are some resources that I want to leave with you so that you know you're all set. And then you're going to hear from the other speakers that are going to help you even more. But you can get all of these from our website. We have a toolkit that will help take your facility tobacco-free, but also offers a lot of information on cessation services. It's done in a way that makes it very doable. It's not rocket science, people. We've got some 10 steps there that'll help you. There's resources in their templates, and to the right is an example of one of the pieces that's drug interactions with tobacco smoke, which I neglected to mention that, yes, so nicotine is not what is killing the individual. It's not the dangerous thing. It's the tobacco smoke and all of the toxins in there that cause cancer. So it's the nicotine that hooks people and the tobacco and the toxins in that smoke that harms people. And then in addition, tobacco smoke can actually interact with medications that individuals are taking. It messes with the metabolism. So they actually need more medication to be effective if they're a smoker. So when they quit, they need less medication to be effective. So one of the side bonuses of that is less side effects, right? But just keep in mind that there are drug interactions with tobacco smoke, and there's a list there. We have curricula that already exist you can have access to with free CEU and CME. In addition, we have a new comprehensive online training. We're partnering with the RX for Change crew that will have 5 free units. This probably will be set up by November. You can see here all the different units and the disciplines that we offer. And I'm sure some of you are on the line right now. Just want to make sure you realize that. You could go there today and start getting more units. And I do encourage you to take advantage of the existing resources. They put a lot of effort into these and understanding that they work. The messages are on task. You can see there's Rebecca noting that quitting smoking actually helped her depression, and the same thing with Katie, who you're going to hear from later. There's state activities, there's trainings coming. I think the next one is in spring, February. Free CME and CEUs. You can see just from that time that we worked in California, 5,742 folks were able to gain access to that. Follow us on Facebook, Twitter, sign up for the newsletter if you want to find out about these things. And this is one of the things we're so proud of. We're working with LA County, we're coming soon, hopefully, to have certified tobacco treatment specialist trainings. And this is for those of you who are super interested in just diving even deeper, being able to do it all yourself, right? and helping that individual quit smoking. And this will be designed to go with the National Certificate of Tobacco Treatment Practices, and that is in line with NADAC. Scholarship opportunities as well. So your takeaways, you saw this, I'm bringing it up again, but remember, quitting smoking benefits all. Your smoking actually exacerbates mental health symptoms and complicates treatment. Quitting smoking improves mental health and substance use disorder recovery outcomes. You can see there it supports behavioral health treatment. It can improve mental health, and it can make relapse less likely. And of course, it has immediate physical benefits. And what you can do, take advantage of those national campaigns. Please promote those facts and bust those myths. Please, please, please. Try and integrate cessation into your services. Try and adopt policies, smoke-free policies. There's no reason why you should be helping a client live longer, healthier life and allowing smoking, right? We got to keep that. You're a healthcare group. And refer your clients to cessation services, whether it's in the community or at the quit line. And please don't do it alone. And that last message down there, really remain empathetic and committed to helping all of those tobacco users quit. They're trying, believe in them. And finally, don't do it alone. Remember, we're here for you. Please contact us. And I will leave it there. Let's see.
Thank you, Catherine. So much great information, really good comments in the chat box. Some folks saying that they've already started to use the toolkit. But we do have a couple of questions, and we got a couple of minutes if you're okay with taking a couple. One of our first questions was, what impacts of smoking and using tobacco, I guess it's supposed to be, what are the impacts of smoking and using tobacco on mental health? Aspects of behavioral health or low social and economic groups of population. I think you kind of spoke to this, but if you want to do a quick.
Sure. So the impacts of smoking on mental health, because of the
low socioeconomic groups.
Mm-hmm. Yeah. Well, I mean, obviously the fact that individuals in that population smoke more, so that is definitely going to impact their health and obviously loss of life. But the bit about exacerbating the treatment, I would say, is maybe where they're going at. And just imagining that when somebody does take up smoking and, most likely from trauma or whatever it might be, it could be PTSD. Remember, adults with PTSD, they are, I think it's 45% of adults with PTSD smoke. So, it's the same kind of thing. But as they take that up, they're thinking that it's helping them feel better. And what it is doing is not only messing with the meds, right? As I just mentioned, the metabolism gets affected by the smoke, but it's also making them feel like maybe they're masking symptoms, but they're not. It's so short-lived that it has these individuals wanting to smoke more and more and more and more and more. And it eventually even marginalizes them. There is currently a stigma to people who smoke now in our community. So trying to recover and rehabilitate and get back into the community as a smoker is already, that's already making it even more difficult, let alone what it does to, their mind and their body. So hopefully that kind of answers your question.
Yes, thank you for that. And I don't know, I'll ask one more, and I think I have one maybe for clinician assistance. Someone asked, where could I get the updated health questionnaire form?
Well, on this slide, there'll be the slide deck that you'll get. There'll be a link on that actual template, and you can see it there. In the meantime, if I can find it for you, I'll give it to Norma. And so when she sends out materials or follow-up email, you'll have that as well. But it most likely will be on DHCS website. Well, we'll make sure that you get it and you don't have to go searching too far.
Okay, thanks. And then the last one here, a question regarding using SBIRT with youth. And one person responded that they don't use it with anyone under 18. But I'm wondering, is there a modification that's developed for use with youth, or is that general SBIRT okay to use with youth?
Yes, yeah, definitely. You can use it. Screening, brief intervention, referral to treatment. Why would you not want to, right? It's, I know you might think, what are we going to do for youth? But I don't know if you noticed, but even with the quit line, they do serve youth. So they are helping youth quit smoking. They are helping youth quit vaping. And there should be no reason why you wouldn't want to help those individuals. I think even, the idea of brief intervention is pretty much if you don't have time to do more. And everybody deserves that attention. And if it's 30 seconds or it's 30 minutes, you should always try and do something. So it works. Yeah, it's just understanding we care. We want to do something for you. We understand there's an issue here. You can go here and this person will help you.
Okay. All righty. We have one more. I don't know, again, it's for you or clinician, but how do you assist a client with PTSD when they're decompensating due to cravings?
Well, NRT is going to help. And any kind of medicines for, the 7 FDA approved medications to help somebody quit. And when you're working with clients, especially with PTSD, and say you're a therapist and you see them regularly, you're really going to have an advantage to helping them quit. So just keep that in mind, that it can be integrated into your treatment plans and bringing it back up every time you see them. And that's one thing that the VA really does recommend, is that integrated treatment. So yes, with the cravings, highly recommend something like varenicline, depending on where they are, or combined with the patch, but that will really help them. And just understanding that they are going through withdrawal, right? And just like with any drug, it can be significant. So the idea is, just like with medicated assisted treatment, is to replace what it is that they're missing in their body, but that won't harm them.
Right. And we're going to have a full discussion, presentation at 10:10 from Frank Vitale regarding pharmacotherapy and tobacco dependence treatment, so that you might be able to get more information at that time. But we are
I have a quick question. And again, Catherine, was a fantastic talk, very inspirational. A lot of emphasis on getting people to stop smoking, not much emphasis on getting people not to start in the first place, especially kids. You want to talk, spend about a minute on what we could do to prevent people from starting in the first place?
Yeah. Well, policies, right? And our state is doing a great job at that. And I think that, with the trauma piece, we have to be cognizant of that and understand that there is a risk factor for picking up smoking. So when you're dealing with youth that are faced with these things, keep that in mind and ask them if they're smoking, or ask them, think early and realize it can happen. There could be 12 years old and smoking. Oh, well, that, the different drugs that they all pick up. So as a clinician, bear in mind, trauma has a big effect, and understanding that they will be more at risk of smoking. So you got to be aware that that's coming down the pike. And then I think, in addition, these policies and showing as a healthcare group or wherever these teams are that, tobacco is not accepted because we know it's bad, or e-cigarettes are not accepted because you don't need to be addicted to anything at your age. So, then there's a great campaign coming out at the state. I think it's called undo.org. Lots of resources to help kids understand. If you want to get children involved early, there's Tobacco Free Kids campaign that has so many great resources for that. And in addition, even earlier in elementary school, the AAFP has a wonderful campaign. It's called Tar Wars. But the earlier you educate, the earlier they're going to realize this prevention. Add that with the policies in the community, add that with you as a clinician understanding that they could be at risk. And we're going to do great work on prevention.
Okay. Super.
Great. Thank you so much.
Again.
Great talk.
Go ahead, Dr. Friedman. You want to introduce our next esteemed speaker? Thanks, Catherine.
Okay. Our next speaker is Peter Selby, who's from the University of Ontario. Peter, is that right? And very prominent. Toronto. Right?
Yeah, Toronto and Ontario. That's right.
Right. And I read his New England Journal review on smoking cessation medicines about 2 months ago, which is what really inspired me. That was a fantastic article, which is why I recommended Norman to invite him. And very distinguished expert in the field of smoking cessation. Go ahead, Dr. Selby.
Well, thank you very much. And again, thank you to for inviting me, and thank you to Norma for making sure we got everything done and hosting us so well. I wish I could have been out in California with you in person because it's beginning to get cold over here in Toronto. But what I'll do is, I know I have a short period of time with you, so my slides will be available to you. Feel free to keep typing your questions into the chat as we go along. I welcome that. And I'm going to now see if I can share my screen and see if it works. So let's try. Let me know if you can see my slides. And are you seeing my slides? Are you seeing my
Yes.
Yeah, it looks
Okay.
great.
It looks great. Okay. So really, I work at a academic health sciences center, or a hospital that is affiliated with the University of Toronto. It's a mental health and addiction facility. It has 500 beds, but also ambulatory setting. And my clinic is focused on nicotine dependence. It's part of the addictions program, and it focuses on treating people with severe nicotine use disorder. But we also have a scale-up program into the province that happens in primary agencies and other ambulatory settings. And we also have a large training program which is focused on tobacco addiction treatment with equity-deserving populations, as well as dealing with people, especially people with other co-occurring mental illness and substance use disorders. So without further ado, I'm going to move forward. That's just me. Disclosures that are relevant to this, one is important to know that I take no tobacco, vaping, alcohol, or food industry funding. I run this large program for smoking cessation where we provide 26 weeks of free nicotine replacement to anybody trying to quit smoking. And so we buy our medications from Johnson & Johnson and Novartis at open competitive bid, and then we distribute this. And in the past, we have had a grant from Pfizer, which is the manufacturer of Varenicline. So those are the only potential relevant. And I hope today through my talk, you will see that hopefully you don't perceive any bias in what I'm going to talk to you about. So one of the things that we do in Canada at CAMH is that we are in a process of what's known as following the Truth and Reconciliation recommendations in our country with our indigenous, with not our indigenous, but with the indigenous people who lived here and were the stewards of the land prior to the settling. And as an immigrant settler to this land, one of the things is we acknowledge where we come and how we occupy this land. And so my hospital is situated on lands that have been occupied by First Nations for millennia. They are rich in civilizations with knowledge of medicine, architecture, technology, and extensive trade routes throughout the Americas. And where we were, it was part of the British Crown as the Councils of the Mississaugas of the New Credit. And where we are is now covered by a treaty, number 13, with the Mississaugas of Credit. And we have a large number of Indigenous individuals who continue to enrich our city, and I work with them. And as a commitment to reconciliation, we honor the land, programs, places that reflect and respect people's heritage. And we also embrace the healing traditions of their ancestors and weave them into our caring practices. So, for example, in our addictions program, that is if somebody so chooses, they can have an elder or traditional ceremony as part of their healing process. And we are in the process of improving and building new relationships in our First Nations, Inuit, Métis, and we share the land and protect it for future generations. And that is our commitment as we work through the reconciliation process. And tobacco is an extremely important thing for many of our Indigenous nations and communities. And so we work with them to restore traditional use of tobacco, which is not the same as commercial tobacco that we sell as cigarettes. And we have a toolkit that has been created for free that in keeping with traditional values and cultures that can be used by anyone when working with Indigenous people to be adapted with them. So thank you for that, and thank you for indulging me on that. But it's extremely part of the work that we do is in a process of reconciliation, and we use the same kinds of approaches to our people who are using substances and are also equity deserving in the way we treat them and help them recover. So what I'm going to talk about is three things. We're going to talk about how I've taken my training in addiction medicine and helping people with other substance use disorder and bringing that approach to the treatment of tobacco use disorder, which otherwise often comes from a public health approach, which is a very directive approach to people of how they should get better, and moving into a much more recovery-oriented approach to help people understand how they can actually quit smoking. And we're going to pay attention to those risk factors that help them get better and those that come in the way of them getting better. And of course, design a plan that can be integrated into their other substance use and mental health disorders. So what is the milestone approach with tobacco cessation? It's no different. If you've treated other addictions, you know it takes a day at a time to get better. But with smoking, one of the things was, the typical way was you told people to quit, and then they would just have to quit. And then, you'd offer them some sort of group or 12 weeks of treatment, and you just waited for them to quit, as opposed to helping them achieve milestones along the way. And as you know, when somebody is trying to quit multiple things like other substances or dealing with other stressors, smoking often falls down to be the last thing that they want to address. And so helping them integrate that as part of their recovery process is critical, and breaking it down into milestones we find helps them sort of make it into doable, achievable chunks. And certainly this helps with the idea of self-efficacy, which is a key determinant in any health behavior change. So helping people succeed builds confidence. Building confidence helps them succeed more. And you'll see that how it plays out. Here's something that is always compelling to us, that why people is that if we've helped 2 smoking patients quit, we have saved 1 life from a tobacco-related illness. And I think that's a compelling reason as to why we in the behavioral health or substance use field need to pay attention to this, because most of our patients will die from their tobacco. Just so that you know, we do talk about measures of how we are measuring it, and we're talking about where people are at in quitting. And when we ask them, have they quit, is it for 7 days? Are you talking about never having taken a puff, or for a month or so? Or are you talking about not having smoked for 6 months or a year? But the good thing is that these measures are all correlated. So you measure that, have you been able to quit for 1 day? That predicts quitting for 7 days, that predicts 30 days, and that predicts 6 months. So I'm just going to go quickly. So what I thought was, when patients were coming in, I started treating people with opioid use disorder and pregnant women with opioid use disorder. And then in about 2000, started focusing much more on a bigger addiction, which is tobacco, because I could help all my pregnant, opioid using moms quit opiates, but I couldn't help them quit smoking, which was a big determinant of the outcome for them and their child. So I really started focusing on smoking. And when I started working on this, I found it really difficult, because I said, we gave them a single treatment and maybe a bit of counseling here, and then they would do it. And I'm saying, wait a second, if this is an addiction, why are we treating it that way? So we broke it down, and over time, this has been starting to come into the way we work, is that if we can help people complete the various milestones, from pre-cessation to that 1 day where they don't smoke, to a week without smoking, to a month without smoking, to a quarter without smoking, helping them get to these milestones may help them stay, becoming former smokers. And so if you can get people to go for that 100 days, and you're essentially reducing the risk of relapse down to 5%. And this is shown by multiple studies. And interestingly, this is both for tobacco and alcohol, that you'll see that most of the relapse occurs in the first week of trying to quit, but it tends to stabilize by about 100 days. And so if we can help people get to that 100 days and stay quit, that is the key. And so our program is designed to get people to that that time, and understanding that not everybody is able to get to that 100 days all at once. So what comes in the way and what helps people get to this? So obviously, milestone one is the pre-cessation, where people are not ready, willing, or able to quit. And the evidence suggests, obviously, motivational interviewing does have evidence to do that. And shorter sessions are also better than brief advice. So, less than 20 minutes. So again, this is something that can be scaled to busy clinicians who are not experts and with training, and they can do that. And of course, longer sessions can be beneficial, but sometimes you get, the laws of diminishing return in there, because so efficient motivation interviewing can go a long way in helping people do that. And most people in substance use treatment are familiar and know and have skills in motivation interviewing. So it's what you've learned applied to this. And there's obviously single session to multiple sessions and follow-up. So I'm not going to bore you with this, but just to suggest that when people who are trained and know how to do motivation interviewing use those skill sets that you use people to motivate other behaviors, help them can also work for quitting smoking. So one of the things that we found with many people coming to quit smoking, they often come as a success fail kind of mindset. This idea, either I'm quitting or I haven't quit, or I'm smoking. And what we've got them to think about is quitting as a process, not an event. And start introducing the milestones one step at a time. What is the first milestone? And understand that people achieve these milestones at different rates. We have people who are not even willing, can't go a few hours without smoking. So for them, we are starting to help them just stretch that time till they meet that first milestone, which is 24 hours without a single cigarette. And doing that voluntarily counts as a quit attempt. And we have, and it's been shown actually, the greater number of people who make a quit attempt overall at a population level, you get actually lower prevalence. And so that comes out of work actually out of California that suggests that if you get more and more people to make quit attempts, you actually end up reducing that. But while people are ambivalent, we are always paying attention to the biological and social determinants of health that are making that person desire smoking, interfering with their ability to smoke, giving them reasons to continue, and giving them this dependence on it where they feel a need to smoke. So this comes from motivation interviewing. And we are working in these 4 domains to get them to shift that ambivalence and move towards where they desire to quit, they increase their ability to quit, they have more reasons to quit, and they need to quit, and they realize that. So that's that first pre-cessation work to get them to that quit date. You can also use pharmacotherapy, and pharmacotherapy does interfere, for example, with the satisfaction of smoking, and it can be started up to a month before. And behaviorally, you'll see a reduction in the number of cigarettes smoked per day. And so you can see that using nicotine replacement prior to the quit attempt, and of course, this might be off-label in your country, but it's kind of silent here in Canada, we can use it. And what that does is it does show that it might make a small difference, but it doesn't actually hinder, abstinence. And so we will give people the choice. There's no difference whether you started before or after, but clinically, I can tell you many patients find this reduced to quit a lot easier on their ability to quit. So we use both. If they're ready to set a final quit date and have no more cigarettes and commit to not take a single puff, absolutely. But for most patients, it means doing gradual reduction to quit. Clearly, we find that the patch, this passive exposure to nicotine, makes it a lot better than giving them as needed nicotine with a gum or lozenge. But that again, in the science, is not backing up one better than the other. So we typically give it 2 weeks prior to quit date with obviously varenicline, which is the oral form of medication, which is a partial agonist. So if you're familiar with OAT, you have methadone, which is the full agonist, and we have buprenorphine, which is the partial agonist. Varenicline is your partial agonist for nicotine. So, and it's oral, you can take it by mouth. So it's a pretty easy way to take it. And so, but 4 weeks before the quit date increases 12 weeks of abstinence. So compared to placebo. So people can take these medications prior to their quit date. And again, mitigation strategies for those who don't respond to those policy options. So let's say you make, cigarettes really expensive, but now for poor people, some of them will quit, but those who can't quit will end up compensating and using their money that they would use for food for cigarettes. But what about making medication available to them, or quit lines, or whatever, or quit programs? So I think governments have a role in making sure services are available, especially when they put in policies. And then of course, so it all works in concert, right? It works together, like trying to help people quit when you have smoking allowed on an addiction inpatient treatment makes it hard. Or if you have staff that are smoking at the same time as with the clients, those kinds of things are problematic. So clearly governments can make sure that accreditation and those kinds of things, or accrediting bodies can make sure that policies, big P policies, small P policies, all affect what we consume, where we consume, and how often we consume, and what potency we consume, and therefore what harm we get or what benefit we get. Yeah, and thank you, Shmil, for your name. I think hopefully I pronounced your name correctly, Shmil. Okay.
Someone's asking about a website.
Yeah, so my website is called nicotinedependenceclinic.com. At CAMH, you'll see the whole range of how we put this together, our program, as well as there's a lot of free self-study programs there. And you can, if you're interested, you can even apply to join our listserv as well, and get that. And I don't know if you have for time, but the weight gain question is extremely important. So weight gain is, so most people coming to quit smoking right now already tend to be overweight, and it is a barrier because there's a perceived benefit from smoking because it kills appetite. And so we talk about first of all, where does their weight and come into the picture, and clearly we work with them on how to that help educate them that when you quit any substance, your body will now crave sugar, and sugar is something that will mitigate acute withdrawal partially for all substances. And they're looking for that stimulation from sugar. So we help them understand that and help them create sugar-free options for that piece. But also, nicotine is an anorexin, so there is an increase in appetite, and as well as, so we help them understand that and figure out how to compensate with more physical activity and better diet. Now, having said that, in women specifically, combining nicotine replacement with naltrexone can mitigate weight gain. All the medications used for quitting smoking, when people are on it, especially bupropion, the weight gain is the least. So certainly that is a possibility. And the other medications that are there is fluoxetine has shown. There's been a like a review looking at these various medications, and that can help with weight gain. But more and more, the field of overweight and obesity is looking at a group of medications called GLP-1 receptor agonists. And we are also beginning to explore that, especially in our patients with schizophrenia who go on to antipsychotics. They gain a lot of weight, they're smoking, they're sitting ducks for heart attacks and diabetes. And we are beginning to use these medications in them to manage that weight gain as well. So hopefully that's helpful to you. And I will put my website.
And also to add, exercise would be a crucial component.
Absolutely, yeah.
It helps with the cessation, it helps with the weight loss.
Absolutely. But one of the things we do find, that actually we've introduced an exercise program in our smoking cessation clinic, but because we are working with the people with a lot of issues, we actually have had to make it into a movement to be inclusive. So because some people come on scooters or wheelchairs or are unable to move. So we start with where they are, and it might be chair yoga, it may be as simple as that to get people going. And so we make sure that they're, that we get them moving and use that as a way to motivate movement when they leave the clinic. But we are seeing that, I mean, maybe my population is very skewed. So, but if people are not, most of our patient populations are not willing or able or have the means to join a gym. So we try to, we try to work with where they are. But you're absolutely right, Dr.
Thank you again, Dr. Selby. So many comments about people receive, me too, new information today, and that's what these trainings are all about. So we really appreciate you taking time out of your schedule to join us.
Yeah, my pleasure. Thanks for having me.
Thank you.
All right. Have a good one. Have a great rest of conference. And thank you for doing this work, everybody.
Thank you so much. Great
Thanks.
job.
Bye for now.
Okay.
Bye.
Yeah, it's time for a little short break, and we're supposed to come back at 10:10. If we could do that, we can get right back on schedule. We're a little bit behind our schedule. So we're going to keep this open. So if you need to just take a bio break, get some water, refresh the caffeine or something, we'll be here when you get back.
Talk to you later.
All right, we're 10:10. We're gonna stay on schedule. We're honored to have Mr. Frank Vitale to join us, who is the National Director of Pharmacy Partnership and Tobacco Cessation. He's been in the smoking cessation field since 1987, so longer than a number of you who are in this world. So we can believe he knows what he's talking about, and we're just excited to have you here. Mr. Vitale, you can take it away.
Are you going to put the slides up?
A lot of people wanted to run their own, so I thought you were one. Hold on, I can pull it up. Just 1 second.
Yeah, I usually, you can give me permission to run them.
Sure, I could do that.
Sorry,
One quick minute. Slides. Slideshow. Okay. And permission. You co-host, can you try to share?
okay, you want me to share my screen then?
Yes, or yeah, so that you can run it yourself.
Okay, there it is. All right,
There we go. Coming up. Yes.
you can see that okay?
Yes, we can. Thank you.
All righty. There we go. Sorry about that.
No problem. We're in a
Still
tech
not used to all
life.
this. After all these years, I'm still not, I mean, the last 2 years, I'm still not used to all this technology. Anyways.
I can say
Thank
raise
you.
your hand if you're sure. Yeah.
Thank you, Norma and Catherine, for inviting me to do this. As Norma said, my name is Frank Vitale. I am in sunny Pittsburgh right now, where it's a beautiful 60 degrees and the sun is shining. I'm assuming most of you are in California. Hopefully the sun is shining there too. So I've been asked to present on the medications that are approved for cessation. Usually this topic takes about 2 hours to cover. So I only have about 50 minutes. I'm not going to be able to go into a lot of detail about dosing and instructions and all that stuff. So what I've given Norma and the group is a handout that has all of the usage instructions, dosing, indications, contraindications, all that kind of stuff on it. Most of it is pretty clear cut and straightforward that you can see for yourself. Rather, what I'm going to do is try to go through some particulars about each one of these medications that I've encountered from, as Norma said, I've been doing this for 38 years now. So over all these years, some of the ins and outs that I've discovered and peculiarities and of using these products. So let's just jump into this. These are the objectives. You can look at that yourself. All right, so I've always used this paradigm as in doing smoking cessation counseling, and that is there are 2 parts to smoking, so there are 2 parts to quitting. Smoking is both a physical addiction to nicotine, and it truly is an addiction for 99% of the people who smoke, and it's also a behavior. It's a habit. And so in order to quit successfully, we know from the clinical practice guideline, which is a meta-analysis of over 8,000 research studies, that you need to deal with both of these aspects simultaneously. So what we're talking about here is getting into some kind of behavior change program, whether that is a individual counseling group, calling the quit line, using one of the programs that come with the medications, whatever it is, but dealing with the behavioral aspect of this while you're using a medication. So in this case, as opposed to many other medications, these meds do not cure you of smoking. What they do is something very important, but they don't actually stop you. You have to do that yourself by making the changes in behavior. And I'll go over exactly what they do in a second. So in this talk today, we only have time to go over the medication side, but I can't emphasize it enough. You need to join that with a behavior change program of some sort or another. Now, these clinical practice guideline, which is down in the corner there, and I would advise you all to get a copy of this if you can. It's the Bible, so to speak, of cessation. It indicates that everybody except these couple populations can use these medications. And these populations, and again, I don't have time to go into it, are not included in the guidelines simply because there have not been enough studies to include them. It's not that you can't use them with these populations. It's just the data is inconclusive. So I know many of you work with behavior health individuals, people with psychiatric and substance abuse issues. Note that this does not exclude that population from using these products. They can use all the products that I'm going to mention, especially the nicotine replacement products. So 5 of the medications are simply giving the patient nicotine in a different form. So remember this, they already have nicotine in their body from smoking. We're just giving it to them in a different way that is easier and more comfortable to stop. We know that using one of these medications alone doubles quit rates. And if you use them in combination, which we will be talking about toward the end of the talk, they can quadruple a person's chances of quitting successfully. So these are the 7 FDA approved products. This is all that the FDA has approved over the years. The first 5 are nicotine replacement: the patch, the gum, the lozenge, an oral inhaler, and a nasal inhaler. The first 3 are over the counter. The next 4 are prescription only. The other 2, besides the nicotine replacement products, are bupropion, which you all probably know as Wellbutrin, and varenicline, which is marketed under the name of Chantix, which is a medication in its own category. So what do these meds do? Why should you use them? Well, number one, they prevent withdrawal. And again, without getting into a lot of detail, many people who smoke go through significant withdrawal when they quit, so much so that it distracts them from really being able to focus on the behavior changes they need to do in order to stay quit. So this gives them just enough nicotine to prevent withdrawal and to help them feel comfortable. It also, and as important, eliminates the reinforcing effect of taking in nicotine through the lungs. So when you smoke, the nicotine hits your brain in 11 seconds. It's like this huge wham. And because there's so much of it and because it's so fast, it's very, very reinforcing. However, nicotine chemically has a very short half-life. So within 45 minutes, half hour, for most people, they're in withdrawal. So in order to get rid of it, they smoke. So all day long, the person's going up and down, up and down, up and down. And they're doing this behavior to prevent the withdrawal, but also to get the hit. They like that hit, that peak when it hits the brain, because it releases neurotransmitters, primarily dopamine, but also serotonin, epinephrine, norepinephrine, all those chemicals that make you feel good. So all the nicotine replacement therapies give you a lower amount at a slower rate so that you do not become physically addicted to these products. So remember those 2 words. It's good to use these products because they're lower and slower. So it eliminates the reinforcing effect and also keeps you out of withdrawal. So then you can comfortably look at breaking all of the habits around smoking that you need to work on. So that's a very, 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 very brief explanation of why these products are appropriate and good to use with your individuals who smoke. Now, the rest of the talk, I'm going to just go over each one of these products very quickly. Again, I'm not going to go over all kinds of dosing. You can look at that on the handout that I've given you. We'll start with the patch because that's been around pretty much the longest. It's the easiest to use. It looks like a big Band-Aid. It's in 3 steps, and you pretty much just take it off, put it on your skin. It's a transdermal delivery system, and forget about it. So this product is very good for people who tell you they don't want to have to think about quitting. They just want something easy to use that's discreet and is not, not a lot involved. You pretty much just put it on a dry, clean, hairless place. And that's really important because on a lot of men, they have a lot of hair all over their bodies. So you have to kind of, in some guys, really find a place to put this, because if you put it where there's a lot of hair, it's not going to completely adhere to the body. So you're not going to get the full dose. But when you go to take it off, it's really going to hurt because you're going to pull out all that hair. So, you can put it up here on your neck, up on the upper chest, pretty much anywhere on the upper body where there's no hair. And you need to rotate the site every day, because if you keep putting it in the same place, you're going to get a lot of skin irritation. Many people, the adhesive can irritate the skin, so it's important to do that. The side effects are minimal here. Mostly it's skin irritation from putting it in the same place. So again, you can mitigate that by rotating the sites and putting cortisone cream or Corday cream or something on if you get a little bit of an itch. The other interesting one is vivid dreams. Now, if you wear this, and you're supposed to wear it for 24 hours, you get nicotine all night long, obviously. And for many people, that stimulates the dream center in the brain, and they have very colorful, active, interesting dreams. Now, a lot of people like those dreams, so this isn't necessarily a problem. What you want to do is ask the person, are the dreams bothering you? Are they keeping you awake? If they say no, then don't do anything. If they say yes, then instruct them to take the patch off when they go to bed and put a new one on in the morning. So the research clearly shows that wearing this while you're awake is just as effective as wearing it all night long, because think about it, most people don't smoke while they're sleeping. However, the reason you're going to wear it for 24 hours is most people have the very lowest amount of nicotine in their body when they wake up, so they have very strong withdrawal. And we'll talk about a way to deal with that in a moment, if you're only going to wear this for the while you're awake. All right, again, I'm just briefly going to go through each one of these. That's the quick down and dirty version of the patch. I recommend this for people, as I said, who don't want to think about quitting and just want something easy to use once a day. On the other hand, if you have somebody that tells you, I want to be actively involved in my therapy, I really want to do something that shows that I am quitting, and I need to be able to be engaged with my quit. The gum or the lozenge are the perfect products. These are both oral products. The gum looks like a big chiclet. It is a resin-based, and it just basically has nicotine in it, other than and some flavoring if you get those. They come in 2 and 4 milligram. The dosing is based on time to first cigarette in the morning. So again, you can look at that yourself. This is the schedule. Essentially, you want to use 1 piece every hour on the hour, because unlike the patch, which passively gives you a nice steady amount of nicotine all day long, you have to dose yourself, give yourself that nice steady amount of nicotine all day long with the gum and the lozenge. So you need to really do a piece every hour in order to do that. Now, I do want to spend a minute or two talking about this. The problem with this product, I like it a lot. I was involved in a lot of the initial research with this when it went over the counter, is the fact that it's called gum. Because it's called gum, people tend to chew this like chewing gum. And if you do that, all the nicotine is going to go into your stomach. If that happens, guess what? It's pretty much useless, because your stomach is acid, nicotine is base. If you think back to chemistry class, when acid and base get together, it's neutralized. So it has really no effect. What you have to do with this is what's indicated on this slide. You just bite down on it, you activate it by biting down on it 6, 7, 8, 10, 12 times, whatever you need to get that tingly, peppery taste. That's the nicotine. As soon as that happens, you park it between your cheek and your gum and let it be buccally absorbed. The only place the nicotine can effectively get into your system internally, other than your lungs, is through this buccal membrane in your mouth. So the whole key to this is to leave it alone in that spot so that all the nicotine on that surface that's exposed can leach into the system. Once that taste, once that tingling disappears, and for most people it's a minute or two, then all the nicotine's been absorbed. So you bite down on it again, 3, 4, 5 times until you expose a bunch of new surfaces and then move it to a new spot. Because this spot has been saturated with nicotine, it's not going to really absorb too much more. So you have to move it to another spot. So the whole thing here is this chew, park method. Now, this is a pain in the butt for many, many people. They just won't do this. It's too difficult. It takes too much time. However, there are many people who like this because it kind of mimics the behavior of smoking, because as I said, they're doing it about once an hour and you have to move it around and think about it. So this is really good for people, as I said, who want to actively participate in their quit. And I'm not being funny here, this is good for people who have boring jobs. So if you're sitting in front of a computer all day, or you're a night watchman, or a truck driver, this takes a lot of work. So it eats up time, keeps you from thinking about wanting a cigarette. So I recommend this for that population. This is also good, and I would just got in on the tail end of the prior speaker. He was talking about weight gain. Behaviorally, because you are having this in your mouth technically every 30 minutes of every hour, and you're not supposed to eat or drink anything while this is in your mouth, this can slow down or mitigate weight gain because you're not snacking as much because of the behavioral aspect of this. So if you are recommending that anybody use this product, please take time to go over this with them. Make sure they're using it correctly. If you don't have the time to do that, please refer them to a pharmacist so that they can do this. This, out of all these products, really needs to have a lot of counseling. The good thing about this is that you can respond to individual urges that might pop up in between pieces. So it's fine to use extra pieces during the day. After doing this all these years and years and years, the problem with this, I've never seen anybody use too much of it. Everybody uses too little of it. They try to use as little as possible, and therein lies another problem. So really, really, really inform these people, really focus on the fact that you need to use this consistently through the day and generally about 1 piece an hour. There are no contraindications to this other than if you have TMJ, simply because this is it's very viscous and it's very hard. So it might irritate your jaw. Other than that, a lot of adults now have braces. They're straightening their teeth at an older age. So I wouldn't use this if you had braces because it gets caught up in there and can just be a pain in the neck. So if somebody wants to use an oral product and they can't use this correctly, or they're not allowed to chew gum, then they can use a lozenge. And this looks like Tums. And then there's a little version that looks like Tic Tac. Again, same thing. It's just has nicotine in it with some flavors. But what's nice about this is that you simply pop it in. Again, same dosing schedule. Just pop it in between your cheek and your gum and just suck on it. So most people can use this correctly, whereas the gum, as I just indicated, there's a lot of issue with many people not chewing it properly. So if you have somebody that wants to use something oral, and again, for both of these products, these are good for people who tell you they miss the oral gratification of smoking. If you look at somebody who smokes about a pack a day, and the average amount of puffs on a cigarette maybe are 10, 15, 20 puffs a day, they're literally putting something in their mouth maybe 500, 600 times a day. So many people miss that oral fix they get from smoking. So this and the gum are good products for those individuals. Again, you just pretty much let this dissolve. Takes about 20 minutes and bing, bang, boom, you're done. So I like this product a lot simply because it's a lot easier to use. Now, when the products originally came out, there were all kinds of restrictions on it. And then in January of 2014, the FDA allowed the manufacturers to put these extensions on without doing a bunch of extra research. So the three things you can do with NRT here, especially these over-the-counter products, is you can start them prior to quit day. So you kind of can rehearse. So if you have someone that's scared of the quitting or afraid these products aren't going to work, they can literally do a test day just to see how it works. Or with the gum or the lozenge, they can smoke a cigarette at noon, at 1 o'clock, use a piece of gum, at 2 o'clock, have a cigarette. So there are many ways to fool around with this. Trust me, it's very, very difficult for anybody who's a regular smoker to get too much nicotine. So there isn't any problem with mixing these prior to the quit day. If somebody has a slip, so in other words, if they're on these products and they have 1 or 2 cigarettes in a certain situation, advise them to continue to use the product. There is no reason to stop any of them because of that. And then you can use these products as long as you need to. I have many individuals that I've worked with who are just scared to death of stopping nicotine altogether. So, you can use these for 6 months, a year. Now, I don't recommend that, and I'm not saying that you should recommend that, but it's not going to hurt anybody. I'd much rather somebody use a few pieces of gum here and there. Like my understanding is one of our former presidents is still on Nicorette gum, even though he's been out of the White House for many, many years. Again, the smoking is what's going to hurt them. It's all those chemicals that are in tobacco that cause all the medical problems, not nicotine. Nicotine's the addictive drug, but it's not the substance that causes all the issues that happen because of smoking. So they can stay on it as long as they need. Again, not recommending that, but the reality is some people just need to be on it longer. These are the precautions. And again, as I indicated at the beginning here, you can use this with almost any population other than individuals here who are experiencing some kind of major cardiac issues. But again, just refer them to their cardiologist. And I'll show you in a second, the American College of Cardiology came out with a white paper years ago that pretty much said, unless the person is having a heart attack right in front of you, you can use these products. So, these are just precautions, not contraindications. Pregnancy is on there simply because, we're cautious about pregnant women using any kind of medication. So again, from your perspective, unless you're an OBGYN, refer them back to their OBGYN and they will help them work with these medications. I've used them with pregnant women and have had no problem, and I have no problem recommending them. But again, you have to be a little cautious here. And then these are some of the studies to support this. Again, you can look at this on your own, but pretty much the heart conditions and the issues around smoking and heart disease come from the fact that they are not getting sufficient oxygen because of the increased carbon monoxide that's produced from the burning of the tobacco, not from nicotine. So these are perfectly safe products to use in that population. So those are the 3 over-the-counter ones. We have 2 oral. We have an oral inhaler with nicotine in it and a nasal inhaler. Just going to briefly go over these because they're not used very much. This one, as you can see, kind of looks like a fake cigarette. It has a cartridge that has the nicotine in a sponge. You put it in there. You can see that line where the mouthpiece comes off. And you put it in there. It cracks the seal. And then you puff on this much like you would a pipe. Unfortunately, this is a good product. I'm not quite sure why it has never taken off, but it hasn't. So I do know why this one hasn't taken off. I do know what the problem is here with the nasal spray. The nasal spray looks like a looks like Flonase. I'm trying to think of, I use it every morning and I can't think of the name of it. You know, it's the same as any kind of allergy medication that is out there in the spray. It's an aqueous solution. Now, I don't know of any clinician that is using this because of this fact. As you know, with any kind of medication, you have to do double-blind, placebo-based studies to get a medication approved. In that case, and in all cases, you have to, the placebo has to have the same effect as the medication so that nobody knows who has what. Well, guess what the placebo is for that they used in this study? And think about it. What do you think spraying nicotine up your nose feels like? Well, they used pepper spray. Yep, I'm not exaggerating. So this hurts a lot. It's very problematic and causes people to cough and sneeze and get headaches. And so again, in all my years of working with this, I've never recommended this for anybody, and I really don't know why this is still on the market because it is not used by most of my clinician friends. All right, so those are the nicotine replacement products. That leaves us with two other medications that we have here, bupropion and varenicline. Bupropion is Wellbutrin. Okay, it's exactly the same thing that is used for depression. It was called Zyban. So many, many years ago, I guess probably like 20 years ago at this point, a doctor out at Loma Linda VA Hospital was using Wellbutrin with her veteran population, and most of whom smoked. And she noticed one day that, you know, most of the people that were taking Wellbutrin for depression had stopped smoking kind of spontaneously. So what they discovered when they did research after this was that amongst all the antidepressants out there, Wellbutrin increases dopamine levels. So it has the same mechanism in the brain as nicotine does without becoming addicting, and therefore allowed people to quit. So they manufactured this, came out as Zyban, and it was wildly popular. Many, many, many people used it. And then like so many other things, it just kind of disappeared. And the sales dropped so much that GlaxoSmithKline just stopped making Zyban. So it doesn't exist anymore. It is now just generic bupropion or generic Wellbutrin. This you start like varenicline before you quit. So that was one thing a lot of people liked. You start this a week or so beforehand to build up a therapeutic blood level. The other thing that people liked about this is it's a pill. So you only need to take it a couple times a day. It's very easy to use. You don't have to think about it. So that's why it was very popular. And from a clinician point of view, you could kind of kill two birds with one stone by having treating the depression and helping them quit smoking at the same time. Now, there are a lot of side effects from this, especially the insomnia and the agitation. And so that's part of the reason why this kind of went out of favor. But primarily, it's the contraindications. This lowers seizure threshold, so anybody with any kind of seizure disorder, with any of these other issues here, could not take this. So clinicians started to shy away from it, but this is the real reason why it kind of fell out of favor, is varenicline showed up. So varenicline is a nicotine receptor agonist. It is in a class all by itself, and it was the last product that was approved for cessation, up till now. So you can see it's been a long time since anything new has happened. So what this does is it fools the brain into thinking that nicotine is there, so there is no withdrawal. But interestingly enough, it creates a barrier in the brain that prevents the nicotine molecule from getting to the receptor sites. So this is great for people who have tried before and have relapsed a lot, because if you're taking this medication, for the most part, when you smoke a cigarette, there's no effect, there's no hit. There's no pleasure from smoking. So there's really what happens is if somebody's on this and they smoke, they kind of, okay, what's the point? I'm not getting anything out of it. So this was really good for the that population and just in general for anybody wanting to quit. So we saw a huge uptake in this. Again, this is the dosing, et cetera. Here's some added information in it. The big issue with this was insomnia and nausea. I'm sorry. And the nausea is caused because people were not using the product correctly. So you really want to make sure that they eat, take this after a meal and with a full glass of water. Now, in probably 8 or 9 years ago, all of a sudden we started getting a lot of reports of people who were on varenicline who were saying they were having delusional ideations and odd thoughts and just all kinds of neuropsychiatric problems. So the FDA decided to put a black box warning on the product stating that if you were treating someone with any kind of psychiatric problems, to use this with extreme care. And because bupropion was kind of in, they considered it kind of in the same category, they put the black box warning on that. However, in a very good move, they said, well, we're not really sure what is causing these neuropsychiatric issues and why so many people are reporting them, et cetera, so let's do a study. So they funded this very, very large study, and anybody who does research can see that this was a unusually large cohort. So what they did was they got over 8,000 participants, half of whom had known psychiatric disorders. And what they were looking at is, did this medication actually increase the report of severe or moderate to severe psychiatric issues. So they had 140 centers, so this was all over the world, and they had 4 arms: people on varenicline, people on bupropion, people having the nicotine patch, and people in placebo. They did counseling with this, again, extensive study, very, very well done. And this was the result. They discovered that the incidence of moderate to severe neuropsychiatric adverse events was essentially exactly the same for all 4 arms. There was no difference in the statistically difference in the reported events. So it wasn't varenicline, it wasn't bupropion. So what was the cause of all these problems? Well, many of my colleagues and I had thought this from the beginning. What these people were reporting was withdrawal from nicotine, not anything to do with any kind of medication they were taking. So the upshot here is that these medications can be used in psychiatric populations. There is absolutely no problem with that. And the other interesting finding from this study is that we now, for the first time, had head-to-head study amongst the medications, and we discovered that clearly varenicline does produce the highest quit rates. So we can now very clearly say that varenicline is probably better than any of these other. So the takeaway for you, especially if you're in the psychiatric substance abuse arena, is that this study very clearly shows that you can use this medication. However, I do recommend, as I do with everybody, that you follow people closely for the first couple of weeks after they quit, just to make sure there are no other issues. Now, the standard for treatment amongst all my colleagues right now is combination therapy. So what we're talking about here is using 2 or more of these products at the same time. Essentially, that is using the patch, which is I say kind of gets rid of the underlying withdrawal, all the general withdrawal, and then adding on the gum, the lozenge, the inhaler, or the nasal spray, PRN. So here you can use these products PRN, whereas if you use them as monotherapy, you want to use them steadily through the day. You want to use these short-acting formulations as to deal with situational urges where a person needs just that little bit extra boost. So what I find here is that most people who do this will do it, the second product, for the first couple weeks just to get them over the hump, and then they stay on the patch for the recommended period of time. Pretty much this is what everybody's using right now. We're just starting people up with the patch. I use the patch and the lozenge most of the time. And we find that that's producing much better results than just using one of them alone. Bupropion and NRT, that was studied in one of the initial arms when bupropion was looked at as a cessation medication. So there is some improvement there. And right now, there is no real data on using varenicline and bupropion together. And varenicline with NRT, because it blocks the nicotine from getting to the brain, it only might help a little bit. So again, there's not much evidence there. I would just go with the patch plus, one of the other products. Again, completely safe. There is very little chance that your people who smoke are going to get too much nicotine from. These are the combinations that the clinical practice guidelines felt there was enough clinical data to recommend. Now, there's all kinds of other stuff out there. Our lovely internet has everything in the world with nicotine in it. These have kind of all fallen by the wayside. None of them work. There is no data for any of these products, so don't even go there. These have all fallen to the wayside because of this. So I don't think I can be any more clear. Vaping, e-cigarettes, Juul, any of these products, right now, there is not enough information. There's not enough data to say that they are effective, there's any efficacy in helping people quit smoking. What we have found very clearly in most cases is if people do this to quit smoking, they end up doing both smoking and vaping. They vape when they can't smoke, they smoke when they don't want to vape. So right now, if there were no other medications out there, if there were no other products out there, I would be telling you something completely different. But we have 7 medicines that we know are safe and effective, and I would not go into this arena with these products. Yes, they may be safer than smoking because they don't have tobacco in them for the most part, and they don't have all those other chemicals, but it's a say that they're safe. So again, we have 7 other products, go with them. All right, now I want to end up with another issue here that you may not be aware of, but it's very, very important. And I've given you a handout for this also. So what we know very clearly is that there are drug interactions between something in tobacco smoke and many, many medications. And what that is, it's the hydrocarbons that are in the smoke. They rev up the CYP1A2 pathway in the liver where many, many, many medications are metabolized. And what they do is when you smoke, you actually need more medication because it's burned up faster. So that when you quit, you need less medication. Now, why is this important? Well, in the past, before we knew this, we would have somebody on one of these medications. And as you can see, there's many psychiatric medications on this list. Somebody would quit smoking, all of a sudden would have all of these strange things happening, which they would attribute to withdrawal and therefore go back to smoking. But it wasn't withdrawal at all. It was too much medication. So it's very, very important that any patient on any kind of medication that you look at the dosing when they're quitting and adjust it usually downward when they quit, because they don't need as much medication as when they were smoking. As I said, I've given you, we update this list from the RX for Change program regularly. So I've given you a handout that has the latest up-to-date info on which medications are affected by this. This is not an interaction with nicotine. It has nothing to do with nicotine. It's the hydrocarbons that are resulting from the combustion of the smoke. So understand that. It's interactions with smoking, not with nicotine. So my recommendation here for you is to work with, if you're not a physician, to work with the patient's physician and adjust dosing on these medications as. You may have to do it a couple times until you get to the right dosing. And this is very individualized, and we don't really have any kind of test to know how much the medications are being affected. It's pretty much individual to report that to us. All right, again, I know I went through this very, very, very fast, but hopefully give you a very high level view of these medications. Again, I've given you that chart that has all of the ins and outs with it. In summary, again, as I said at the beginning, the best way to quit smoking is to combine a cessation medication with a behavior change program. And by the way, I mentioned vaping, not to use vaping as a way to quit smoking. Many of you are dealing with now people who want to quit vaping. There has been very little research using these medications for that, but intuitively, there's no reason why you can't, and many of my colleagues are using these meds. So that brings up the question, how do I dose? Well, the way to do that is most people who are using this are former smokers. So I would just look at how much they were smoking, because what they've probably done with the vaping is come up or giving themselves an equivalent amount of nicotine and just dose based on that. If these are new people who have never smoked and they are, new vapors, pretty much go with the highest level of the dosing, because there's little way to know exactly how much nicotine they're getting. And I would rather go with a little higher dose than lower, and then adjust it as needed. But you can use all these products with anybody who actually wants to quit. And this is my contact information. I'm more than happy to talk to you about any kind of issues you have individually or with groups, or any kind of problems that you might want to discuss. Okay, Norma, if there are questions, I'd be happy to.
Yes.
I didn't see any of them, because if I look at the chat while I'm talking, I lose track of what I'm saying. So.
I know, I understand very well. Yes, let's see. We have a question. Which replacement therapy have you found that works better?
Well, as I said at the very end there, varenicline is statistically from the studies shown to be the best of all of them. If you want to use a nicotine replacement therapy, I use the patch plus the lozenge. That's pretty much my go-to right now. That seems to work best for most of my patients.
Okay, and what one of our co-PIs who does training says which one works best is the one that, excuse me, the one that the patient will take.
Absolutely right. No, that's that person's absolutely correct. It's whatever we use, and that's part of the reason. One of the things I go into when I have much more time to talk about this is very individualized. So you really want to ask a lot of questions, and one good thing to ask right at the beginning is, will you do something 10 or 11 or 12 times a day? If somebody says, what, I can't, I don't have time to do all that, then don't go with the gum or the lozenge or the sprays, because you have to do that a lot of times during the day. That can be a very simple way of cutting through all that and knowing very quickly that they either want to use the patch or take one of the medications.
Yeah, and I think Dr. Hurley will touch on some of that when he does his talk about changing the use of tobacco products a little bit later. And we appreciate you condensing this, because I know this could go on for many hours. There's a lot of information. One more question. Can a person that is taking medication for depression also take bupropion? To review that.
Yes. Yeah. I think you cannot take it with an MAOI, but yes.
What's that? MAOI?
Mono. I don't remember the exact one, but anyways, it's that's one medication, but I don't think it's
monoamine oxidase inhibitors, but they're
Thank you. I
rarely used
know I
nowadays.
do it, but yeah, thank you. I think you can take it with many other antidepressants. But again, the issue there is to talk to the doctor, and maybe that's all you need is to take bupropion and not, not use another.
Yeah. And one of the comments from Catherine, who was our first presenter, she says the side benefit of quitting is the need for less psychotropic meds. So this
Right.
means less side effects, including those psych medications that have been attributed to weight gain, because we have a question about weight gain as well. And I think that might be the last one. Does varenicline cause weight gain?
No.
Varenicline / Chantix.
The weight gain, by and large, I mean, this is interesting. It does happen. I'm not denying it, but I know a lot of people who've lost weight when they quit smoking because they got more active. They felt better, so they got more active. From my perspective, I'm a behavioralist, so I kind of look at this from that perspective. If you think back, you're putting something in your mouth 500-600 times a day. So when you quit, you really miss that. And what's the natural substitute for that? Food. And because the fact that we know that smoking dulls the taste buds, so many people who smoke, their taste is kind of ruined. It's a mess. They really can't taste very well. But when they quit, those taste buds reawaken and everything tastes incredible. So not only are they eating more food, but think about it. What's the one ingredient in food that gives it the most taste? Fat. So
Right.
they're going after, they're not eating celery and carrots and radishes. They're eating potato chips and cake and candy. So not only are they eating more, but they're eating more fat. So they're doing two things behaviorally. That's where the weight gain comes about. So if you look at all the studies, if you do a meta-analysis of the studies, 1/3 of the people stay about the same weight, 1/3 of the people lose weight, 1/3 of the people gain weight. So it's not a guarantee. But if the person is concerned about it, then right from the beginning, do some stuff to mitigate the weight gain by looking at fat content, looking at their eating, ramping up, as you said at the end of the last talk, getting some kind of exercise, walking in something that will mitigate that.
Okay. And I think this will be the last one. Based on the fact that there is high use of marijuana, usually coupled with smoking or vaping, are there any meds that help in stopping marijuana use that you know of? And I'll just say, even off label, what's being used now?
No. Sorry. Okay. Yeah, and I know none of these 7 that I just talked about have any effect on marijuana. And that's not an area that I've really done much research. I'm not aware of anything that stops marijuana use.
Okay.
The supplement NAC is supposed to help marijuana cravings.
Okay. Thank you.
Great. We got so many specialists and skilled and experts on here. I'm grateful that we can bounce off of each other to get additional information. So I think that will wrap up yours.
Okay.
Frank, thank you again so very much.
You are most welcome.
Ecstatic about our bevy of speakers today. Thank you again for joining us.
You're welcome, and don't hesitate to contact me if you need any more information.
Okay, appreciate that.
Thanks.
Thank you. Okay,
best wishes with the rest of your conference.
Thank you much.
Bye-bye.
Bye.
Thanks so much.
Next, since it's baseball season, I'll say next at bat will be Dr. Neil Benowitz. Dr. Benowitz is with UCSF. And I'm sorry, my computer just went blank. Forgive me, I don't have your proper bio. Can you just take a couple of minutes to tell us a little bit about yourself and then go ahead and dive into your presentation, Dr. Benowitz. I think you're muted still. Oops. Dr. Benowitz, I see you here and I see that you're still muted. And
I've been
okay.
having some problems with the Zoom.
That's all right.
Can
Welcome.
you hear me now?
I can. Welcome.
Thank you very much. Thank you for the invitation to speak to this group, which is doing incredibly important work. So I'm emeritus professor of medicine at the University of California, San Francisco. I practice cardiology, but I'm also trained as a clinical pharmacologist and a medical toxicologist. I've been doing research on nicotine and tobacco for many, many years, stimulated by the fact that smoking is the most preventable cause of premature cardiovascular disease. So I've done a lot of work on nicotine and vaping and nicotine-related policy. So today I want to talk about a nicotine-related policy issue. And let me just share my screen. So can you all see that?
Yes.
Can you see my screen?
Uh-huh.
Okay, so I'm going to talk about something which does not exist as policy now, but has been proposed by the FDA to occur next year, which is a policy to reduce the nicotine content of cigarettes. And this could have a huge impact on the smoking cessation landscape, including what all of you do every day. So this is my conflict of interest. I do consult with companies that market or developing smoking cessation medications, and I have served as an expert witness in litigation against tobacco companies. So the first point I want to make is getting smokers to quit as soon as possible is essential for public health. This is a projection that was made back in 2000 of the effects of prevention versus treatment. So the solid yellow line are cumulative deaths in millions between the year 2000 and 2050. And the dashed line is what happens if you prevent smoking in kids, which actually we're doing a great job. The smoking rates in high school seniors are now 3%. But the dashed line on the bottom is what happens if you treat patients. And the reason why this is important is because people die when they're smoking relatively soon. So they die from heart attacks, sudden death, chronic lung disease. So a critical thing is to get people to quit smoking as soon as possible to advance public health. So if you look at sort of the quitting scene, these are surveys that have been published from 2000 to 2015. So 70% of smokers want to quit. 50% have made a quit rate attempt in the past year. Only 5 to 7% are successful a year later. So while smoking cessation is really important and what you do is critical, we're still making slow progress on advancing the health of current smokers. So the concept of nicotine reduction is something which could make this process of quitting for the population much, much faster. So for enhanced quitting, these are some of the things that have worked well. So one is denormalization of smoking, so constriction of social networks. This has worked especially well in kids, but this is true for adults as well. Traditional smoking cessation interventions, which is what you all do very well. And that's really key to any intervention. Tobacco harm reduction, where there's different views about this. I'm actually more supportive than others. But this is basically trying to get people to switch from combusted cigarette smoking, which is most harmful, to non-combusted nicotine delivery systems. With, they may want to sustain nicotine exposure, with much less harm. And the last one is tobacco product regulation. That's nicotine focused. That's what I want to talk about. So The combustible tobacco endgame is something which has been discussed for years, and this is really a strategy to eradicate or reduce to minimal levels of use and disease caused by combustible tobacco products. The beliefs are that the status quo is unacceptable and that reducing smoking substantially will require something new, bold, and fundamentally different. So let's talk about nicotine pharmacology and public policy. So this is a key concept. So the 10 million deaths annually, premature deaths in developed countries, is caused by addictive combusted tobacco use. So the main toxicants that kill people are the oxidants, the prothrombotic chemicals, the carcinogenic chemicals that are in tobacco smoke. Nicotine is in a way responsible for all of this, but not because nicotine is directly that harmful. It's not harmless, but it's because nicotine drives combusted tobacco use. So if you look at the harm is related to two things. It's the intrinsic risk of the product and how much you use it. And nicotine is why people use tobacco multiple times per day. Nicotine addiction cycle. You heard a little bit about this in some of the other talks. So a person smokes a cigarette, nicotine gets absorbed rapidly. It affects arousal, mood modulation, and pleasure. Throughout the day, tolerance develops to the cigarette. You see physical dependence, which means withdrawal symptoms, even between cigarettes. And then drug abstinence produces withdrawal symptoms that then trigger craving and your next cigarette. So regular smokers basically take in the same amount of nicotine day after day after day to optimize arousal and mood and pleasure.
Dr. Benowitz, excuse me, can I ask you if you put it in full screen? We can see your next slide. It's in presenter mode.
Oh, sorry about that.
No problem. Just makes it bigger for folks to see, I think.
Yeah, so let me just see which one of these. Unfortunately, I have a different taskbar up here to.
One of you other presenters, what should he do? Click on the three buttons there
I
down at the
think-
bottom.
Or go where it says display settings in the top. And then I think it'll give you the option there.
So which one should I hit?
Display settings.
Right there. Yeah.
Right above your left slide, it says display settings.
Display settings. I don't.
Right above there.
Go to the right a little, to the right, to the right, to the right, a little bit more. To the right. Display settings. Sorry, young people, we have a different kind of knowledge we're sharing with you today, so bear with us just a moment.
I don't see anything that says display settings per se.
Huh. We see it, but
Yeah,
So
that's
it's not
great.
new share. It's not pause share. It's not annotate, remote control, apps, more.
And it might be
not
depending on
on
the kind of
Zoom.
computer. Mhm.
Pardon?
You might be looking at your Zoom settings. If you're looking at your Zoom settings, that's where you're missing annotate. You have to look to the PowerPoint. That's where it's going to show display settings.
Down at the bottom where it has the pen and the monitor with the line through it and the three
Right.
dots.
So I'm not seeing that. That's the problem.
okay.
Oh, okay. Well, folks,
Do you
bear
have
with
two
us. We'll-
monitors?
Yeah, I got two monitors.
Oh,
If you
that's
have
good.
two monitors, you might want to look at the other monitor where your slides are.
Right.
Yeah, so
Maybe
you're
I should
clicking
just-
on it now. It's like a black screen.
Maybe I should take off my second monitor. Let me see that. So it's still, I still can't.
What do you see now on your end?
Basically my slide and the coming slide. So if I do stop share, let me stop sharing.
Yeah,
share.
I would end your slideshow and then start your slideshow again. And now that you only have one monitor, it should show up the way that it's supposed
Right.
to.
Oh shoot. Okay. Well,
Now we just see you. Okay.
Can you see my slides now?
No.
No.
Go
Gotta
to, yeah,
share
now
again.
go to your Zoom bar and hit share screen.
Okay. Well, the problem is I can't get my Zoom bar now. I'm gonna go back to the share screen. How's that?
That's it. That's the ticket.
Perfect.
Thank you. Thank
All right, all
thank
right.
you, little minion who helped us.
Sorry about that. Sometimes two screens make it more complicated. All right. So just, I'm not going to spend a whole lot of time about this, but people are concerned about the safety of nicotine. And this is something I've been interested in for a long time. Let me just summarize really quickly. Nicotine definitely causes addiction, and that's its main harm. It has a probable role in cardiovascular disease if you have pre-existing disease. Although data from Sweden, where large percentage of the population uses snus, which is oral tobacco, that delivers just as much nicotine as cigarette smoking, does not accelerate atherosclerosis, but probably increases the risk of events once you have cardiovascular disease. Reproductive toxicity, we know nicotine can affect birth weight and has got effects on fetal maturation. There's concerns about impaired adolescent brain development. I can answer questions later. I would say it's possible. Nicotine activates an anti-inflammatory reflex in the body, so it could affect infectious disease risk, shown in animals, not in people. There's some theoretical relationships to cancer and likely no role in COPD. All right, so again, why cigarettes are so harmful is because they're hardly addictive. Addiction means loss of control of drug use, and we said that 70% of smokers are daily smokers and rarely go through a day without smoking, and that's all nicotine driven. We talked about this. Okay, so the history of the nicotine reduction intervention. So it starts, this is David Kessler, who was head of the FDA. He was a pediatrician. And back in the early 90s, he started looking at tobacco company documents. And they found documents showing that the companies designed cigarettes to alter bodily function and to be addictive. And he decided that nicotine delivery devices like cigarettes are drugs based on the FDA definition of a drug, which is a product that is intended to affect the structure or function of the body. And he declared the intention of the FDA to regulate cigarettes as drug delivery devices for nicotine. Well, the FDA decision to do that was overturned by the courts. But then in 2009, the Family Smoking and Tobacco Control Act was passed, which then gave FDA the authority to regulate cigarettes. And they formed the Center for Tobacco Products, which is the branch of FDA that regulates cigarette products. So since 2009, we've been able to regulate tobacco products. And this has given the FDA the authority to promulgate tobacco product standards as appropriate to the protection of public health. And standards means what's in the tobacco or what the tobacco product delivers. It also gave specific authority to reduce nicotine yields of the product as long as it does not require total nicotine to be reduced to zero. In 2016, Scott Gottlieb, who was head of the FDA at that time, and Mitch Zeller, who was head of the Center for Tobacco Products, published a really critical paper in New England Journal of Medicine, which basically talked about a nicotine-focused framework for public health. And in this framework, they said there is a continuum of risk for tobacco products. So cigarettes, which are the most intrinsically harmful, the most addictive, are on one end. Nicotine medications, which are much less addictive and not very harmful at all, are on the bottom end. Smokeless tobacco is partway up. E-cigarettes are partway up. And so the thought was that if people could not quit smoking, let's at least drive them down the continuum of risk of nicotine products. And would also be supportive of the availability of, say, e-cigarettes or other less harmful tobacco products. So this was the intent of the FDA. Now, this was the commitment of the FDA to this was changed a bit when vaping became such a problem with adolescents. But this concept is still relevant for nicotine reduction. So the argument of this paper was that smoking causes almost 500,000 deaths per year in the US. Like I say, the core problem is not nicotine itself, but combusted tobacco. The goal was to reduce the addictiveness of cigarettes, to focus on nicotine and support innovation for harm reduction, and to continue or to consider the continuum of risk of nicotine-containing products. So what about reducing nicotine content of cigarettes to make them less addictive? So I and Jack Henningfield, a colleague, back in 1994, published this paper called Establishing a Nicotine Threshold for Addiction. And this was based on documents from tobacco companies showing that they did research to determine how much nicotine was needed to sustain smoking. And they make sure in their manufacturing that every cigarette contains that amount of nicotine. Now, at first, our thought was, kids we know start smoking not because they're addicted, but because their friends are smoking or they want to be cool or whatever. And then over time, they change from smoking for social reasons to smoking for pharmacologic reasons. But if you ask kids, are you going to become addicted? They would say no. So the idea of this would be basically to give kids the freedom to, if they want to experiment with tobacco, that's fine, but they would not be driven to addiction. Now, obviously, if you're an adult smoker and this occurred throughout the population, it would also affect you. And then we did some calculations to suggest a dose to establish addiction. And then we proposed a gradual reduction of the nicotine content of cigarettes over 10 to 15 years, which at that time, FDA did not have authority to do, but now they do have it. And here's a cartoon I use in my talks. Basically, there's a study that was done just interviewing adolescents when they started smoking and saying, do you think you're going to be a smoker 5 years from now? And almost all of them said no. But when I went back and talked to them 5 years later, a high percentage were addicted. So again, the rationale was to prevent children who experiment with smoking from becoming addicted later in life, and that addicted smokers, most of whom would like to quit, will move towards cessation. 1998, the American Medical Association committee examined this proposal, and they basically endorsed it fully, saying, we think it's a great idea, we think FDA should do this, in 1998. Now, I want to make sure you understand what a reduced nicotine content cigarette is. This is an ad from a long time ago when companies could advertise yields of cigarettes and different cigarettes. And so this shows basically tar yields of cigarettes, but nicotine could be put on the same scale. And there were some cigarettes like Now that were very low, and cigarettes like Camel and Marlboro that were very high. And so people thought that low yield cigarettes were these commercial cigarettes. Well, it turns out these cigarettes contain just as much nicotine as regular cigarettes, as high yield cigarettes. They're low yield because of faster burn time. So the smoke machine takes fewer puffs, more ventilation, so more air comes through, ventilated filters, and also people just take more puffs and deeper puffs. This is a copy of the smoking, or picture of the smoking machine, which determines the yields. And you can see that you put a cigarette in there and you burn them. You take a standard puff every 30 seconds till it burns down to the filter overwrap. But smokers take much bigger puffs and much more puffs. And so this machine is really inaccurate. And we and others have studied this and found out that people who switch to low yield cigarettes take in just as much nicotine as regular cigarettes, the commercial ones, because they contain the nicotine. The reduced nicotine content cigarette would have 95% less nicotine content. So you could not possibly compensate. So, and this is just what I said about compensation. So the original proposal was to reduce nicotine availability in cigarettes over maybe 10 years or whatever. And then for people who couldn't quit smoking, provide clean nicotine alternatives. And then they could either continue that or quit smoking, but the harm would be markedly reduced. An important thing to keep in mind is that if you reduce nicotine in cigarettes, all other forms of combusted tobacco have to also have reductions. So roll your own tobacco, little cigars, pipe tobacco, it must all be uniform because otherwise people will just switch to a different product that's got nicotine. So it's not just cigarettes. Every combusted tobacco product has to have a nicotine reduction. So let me just summarize really quickly the study. So a number of studies have been done since the year 2000. We did the first ones, but several others have been done. So one of the first studies that we published was with a small group of smokers switched to experimental cigarettes that were low in nicotine. And cotinine is a marker for daily nicotine intake. We did this over 6 weeks. And we found that people reduced their nicotine intake by 70%. They tolerated it pretty well. They did smoke a few other cigarettes that were not research cigarettes. We could tell it by analyzing the expected cotinine versus actual. Several quit after the end of the taper. And interestingly, at 8 and 10 weeks, when they were back on their normal products, their nicotine intake was substantially less than before. So the level of addiction had been decreased and the amount of nicotine that they needed each day was decreased. This was the first study to look at this experimentally. And then this was cigarettes per day. So in the beginning, they smoked more cigarettes when the yields were a little bit higher, but by the time they got down to the lower yields, they were smoking fewer cigarettes. And as follow-up, back in their own cigarettes, they smoked half as many as a baseline. So clearly the level of addiction was reduced. And these are some quotes from some of my study participants. So I no longer feel the need to have coffee and cigarettes first thing in the morning. I'm experiencing less craving. Smoking these cigarettes are like quitting, and therefore I might as well quit. And smoking is losing its pleasure. So there have been several large studies. Eric Donnie did one that was published in New England Journal of Medicine in 2015. This was like 800 people using various yields and basically working out what the threshold would be. And so they figured out that the level of nicotine would be 0.4 milligrams to 1.3 milligrams per cigarette. And they found that when you did that, people dropped their nicotine intake by 70%. They smoked fewer cigarettes per day. Those reduced dependence, increased quit attempts, no compensatory smoking, and no increase in other substances like cannabis or alcohol. Dorothy Hatsukami led another trial, which is published in JAMA in 2018, which looked at immediate versus gradual reduction. And basically what they found is that, first of all, immediate reduction was tolerated relatively well. You can see at the bottom, nicotine levels dropped markedly, immediate, more slowly with gradual, as you'd expect, versus own control cigarettes. And cigarettes per day and exposure to toxicants drop more if you immediately drop levels. So the current consensus is we don't need to taper over 5 or 10 years. We could do this immediately. So, as soon as FDA does it, and as soon as the lawsuits are settled in the court, they do it. And what was found in this study basically is that immediate reduction was associated with greater decreases in tobacco dependence and higher rates and duration of the number of days of abstinence that occurred. So this seems to be a pretty reasonable approach. Again, there's been concerns about compensation. Well, won't people just smoke more cigarettes? Because we know that occurs when they're switched to commercial low-yield cigarettes. As I mentioned before, with very low-yield nicotine cigarettes, compensation is impossible. And several clinical trials document no increased exposure, including studies that were done in hotel rooms where people could not get 1 or 2 of their own cigarettes if they needed it. And basically over a week, people reduced their nicotine levels to 5% of baseline, and a number of biomarkers were examined. There was no increase in any toxicant exposure. So compensation is not an issue. So in 2018, the FDA issued an advanced notice of proposed rulemaking for a tobacco product standard for nicotine levels in combustible tobacco. And they elicited comments from a variety of sources. They analyzed those comments. And then this year, it was announced that the Biden administration is considering a rule that could be put in place by 2023 to cut the nicotine in cigarettes. And they're also talking about banning menthol. Now, whether this is going to occur in 2023 is unclear because most likely the tobacco industry will file many lawsuits. But if this happens, this will be a total game changer in terms of tobacco control. And again, here's another quote from, I forgot, New York Times maybe. So one thing which comes up is nicotine reduction prohibition? This has been a big concern by a lot of people. And we know prohibition has not worked for other drugs such as alcohol and cannabis. And smokers, this is really important. Smokers need to be educated that nicotine is per se is not being prohibited. But what's happening is that the harmful delivery system for nicotine is being not prohibited, but markedly less addictive. And so other less harmful forms of nicotine will still be available. And this is important because some people don't want to give up nicotine, or some people self-medicate mental illness with nicotine, and they need to have an out. They need to have a way to go so that this is not seen as prohibition. So possible adjuncts to nicotine reduction are nicotine replacement medications, non-combustible tobacco products like smokeless tobacco products like oral nicotine pouches, electronic cigarettes. And one thing people have talked about is differential taxation, which I won't get into here. But I think this is important, that people need to have an out. So this is not viewed as another prohibition approach. I published a paper along with Eric Donnie and Dorothy Hatsukami in 2016 saying that reduced nicotine content cigarettes and e-cigarettes are best used in combination to promote the cigarette endgame. Of course, e-cigarettes need to be the least harmful ones and the most effective ones, and they have to be kept away from kids. But I think that's feasible, and this could be the end of combusted cigarettes. So some things are needed, and this is where the impact on the smoking cessation infrastructure comes in. There's got to be public and medical education about why this is being done. Again, we're not reducing nicotine because nicotine is what causes cancer. We're reducing nicotine because nicotine is what makes you smoke 20 cigarettes a day. This would tremendously increase the demand for tobacco dependence treatment. So millions of smokers would need assistance in a relatively short period of time. We also need surveillance to assess changes in cigarette consumptions, make sure that there's not increases, to look at whether kids are smoking more or less, any other unexpected consequences. And again, we talked about the ready availability of alternative non-combusted nicotine products. So again, these are the key public educational messages which people like you will need to transmit. So nicotine is not being reduced because it is intrinsically harmful, but because it sustains cigarette addiction. Nicotine reduction will make it easier to quit smoking, and other less harmful forms of nicotine will be available. So you need to convey these messages to everybody. So in conclusion, I would say reducing the nicotine content of cigarettes is likely to reduce the addictiveness of cigarettes. The result would be preventing children from becoming addicted smokers and giving adult smokers who are currently smoking greater freedom to stop if they decide to quit. And again, immediate rather than gradual nicotine reduction is probably safest and most feasible. Electronic nicotine delivery systems would provide an attractive alternative to conventional cigarettes and would likely enhance public acceptance of a nicotine reduction policy and the possible long-term adverse effects of of these products, including primary addiction, nicotine addiction in youth, remain a concern, and obviously have to be addressed. There was a couple of papers I've tried to assess what the impact would be modeling this. And so one paper published in the CDC by Appleberg in 2018, basically they modeled the effects, and they concluded that considering 2016 to 2100, nicotine reduction would prevent 33 million youth and young adults from becoming regular smokers. And that 5 million smokers would quit within 1 year of implementation and 13 million within 5 years. Another simulation was done in 2004 by Tangs about this proposal. And they projected that the smoking prevalence is likely to decline to 5% after this occurs, with a resultant gain of 137 million quality adjusted life years over 50 years. And that policymakers would be hard pressed to identify another domestic public health intervention short of historical sanitation efforts that has offered this magnitude of benefit to the population. So to end up, New Zealand is currently proposing this smoke-free 2025 tobacco control policy. And this is one, the Maori have got a high prevalence of smoking, and they're very much involved in leadership and decision-making. They're going to increase health promotion and community involvement. They're going to increase stop smoking services. They're also talking about reducing the nicotine content of cigarettes. And they're also doing something which I think is a good idea too. That's something called a smoke-free generation, which basically says that anyone born after a certain age cannot buy cigarettes. So say they, if you would go back, say 18 years from now, whatever that is, you would say anyone born after that year cannot buy cigarettes anymore. And for vaping, they want to ensure that smoked tobacco products are more regulated and less available in vaping products, again, to promote harm reduction. My final slide is this one. This is something that just came out. So besides the AMA, 72 health organizations in the US are now supporting FDA mandated nicotine reduction. So this includes the American Heart Association, the American Lung Association, the American Academy of Pediatrics. As many organizations as you can think of are all supporting this. So let me stop at this point and then ask if anyone has any questions.
Thank you very much, Dr. Denowitz. We do have a couple of questions. Are babies born to fathers who are heavy smokers affected as much as a mother who is a heavy smoker?
That's a very good question. Certainly, if you're born to a mother who's a smoker, there are a number of epigenetic changes. So there's changes to your DNA that the baby lives with the rest of their lives. It's not clear if the father's a smoker, how much that occurs. And so I'm not, there may be some data about it. I'm not specifically aware. It's also hard to sort out the fact that if the father is smoking, there's also a home where smoking is occurring. And so there's a lot of other socioeconomic issues that affect the behavior of the child when they're born in a smoking household.
Mm-hmm. Okay. Emily Bertram says, as I understand it, vaping also has serious health consequences due to the high heat involved. Can you speak to that?
So certainly there is a wide spectrum of harm from smoking depending on the device. So the big mod devices, which have high temperatures, generate large amounts of what are called thermal degradation products. So you're basically breaking down propylene glycol and glycerin into toxic things like acetaldehyde, nicrolein, and formaldehyde. And those are clearly more toxic. And also people use liquids that are low in nicotine, so they vape much more into their lungs. But if you take a product like Juul, and I'm not promoting Juul, I'm just using this as an example because they were the first one to basically put in heat controlling feedback devices into the device. So they control the heating temperature so that it doesn't get as hot. Breakdown products are much, much less. There's high nicotine in there, which is a mixed blessing. The positive side, it means you have to take in very little aerosol to get in the amount of nicotine to satisfy a smoker. And that's so a Juul or Juul-like device could be relatively safe because it does not generate high temperatures and gives you plenty of nicotine. Now, the downside, of course, is that it's got a nicotine salt base, which makes it easier to inhale. And so it's easier for kids to inhale nicotine and become addicted. So that's a downside of Juul and similar devices. So that requires basically education and access control for youth. But I think devices like Juul probably have relatively little harm compared to cigarette smoking. And again, it's comparative. I would never recommend anyone to start Juuling or whatever, anything, if they're not a smoker. But smoking is such a harmful product, thousands of chemicals that are harmful to the body. E-cigarettes have got many fewer. There have been a number of biomarker studies looking at all the toxins we can measure in the urine. And if you switch to an e-cigarette with a low temperature, your exposure, it's hard to detect exposure to a toxic over baseline, where cigarettes got huge effects. So I would say temperature is important, but this is something FDA could regulate. They could say only devices with low temperatures are the ones that could be on the market.
Okay. There's a question, have any efforts been made to remove ammonia from nicotine?
Okay. The ammonia story is interesting. So that in the ammonia story, ammonia is in cigarettes and it has effects on the flavor of the cigarette. It makes it, it affects the taste. It's ironic because at one time there was a concern that ammonia, because it increased the pH of the smoke, would have made the smoke contain more free base nicotine. And it was thought maybe to be more addictive. Now it's interesting, just as some history for you. Natural tobacco, when you burn it, has got a relatively high pH, and nicotine is quite irritating because the free base is irritating. That's what hits the receptors. Flue curing, which was developed in the late 1800s, basically results in more sugars and more acids being generated, so the pH drops. And so a cigarette of pH 5.5 smoke, it's got mostly protonated nicotine, so it's not nicotine base, and that's less irritating and easier to inhale. And a Juul basically has got the same pH as cigarette smoke. So ammonia, if anything, makes the cigarette harder to inhale. And so the original concerns about more free base being more addictive have not been borne out. So it makes the main thing for ammonia is like another flavoring. So that basically makes the cigarette more tasty and people like it more. But the whole concept of ammonia making cigarettes more addictive, I don't think that's true.
Okay. All righty. Dr. Friedman has put some information regarding an article in the chat box. Dr. Friedman, you want to speak to what that article is?
Yeah, so I mentioned earlier about NAC, nicotylacetylcysteine,
N-acetylcysteine.
N-acetylcysteine for you marijuana craving, and there's a reference to it right here.
Yeah.
That was from last talk, but
Yeah.
I don't know if it was talked about last, but we're studying the combination of marijuana and THC. And one, you talk about vaping. We did a study with adolescents looking at urine, nicotine, and THC exposure. And there's a very high concordance. So if you were a smoker, you had a 70% chance of using marijuana. And we know that vapors, there's a high concordance of vaping nicotine and vaping THC. We also know that the combined use of marijuana and cigarette smoking makes you more dependent on both. So it's hard to quit smoking and harder to quit marijuana. So dealing with the combination of both of these, I think is going to be a real challenge for all of you in smoking cessation field, because if they're still smoking marijuana, it's going to make it harder for them to quit their cigarette smoking. So that's something you need to think about.
We have an investigator at my university who's working on blunts, which is very heavily marketed to the African American community. That's marijuana inside cigarette wrappings for the most part, cigar type
Cigar.
wrappings.
Yeah,
Cigar
yes,
wrappings, right? Yeah.
Okay, okay.
There was a question on your background. Is that like Tahoe?
No, this, if any of you know the San Francisco area, so there's Mount
Yeah.
Tamalpais.
Yeah, beautiful.
This is a place I mountain bike, and there's a lake that I mountain bike past, and I always stop here for a few minutes to admire the lake and to have a snack.
Mm.
That's beautiful. It is.
Yeah.
That's so
What's the
One
name
of
of
my
the
favorite
lake?
places.
What's the name of the lake?
Is it a Marin somebody's asking, or Phoenix Lake, or
It's Alpine Lake.
Alpine? Oh, yeah, it is really beautiful up there. Wow.
Alpine Lake.
Okay, well, thank you for that background.
Thank you so much.
Somebody
It's a
asked
great
about-
talk. Really nice.
Yes, wonderful, wonderful. And thank you again for taking time out of your busy schedule to come and share with us this morning. We really do appreciate it. Thank you so
Okay,
much.
thank you for inviting me. Okay.
Sure. All
Enjoy the
right.
rest of the meeting. Bye.
Thank you. And we are at time for our panel of tobacco-free recovery, the community experts, perspectives from the field. We have a panel. And Jessica, can you instruct Granny on what she's supposed to do to get you all on the screen?
Oh, is that something you're able to arrange, Norma, to be able to pin us all so that everybody can see the panel numbers?
You know what? I will. It says I can do. No, it says that I can do a full gallery. I don't know. And I know that we've had this before. I'm not sure. Can anyone else chime in? A way to get only the speakers on the screen, only to get the panel on the screen?
I think if you go to the actual panelists, you can go on the three dots and then pin spotlight for everyone. Probably would work.
Okay.
So you've got Arlene Vasquez,
I got you. Okay.
Jessica. There you go.
Yeah, there's Jessica, Arlene. Arlene's coming up next. Add spotlight. Aura.
Great, so Aura Gonzalez. And then not sure if Katie Rogers is in yet. I know she'll speak later on. And Veronica
she's not.
Lewis as well will be on.
Yes. Okay, just 1 second. Yeah, Veronica's here. She's not. Oh, here she is.
Marvels of technology.
Oh, yes, I learned quite a bit today. So do we have everyone who's here other than Katie now?
Just Aura.
So
right?
Aura Gonzalez, I believe, is on.
I'm sorry?
I believe Aura Gonzalez is
Yeah,
on
she's
as
here.
well.
She is.
Great. Okay.
But it doesn't
so
get, you know what, it doesn't give me the opportunity. I don't know, are you on your system at work, Auda, that, is pretty locked down? I'll pin it. I don't know what that means. No, it doesn't allow me to. And I know we've had that issue before with people that are on certain systems that have really strong security. They don't allow it. So I'm sorry,
well,
Auda.
we'll do the best that we've got. So no worries.
Okay.
We'll keep moving full steam ahead. So thank
Okay,
you for
but just
having
remember,
us.
she's here. She's here. Auda, we're sorry we can't get you to come on the screen, but we know you're here and appreciate it. So let me just introduce you a little bit, Jessica. Jessica is our facilitator for this panel, and she's with the UCSF Smoking Cessation Leadership Center, and has been working in this field for several years. And she's the program manager for California Behavioral Health and Wellness Initiative. And so you can take it from there if you want to add a little something, and then it's your panel.
Sure. So just to give a little background, you've heard Catherine Salcedo present earlier. She's the Deputy Director of our organization, and I work very closely with her. We have been lucky enough to have a wonderful project, the California Behavioral Health and Wellness Initiative, where we've worked with many great folks who are addressing tobacco cessation in the behavioral health field. So we've got a few guests today. Arlene Vasquez of LA Cata, Aura Gonzalez of La Familia, and Veronica Lewis of the Homeless Outreach Program Integrated Care. And what should make this panel kind of interesting and dynamic is each of these folks are kind of in a different place in terms of the level to which they have or maybe haven't even addressed tobacco cessation in the work that they do. So we're hoping to have kind of an interactive, casual conversation where we can all kind of learn from each other as far as best practices. So what I wanted to do first was give each panel member a really quick, couple, 1 or 2 minutes, just to introduce yourself to folks, talk a little bit about the organization that you work with, and what your organization has done to address tobacco. And we can start with Veronica.
Good morning, everyone. Is it still morning? Yeah, good morning. Thank you, Jessica. And thank you, Norma, for the invitation. Veronica Lewis from Hopix. We're known as Hopix. We're part of a parent company called Special Service for Groups, and we're primarily based in South LA, Compton, and Linwood area. And we work in 3 different domains that obviously where smoking cessation is very much so needed. So we're a behavioral health provider, providing outpatient substance use disorder services, intensive outpatient, and recovery bridge housing, which is one of the main pieces I'll be lifting up as we talk today. And then we're also an outpatient mental health provider and one of just over a dozen trauma recovery centers funded by the state of California. We also, the second bucket of work is reentry. So an array of supports for people returning home from jail and prison, or folks that have been in the community for a while, but are still having difficulty stabilizing. And then the third bucket of work is our largest portfolio of homeless and housing support. So an array of services from outreach, access center, to a lot of permanent housing programs. But the thing I'll be talking most about today is our variety of interim housing programs, where on any given night, Hopix, we're keeping about 2,400 people off the street every night temporarily in interim housing, including about 400 children. And there is a lot of smoking there. So we have not formally done any smoking cessation yet, but we are really excited about doing it because it is a major concern of ours, in particular at our recovery bridge housing sites. And as I mentioned, the interim housing program. So thanks again for having me.
Great, and we'd love to delve into that a little bit more. I know the homeless population, is especially underserved in this area. So I will be asking you a couple of more questions to address that. I'd love to move on to Arlene, get a little bit more information about LA Cata and who the clients you serve are.
Yes, good morning, everyone. My name is Arlene Vasquez. I'm the Director of Outreach and Community Engagement for Los Angeles Centers for Alcohol and Drug Abuse. Our acronym and what we're mostly known as is LA Cata. We're a nonprofit agency that specializes in behavioral health. We're on our 51st year responding to the needs of the communities. And our primary focus is on saving lives. The way that we do this is by providing direct services such as substance use disorder treatment at a residential treatment setting, outpatient setting, intensive outpatient settings. We have recovery bridge housing. We have specialized services that such as medication-assisted treatment, HIV prevention, testing, and linking to care. We have homeless outreach and engagement. We're part of a mobile crisis response team that corresponds with law enforcement's and fire department. We also have a youth and family services that focuses on our adolescents and transitional age youth and extending the support and services to families. We also are the largest provider for recovery bridge houses in Los Angeles County. As part of our contracted services, we've implemented smoking cessation throughout our services, making sure that we screen individuals upon intake and letting them know that we offer smoking cessation services that also include medication-assisted treatment for where we offer the nicotine replacement therapy. So it's great to be here today to be able to share our experience as far as implementing smoking cessation, being able to successfully have one program become tobacco free, and then another where we had to implement a harm reduction approach. But thank you, Jessica, for inviting me.
Thank you so much, Arlene, for joining us.
You're
And I know we don't have you on screen, but just checking in, Auda, if you are able to access your audio and give us a little bit of update about your work. Okay, so
Hi,
we'll
everyone.
see,
I have a PowerPoint. Is that okay or no? Can you
sure.
hear me?
Do you want to just give a quick, maybe 1 to 2 minute update on, what La Familia is working on, just to start with?
Yes, that would be great. Give me 1 second. Hi, everyone. So my name is Auda, and thank you, Jessica, and everyone at UCSF and Norma for having me here today. And I work at La Familia in Oakland, based in Oakland, California. We started with UCSF at El Chante, and El Chante was funded in the 1950s. It's a 90-day program. We house 20 mailmen. It's the only bilingual program in Alameda County, and we're proudly smoke-free since May 2021. So before El Chante became smoke-free, we had 6 fresh air breaks where clients were allowed to walk to the corner and smoke. They were able to have on them cigarettes, vapes, and chewing tobacco. So in 2021, we partnered with UCSF for the tobacco cessation grant, and we started working with them. We did many trainings, and one of our partners here in Alameda County grant us a scholarship to do a to become tobacco treatment specialist with the University of Massachusetts. And the majority of the staff took this training, and we're just waiting for it to be certified with them. The most important thing that we did was that we replaced the fresh air breaks. And we did that with walks around the lake, a lake that's near our home. We did gardening, movies, sports, tournaments, art hours, puzzle races. We did a lot of educations and groups around smoking cessation. We had a workout group. We included a healthy menu, and clients were provided with books, puzzles, coloring books, word search books, etc. We also have nicotine gum on site and patches for the clients when they need. Here's some of the gardening. They grow squash, tomatoes, peppers, beans. These are some of the activities. The beach, we went to the beach, we went to the movies. They did a lot of murals around the house and a lot of artwork that they were able to take home or donate to the house. And we just have it all around our house. This is some of the art stuff that they created while we were doing this grant, and they're still doing it. And I started something called the Tea Time, and I like to honor my grandmother because, so I'm from Guatemala and we are from Mayan descent. My grandmother was from a place called Cobana, El Taberapaz, Guatemala, and she was very holistic, believed in tea cured everything. And so I did notice that some of the clients were still showing signs of anxiety, although they were taking medication and they were unable to sleep. So I just practiced what I learned at home when I was a child, and we would form a circle and have tea. And then I found all kinds of teas, you know, so so some of the benefits that we have found is that the clients reported, and we noticed that they had less anxiety. They reported that they were able to sleep better, and they started coming to our office asking for tea because they wanted to switch from caffeine to tea on their own. And they were optimistic. They're actually optimistic. They look forward to tea time every night. And we found it a way to kind of nourish them. And, you know, we can't go back in time to like nourish them as their mother, but that tea time kind of like it's right before bedtime, and they feel loved, and it's helping them with their tobacco cessation. So thank you, and thank you for letting me share.
Sure. Thank you so much, Auda. I appreciate that explanation. That's wonderful. One of the things that I wanted to start with was an issue that came up a little bit earlier in these presentations, which is the issue of health equity. And I would love to understand a little bit more about how folks, maybe we can start with Veronica, would look at something like tobacco cessation as an issue of health equity.
Thanks, Jessica. Again, unfortunately, I wasn't able to be a part of the earlier discussions, but I, you know, as a homeless service provider, we're one of the largest homeless service providers in Los Angeles County, serving some of the most disenfranchised and impoverished communities with all the different health disparities and overrepresentations and essentially very disturbing data in all facets of life, right, including health. And one of the things I find most interesting is, you know, in the homeless services sector, there's been a lot of work and we're still not where we need to be, but you know, there's a lot of attention paid for obvious reasons to the intersection of behavioral health and homeless services, and in some cases lightly touching, you know, in particular related to STDs and STIs, some of the preventative stuff. But there is not any focus on smoking cessation. And as I've said, are a significant amount of people that are living outdoors still, or even in our shelters who are smoking. And so I think that it's critically important that we begin to really focus on the dangers and the impacts of long-term use of tobacco amongst our homeless service. Amongst people that are experiencing homelessness. And so I think that, you know, it falls into the larger equity push related to trying to address all the different disparities and the overrepresentation in chronic diseases and early deaths and all these other things that I don't have to tell this group about. So yeah, it's critically important. And that's why I'm glad to be here today to maybe push for that as one of the leading organizations in our system, so it can be a system-wide effort.
Great. That's really helpful. And, you know, I know we're always trying to tie this into what we've heard earlier. And one thing that people brought up is, you know, what I like to think are myths that maybe folks who are really struggling aren't interested in quitting, or, you know, staff members at organizations feel like, you know, hey, folks are dealing with homelessness or they're dealing with drug addiction, you know, let's put tobacco use on the back burner. So I know, Arlene, you guys were able to kind of address tobacco really on par with a lot of other issues. And I'd like to hear a little bit about, you know, the way that you went about it.
Right, definitely. One thing that resonates as far as tobacco is I had one of the coordinators say, oh, Arlene, we're finally addressing tobacco use as a disorder, right? And we're putting tobacco as a substance that needs to be addressed. So working with vulnerable populations, earlier we heard about the adverse childhood, you know, experiences, ACEs. A lot of the individuals that we provide services to are community that we're surrounded with. There's history of trauma. So therefore, you know, there's also the diagnosis STDs and co-occurring disorders. So we're seeing how tobacco use impacts this particular population and the inequities that exist. So what we're doing is, as an agency, filling the gaps to educate the individuals, empower them so that they can make educated decisions. So just like earlier, you know, throughout the conversations and the education that we received, rather than telling the individuals what they cannot do, let's go ahead and introduce them to alternatives that they can do. And you know, especially with the tobacco industry focusing particular populations such as our youth, right? We make sure that we also provide a lot of prevention education so that there isn't misuse of substances, including tobacco and nicotine. So that's how we're addressing the inequities, right? And making sure that there is health equity through education, not only through the direct services that we provide, but also through community engagement and education, and along with our county, our state, and our federal government, working on policies and addressing this as well.
That's wonderful. Thank you. So, we've talked a little bit about health equity, issues that folks in the community are facing and how that works together with enabling them to have access to tobacco cessation and how important that is. One of the things I want to address, I know Catherine was talking a little bit earlier about, unfortunately, the lack of organizations that have gone tobacco free and how complicated that can be when you've got staff who are smoking and they get along well with the clients. You're sort of sending these mixed messages. So I wanted to ask Aura briefly. You do have an organization, La Familia, that was able to go tobacco free, and I wanted to just pick your brain and ask a little bit about how you were able to do that and how you worked with the staff.
So we were able to do that. We did a lot of education. We did a lot of webinars like this one. And at the beginning, we didn't have a lot of knowledge about, how tobacco was affecting our clients. We actually felt like, oh, if they're feeling anxious, let's give them an extra smoke break so that they can relax. And we didn't realize how we were harming them. And so we did a lot of webinars, we did a lot of education. I'm grateful that we partner with a lot of, for example, the Bridge Clinic at Highland Hospital, Lifelong Medical Center, who gave us a scholarship to do this TTS training. And, everybody, all the providers around here that were happy that we were going smoke free. So they gave us curriculums, they gave us ideas on how to what to do with the clients. And there, I would say maybe about 20% of the clients report that once they're done with our program, they're going to go back and smoke. But I was surprised to see that the majority of the clients are they say how stop smoking has bettered their lives, and that they're gonna continue with their recovery and stop smoking. They definitely enjoy the art groups. They enjoy the gardening. They worry about their fruits and vegetables and worry about how long it's going to take for it to sprout. So, we are available for them 24 hours. So if they're going through anxiety or they feel like, I need to talk to someone about, I'm having cravings for cigarette, we were always available for them. And it was very surprising to see that they themselves reported that, even the tea there, you would see all these guys with tats in their face and they would look at the cup and they said, I didn't know tea could do this for me. So I think those were some of the factors that help, and meeting monthly with UCSF, Christine, that really helped us be successful with this. In early intervention.
I think it's very important that you talk about not making assumptions. I mean, in our program, we've seen, like you said, kind of men with a lot of tattoos who are in prison and they're doing trauma-informed yoga and they're loving it. So I think it's awesome not to put the kibosh on anything before trying. I think that's a big deal, to kind of try and see what works. And one thing I wanted to ask Arlene, I know you guys did a lot of amazing work in terms of doing some reframing. So not focusing simply on, okay, you guys are not smoking, but looking at how can we sort of create an overall lens of wellness and get people to kind of change their lives and focus more on health. So if you wouldn't mind talking maybe a little bit about some of the things that you were able to accomplish.
Sure. So you'll probably hear some commonalities along with what Aura just presented. It was about helping the individual just take a holistic, whole person approach, right? Don't see this as, we're offering you smoking cessation or we want you to quit completely. It's more of an opportunity of how can we guide you or assist you in improving your overall health. one way to do that is by addressing nutrition, right? So rather than just presenting nutrition, we made it more of a inclusivity, right? Taking all the diverse cultures and sharing with one another, putting some of those healthful dishes on the menu. So incorporating their culture, their healthful meals into our menu and empowering them to be a part of that design. Another way was to help the individuals ground themselves with nature. And that was through walks, through gardening, through exercise, outdoor exercise. We also use very affirming words, right? And to destigmatize a lot of what's associated with tobacco use, right? So rather than say it, you're going to have a smoking break, it's like, let's have a wellness break, or give them alternatives. It's something available for them to pick up instead of picking up a cigarette. We use the rethink your drink, having infused water available for them when they have that oral fixation. Also through therapeutic services, right? Empowering individuals to have, sometimes it's really difficult for individuals to express themselves vocally, verbally, right? But throughout, it's amazing. All these individuals just become these expressive, amazing artists where they put together beautiful pieces of their experiences, of how they associate the tobacco use and incorporate it into how it's affected them negatively in their lives, or the big picture as far as how they see their health being improved overall. So that's the approach that we take. And at one of our programs, we had to take a harm reduction approach, right? Where we meet the individual where they're at and making sure that it's a person-centered approach, that we educate them, that we support them, and through a treatment approach, give them the resources that are available to them for them to access. And it's always, it's the opportunity to connect with these individuals, give them the skills to be able to use in the future. And I always tell them, we equip you with the tools that you'll need to make better decisions, but it's ultimately up to you to make that decision. So that's how we incorporated the overall wellness with exercise, we bought equipment, having it available for them outdoors. We also purchased a grill so that we could do more outdoor grilling, utilize the citrus fruits that were growing on the property, pulling those natural herbs that they're growing in their herb garden to season a lot of the food. So it was just a matter of, we offer the residential treatment services in the least restrictive environment. And teaching them that when they transition back into the community, all the lived skill set that we introduce them to or just reinforce can easily be transferred once they go back into the community. So that was our approach, and it gave us a great opportunity to really connect with the patients and have our smoking cessation groups, process. Our clinician was the one that would host the groups and really empower the individuals to make those changes.
Great, that's wonderful. I know our time is running a little bit short, but just wanted to put that out there. I know formerly the California Smokers Helpline has become Kick It California, and I'm curious with Arlene and Auda, I know it can be really challenging. Oftentimes agencies do not have enough staff sometimes to really run every program you'd like to run. I'm curious to hear from either of you if you were able to utilize Kick It California services, or I know Auda, you spoke a little bit from the community partner. So we might want to give folks here a little idea of who's able to really help out in this situation.
Sure. So we utilize, the hotline, right? The Kick It California. We've had their director provide education to personnel. It's easily accessible. They have they have apps. They have the nicotine replacement therapy available to the individual. They have support calls. But not only are we able to utilize their services, but we also have our medication assisted treatment on site. So, internally, we just happen to have a department that offers that, and we include nicotine replacement therapy. But Kick It California has been a great partner. Their director is always open to providing education. No issue with accessing the hotline at all.
Great. And Auda, could you just chime in as well?
Yes, so La Familia has many programs, is very rich in resources. And we actually have a program called Basta. And so they are, it's a program that educates different programs on how to use Kick It California. So definitely we took advantage of that resource. And we partnered with our local hospital and their bridge, it's called the Bridge Clinic, and they do mat services. So, you know, as if we did early, as soon as they, almost as soon as they walked in the door, we did an assessment. We talked to them about this is a smoke-free place, and then we would educate the client about mat services and the NRTs, and some of them were open to it. Also, you know, we were also educated on how to chew the gum properly. So that was a lot of success because they didn't know how to. And so that when we would teach them, that was something that they, that it started to work for them, and instead of rejecting the NRT. So, but like I've shared, we did a lot of partnerships with medical centers like Lifelong, the Bridge Clinic with Highland Hospital, in our own agency with the Basta program for Alameda County.
Great, that's a really good help. I want to thank you guys so much for the wonderful work that you are doing. You're all in different stages of this process and have a lot to add. I just wanted to mention briefly, you know, we will make available our toolkit for cessation and taking organizations tobacco-free. So, you know, feel free to follow up with myself or Catherine. We're happy to talk with anybody who is interested in starting this process and maybe unsure of how to go forward. We've got some great steps for you to follow. It's not an easy process, but it can definitely be done. So I think our guest speaker hasn't quite joined, but maybe I'll have folks round it out.
I'm sorry,
Veronica.
I'm sorry. Catherine asked if we could address, let me roll back to it. If possibly Arlene and Auda can share how they utilize the Office of Problem Gambling and Nutrition Education, Obesity, and Prevention Services to strengthen their wellness activities and help sustain their cessation efforts.
So definitely, you know, part of the partnerships and the connections that we made through this particular program was with the Office of Problem Gambling. And we're like, what does this have to do with smoking cessation, right? And then like that, you know, we blew out the candle and turned on the light bulb. Was like, oh, you know, smoking is always allowed at the casinos, one thing, right? Two is, you know, gambling is an addiction. And so we were able to provide that education to the individuals as well. Use a screening tool to not only, you know, screen for substance use disorders, but also for gambling addiction, right? And address that with the individuals as well. As far as the nutrition, education, abuse, and prevention services, once again, it was just about, you know, having health, more of a healthful proportion as far as foods were concerned, incorporating more natural foods such as raw vegetables, fruits, lean proteins, more exercise, and making sure that the individuals are educated to be able to make better choices.
Great. I like how you talked about that, Arlene, in terms of things being a holistic process. So, you know, while we might want to go tunnel vision and really focus on the cessation piece, I think there are so many other linkages. And I know the work that you are doing is amazing, and I hope to hear about the work that you will be doing, Veronica. I know you have a population that definitely has a lot of their own struggles, but being able to address this, I think, will make a huge difference in terms of people's overall health and well-being. So I see we're, I think, just about wrapping up, but it does look like we have one more question from the audience, and they want to know how to ensure that harm reduction work also includes the provision of NRT. I know sometimes that has been an issue for folks who are working on this, not knowing how to provide that in their budget. But maybe if Auda, you can speak really briefly to NRT in your program.
Yes, so our agency they help us purchase nicotine gum that we have available for the clients. And I partner with Lifelong Medical Center also, and I applied for, they gifted us a bunch of NRT for all of our programs, not just El Chante, for our outpatient and our youth program. So, I guess just hearing opportunities and talking to them often, they tell me of the different opportunities there is to get NRT. And also the Bridge Clinic, being able to enroll our clients in Medi-Cal fast and applying for Alameda County has medical insurance for undocumented participants. It's called Health Pack. And so being able to enroll them probably on their first day, we're able to get those medications for them when they're prescribed by their doctor. And using GoodRx also. So we try to use all of our resources available for our clients.
Great. So I think just that, I know we're running short on time, but to wrap it up, what I hear from everybody, from Veronica, Arlene, as well as Auda, are kind of three main pieces or takeaways. I think one of them is really looking at the issue of health equity, making sure that we are meeting people where they're at and offering them appropriate services. Education is a huge key. A lot of people don't necessarily know what we know, don't know about the harms of smoking, or don't understand how it's important in the scheme of dealing with other addictions. So I would say that was a big piece. And the last thing I would say is really making sure you take advantage of your partnerships. So I would have just talked really about, grant opportunities, about how to purchase NRT. We've worked with organizations that have, gotten gym equipment donated or any kind of thing. So reach out into your community. It's ripe with opportunity. You guys have some great connections. Make sure to utilize those connections. So those would be my parting words. Thank you so much, Norma, and thank you to everybody on the panel. This was a really rich discussion.
Thank you, panel. I'm a little biased. I'm from the community, and I always love this panel, getting the information from the, folks with the boots on the ground. We are really interested and appreciative of all the research information that we get. And this piece is really important to folks who want to implement what the researchers have told us works. And thank you for taking the time. I know y'all busy out there in the real world, so thanks again. And we have a short break until 2:25, when we will have Dr. Brian Hurley, who's the Director of Addictions Medicine at our Substance Abuse Prevention and Control, our county office that oversees the substance use disorder services in Los Angeles. So
there's a couple questions in the chat.
Okay, do we?
And also, you said 2:25. It's okay. 12:25. Everything's all set. Great. So we'll come back at 12:25.
Yes. Thank you all. See you in a bit.
It seems like it's going really well, Norma.
Oh, everything has just been wonderful this morning. A lot of new information even.
That's great. So I'm going to go ahead and do this.
Okay, set up.
I think we got a lot of great ideas for the grants. Catherine, can we build in some of these things on wellness and gardening and exercise and meditation into the grants?
Sounds like a good idea.
Right.
And then Norma, you want me to stop at 1:25?
We have, let's see, if we come back on time. Yeah, 1:25. If you can do that. I know you got 8 hours worth of information to push into that time,
but you also know that the information that I give can expand or contract to meet
yes,
the space allotted.
Yes, I do.
All right, I'm gonna see you in 6 minutes.
Okie dokie.
Norma, don't forget to unpin.
Thank you. Yes, I did forget. And I'm kind of flying solo right now, so I appreciate whatever you think might be helpful for me. Go ahead and chat it out. I appreciate that.
Hey Norma, it's Tasha. I just switched the account, so I didn't log off at all, but I just logged off one account on another one. So this is the one that I'm gonna be using.
Okay, hold on. I can't see you. Hold on just a minute. Let me finish these unpinnings. I think that's it.
They're all done. I didn't realize I actually had access, so I went in and did it for you.
Oh, yes, co-host, you do get to do a lot of things. That's great. That's great. Okay, Tasha, let me see who you are. Okay. Oh, I think maybe you came back on automatically as co-host. I'm way down at the bottom. Just a second. Yes, here you are. And you are co-host now. Okay.
Thank you.
All righty.
All right, see you.
Okay, I'm gonna step away for a couple minutes.
This is the right talk, right, Norma?
Yes, and
All
we're
right, cool.
back. Yes, conversations about change. And I'm going to turn it over to Dr. Hurley. If you just give a little snippet of who you are. I know you probably got about a 30-page resume, so I'm not going to try to handle all those titles and whatnot. You can do it quickly.
Yeah, sounds good. So I'm Brian Hurley. I am an addiction psychiatrist, and I work as the medical director of the Division of Substance Abuse Prevention and Control, LA County Department of Public Health. This is a talk about how we talk with people about change. I'm planning to stop at roughly 1:25. I don't have any financial conflicts. I am the president-elect of the American Society of Addiction Medicine, and ASAM runs a motivational interviewing course. They're actually running a motivational interviewing course today. One of the reasons I have not been here more of the day is that I'm running that course. But I'm here to talk about conversations about change. And so the topics and ASAM, I'm likely to be biased towards ASAM. I'm not going to try to sell you anything. I'm not going to ask you to pay anything necessarily, but so it's not a financial conflict, but it's something I should disclose. So here's my ASAM disclosure. All right. So on completion, we'll talk about applying the spirit of motivational interviewing when working with people ambivalent, that is, feeling two ways about change. We're here as part of a smoking treatment symposium, but actually this could be anything. This could be weight loss, medication adherence, going to see the doctor. This could be finally signing up for that, gym. It could be anything, right? Any particular change behavior. There's 4 meta processes in motivational interviewing. And the strategy is to identify and selectively reinforce change talk that we've evoked from somebody in conversation. And then in an hour where, I can introduce you to some of the concepts, but really I would want to point you towards other training opportunities. I regret this is interactive, so I'm going to ask you to respond to me. What do you already know about motivational interviewing?
Chat to us. Put it in the chat.
Oh. Norma, I'm having trouble seeing the chat right now. Is there anything in there?
I was reading everything while I was on mute, but it says he listened.
Right, here, hold on. Oh, there we go. There we go. Here, I'm gonna move this over here. I'm gonna move this. There we go. Oh yeah, okay. Yeah, the 5 A's. The 5 A's can be consistent with motivational interviewing. It's a little heavy on assessment. Evoking change talk, that's right, Emily. Open-ended questions are part of it. It works if the facilitator is properly trained. Yeah, what is the right term? Fidelity to motivational interviewing is important. It's a conversation about change. It's patient-centered, client-centered. It was developed by Rolnick and Miller. That's right. And it's a way to dance and not wrestle with the client. Excellent, excellent, excellent. What do you want to know about motivational interviewing?
Feel free to put it in the chat. What else do you want to know about motivational interviewing? Those of you who may already be familiar or not.
Is there anything you want to know? Yeah. Oh, so Victoria says, anything. How to convince fellow providers to learn, practice, and use it. How to evoke change talk from people around MI. Yeah. How do we evaluate its effectiveness? I have some specific ideas about that. All right. So if I don't touch Anya, Victoria, and Lauren, if I don't touch on these things by the end, please hold me to account. Selena says, how do I help a client who provides very little information? Yeah. When somebody is actually providing very little of anything, change, sustain, or otherwise talk, how do you support engagement? What's truly motivating? All right. What else, if anything, should we cover today? I asked, what do you already know? about motivational interviewing, to which you said, we can follow the 5 A's. It's about evoking change talk. It's an open-ended process. Fidelity is important. It's a conversation and client-centered approach. Yep. You're interested in knowing how to evoke readiness to change from other clinicians and other practitioners. Anything? How do we evaluate its effectiveness? How do we help somebody who provides very little participation? What's truly motivating? And you want to do a role play. Okay. Starting conversations with people who are starting at a place of unreadiness. All right. So the next part of this talk is interactive. Please, for those of you who are able, please stand up. I'm at a standing desk. I'm already standing. So for those of you who aren't standing, please stand up. Give you a moment to stand. All right, assuming you're standing. Cross your arms. Just cross them. And notice which arm do you have on the top? Which arm do you have on the bottom? You know, this one. So just notice which one you have on the top and which one you have on the bottom. So you're standing and you have your arms crossed. Now I'm going to ask you to do something difficult. What I'd like you to do is uncross your arms and cross them the other way. Take the arm that was on the top and now put it on the bottom. Take the number that was on the bottom, put it on the top, and cross them the other way. Sit with that for a moment. Now, as you cross your arms, now cross them the way you don't usually cross them. All right, sit with that for a moment. Question. On a scale of 0 to 10, 0 being not at all, 10 being maximal, how motivated are you to cross your arms this other way? I don't mean the first way. I mean, when you uncrossed and recrossed the other way, how motivated are you on a scale of 0 to 10, 0 being not at all, 10 being maximal, to cross your arms the other way from this point forward? All right, so we have 0, 0, 0, 3, 0, 0, 0, 0, 0, 0, 0, 0. So the modal response is going 0. Oh, we got a 2, we got a 3, but I'm going to say the modal response, or the most common response we got was 0. We're going to say that the motivation was low. So let me persuade you to open your mind. Let me persuade you that if you cross your arms the other way, it increases your flexibility. In fact, imparts important health benefits. In fact, I'll offer you $100 if you agree to cross your arms the other way from this point forward. On a scale of 0 to 10, 0 being not at all, 10 being maximal, how motivated are you to cross your arms the other way from this point forward now that you've heard my persuasive speech? All right, so some of you already grows on you. Thank you, Diane. So 10, 10, 10, 10, 10, 8, 10, 10, 8, 5, 3, 4, 10. So I think we're now at modal 10. So we went from not motivated to now very motivated. Fabulous. It just so happens that I have a doctorate degree in hand crossing. I am an expert. So I will not only persuade you to cross your arms the other way, I will tell you how to do it. What we're going to do is we're going to set up on the Jew campus a crossing the arm station where we're going to install reminder tacks on your elbow so that when you cross your arms the usual way, your elbow will give you a reminder that you actually should be crossing them the other way, right? It's a reminder tack to make sure that, you know, if you were to cross your arms the first way, now that I've persuaded you to cross your arms the other way, I have the plan, reminder tacks involving tacks and super glue. We'll start the installations next week. How motivated are you, scale 0 to 10, to show up to get your reminder tacks installed? Thank you, Maritza. Thank you, Emily. Okay, we're at a bunch of zeros again, right? I mean, there were interim numbers, there were a bunch of zeros. So I'm confused because this is really important. I talked about benefits. There's really no thinking involved. I mean, that's the thing with the reminder tacks. You don't have to think about them. They're just there. You just do it. It's easy. I've already told you how to do it. I've offered you cash, and if you don't do it, you'll be stiff. Question: what did it feel like when I was talking to you about crossing your arms? What was that like? Yeah. Lauren says, I felt pressured. What else was it like? You felt confused. I knew you were curious. You were entertained. Thank you, Catherine. I tried. You felt uncertain. Yeah. Confused. You were wondering why. Any other reflections? Okay. All right. So we're now going to do a different exercise. I need a volunteer for this one. We're going to do a real play use of motivational interviewing. I will demonstrate. But to do this, I need somebody that, thank you, Sophia, for volunteering. I'll explain it, and then I'll just confirm that you're still okay with it, which is choose something that is true in your life that you want to change, that you need to change, that you should or ought to change. You've been thinking about changing, but you haven't changed yet, and you're comfortable sharing as part of this exercise. You're comfortable like unmuting yourself, you have a microphone, you have a camera, and you're willing to talk about with me as part of this conversation. So if all those things are true, Sophia, are you our volunteer?
Of course. You need my camera on, right?
Yeah, turn your camera on. And then Norma, can we highlight Sophia and myself?
Oh man. Okay, hold on. Where's my camera showing up?
Your camera's perfect. We can see you just fine.
Oh, okay.
Yeah.
But I don't see myself. That's okay, right?
No, you
don't need to
will
see
get it.
Okay. Oh, there it is. There I am.
All right.
Oh, you already did it.
We are
Okay.
spotlit.
Okay.
So everybody, what I want you to do is listen to what I say. I mean, you can listen to Sophia, but for the purpose of exercise, listen to me. What are the questions I ask? What are the reflections I give? And just kind of keep track of what I'm doing in the conversation as an illustration of motivational interviewing. So, and I'm going to ask you at the end, how many questions did I ask? How many reflections did I give? And did you notice me doing any other behaviors? Okay. So, Sophia, I understand, and you're muted, just so you know. There you go. I understand that there is something in your life that you want to change, you need to change, you've been thinking about changing, but you haven't changed yet, and that you're comfortable sharing with me.
You know what, Brian, I feel that I probably would need to change I sometimes have negative thinking, you know, more about like, if it doesn't go as planned, you know, my expectations sometimes get in the way. So I think more of like my negative thinking on results that I've planned.
When you come up with a plan, you're preparing for the worst.
Yes, that's what I've been conditioned to do. Yes, definitely. What is it? Hope for the best, prepare for the worst.
And you'd like to not always be expecting the worst.
I want to stay in the moment. I'm working on staying in the moment.
And these sort of distorted expectations of the future really get you out of the moment. You're not able to maintain a mindfulness of the present moment because of these thoughts.
Yes, that is true.
And it's something you're working to change.
I do. I want to change that.
Tell me more.
I guess when I was growing up, I feel that it was always like, what am I going to do? What am I going to do with my life? What's the purpose of my life? You know, if I find that, I'll be happy. You know, I feel now that I found the purpose of my life, which I'm in human services, you know, now I feel like it's not enough. So it's like always not enough, you know.
You made it to the level where you wanted, now you got what you wanted, and you want more. You want something else. You want something different.
Yes, I wanted to get certified as a substance abuse counselor. That happened. I wanted to finish my bachelor's degree. Okay, that happened. I said I want to get into master's. Now I'm at the master's program. Now I'm already thinking, what if it's PhD?
Mhm.
And
With
it's
all
not
the
even,
success,
yes,
with all of this success, yet you expect the worst.
yes. And it's not even about the money anymore. It's more about this. I don't know. I need to prove this to who? I don't know.
Mhm. One of the things
Myself.
that you're thinking about is who are you proving this to? What is this really about?
I guess to myself, because
Mm-hmm.
everybody accepts me. My family's proud,
Mm-hmm.
you know.
Mm-hmm.
Probably just to get out of the stigma, maybe that, you know, a person of color, you know, we can't get that far, you know. It's like we stay at the high school diploma, if sometimes not even that, you know. I don't know, maybe it's that.
Mm-hmm. You're feeling like there's expectations of you did not do well.
Oh yeah,
Mm-hmm.
definitely.
What are you thinking about doing about these negative thoughts that you have?
Well, I know that I've learned to challenge those negative thoughts and really
Mhm.
just look at the facts. But the thing is, it's easier said than done.
Mhm.
You know, I can teach this in group all day long, and I've gotten better. Don't get me wrong. You know, it's progress, not perfection. But I can teach this all day long. But then when it comes to me doing it, it's like, wait a minute, how am I challenging these thoughts? Rachel, look down at your feet. Where are you right now? It's September 23rd. It's 12:41. You know,
It feels really effortful to be able to actually always be challenging these negative thoughts.
yeah, it is. You know, I think I was worse off. You know what actually helped me, and this is may seem like it's not relative to this, but
Mhm.
my best friend and I took a trip last year, and we decided to take a road trip up to the tip of Nevada, a small town,
Mhm.
population, I don't know, maybe 100. And we decided to go and find UFOs near Area 51. Now,
Mhm.
you may say, well, what's that have to do with it? Well, the thing is, there was no cell service for like the whole trip. So we really just had to like learn how to stay in the moment and really just cherish each other's company and not be on the devices, you know. And I learned how to dine. And what that means is I learned how to sit down and savor my food, which is, I think, a sense of a tool of mindfulness, right? You savor your food, you know, and that definitely has helped me a lot to really just stay in the moment and challenge those thoughts of like the future.
I have
You
some
know.
ideas. Would it be okay if I shared my ideas with you?
Of course, go ahead.
There's this dichotomy in your life between your professional pursuits, and yet the thing that helps you in the moment is when you're away from your phone and from your distraction. And the work, you know, in the moment while you're working, to then always be challenging your automatic negative thoughts is in fact making more work for you in the moment. And so maybe one of the strategies is to build time out of work to be able to build rest, so that when you are at work, you have a stronger battery, metaphorically speaking, to be
Yes.
able to be present. But
Yes.
what do you think? What do you think about that?
No, I think it's definitely true. It's kind of, I guess, would that be ironic that I have to get away in order to learn to be present in my daily life?
Seems actually quite logical.
Logical, right?
Yeah.
Since that trip, I'm pro taking vacations. because it's not for selfish reasons. It's for self-care and mindfulness and learning how to stay in the moment.
And makes you even more effective at work.
Yes, to prevent.
Is it okay if we check in next week to see how you're making use of your off work time to optimize your on work time?
Yes, yes.
All right. Thank you, Zofia, for participating in a real world illustration of motivational interviewing. Thank you, everybody.
This helped better than my therapies.
All right, so we're gonna unspotlight here for a second. All right, cool. So let's debrief. Zofia, what was that like when I was listening to you?
What was it like to? It was great. You know,
So,
a lot of.
Go ahead.
You know, growing up, I was the kid with. I didn't have a very loud voice. You know, it was the time of kids are to be seen, not heard. So I feel like, and then sometimes now I feel that too in a group of friends, you know, until you find one good friend that's able to direct the conversation. So wait, what were you saying, Rachel?
What did I think I said, what does it feel like?
Oh, it feels I'm significant. I'm valid. I matter.
You felt validated and heard.
I felt validated and heard. But the thing is, I don't want to feel like I need to be validated. Like,
I hear you.
You know what I'm saying?
Well, so here's my question actually now to the group, which is, you know, we see patients and clients, and when we have an agenda, you need to stop smoking cigarettes. You need to stop smoking weed. You need to go to treatment. This is what you need to do. And like there's patches, there's gums, there's lozenges, there's the quit line, all of which is important and valuable. Let me be clear. I prescribe meds. I recommend quit lines or helpline. You know, like these resources are valuable, but when it's on my agenda and not on the agenda person I'm talking to, well, what were the words you used? You felt pressured, confused, uncertain. You felt hesitant. You felt like curious about my intentions. If I instead listen and evoke from somebody their ideas, their values, their intentions, what they're thinking, well, what did you say, Zofia? You felt valued, you felt validated, you felt heard, you felt listened to. And ironically, you know, for the first exercise, I did most of the talking. In fact, I did all of the talking. You were muted. I did all of the speaking, and you chatted in some stuff. I got information, but it wasn't it wasn't like an extensive conversation. Whereas the second one, Zofia, you did most of the talking. Most of the space was filled with you. So which patient would you rather be working with? A patient that felt uncertain, worried, skeptical, or a patient that felt heard? Obviously, you want to be with the patient that feel heard. Ironically, motivational interviewing, where we spend the time to evoke from our patients their ideas and their values, their intentions, is like we control. Not control, we influence. That's probably the better way of putting it. We influence that interaction. All right, so let's get into the technique of motivational interviewing. Thank you, Zofia, again, for your participation. So what is motivational interviewing? Motivational interviewing is defined as a collaborative conversation style that arranges conversations so that people talk themselves into change based on their values and interests. What that means is just by having a motivational interview does not mean someone's going to change. Right? It means that to whatever extent people value or are interested in change, that's the basis of the change, which means people are not ready to have a conversation around tobacco product use, then doesn't mean they're going to change. But motivational interviewing structures the conversation to maximize the capitalization, right? The engagement on whatever ambivalence exists. Hold on. I may not have done this right. Give me one more second. Oh, there we go. Yeah, I think I did this right. Here's a quick video illustrating this point.
Denial and resistance in people, if you think about that I went through, is not a property of the pathology of the individual, okay, but says something about the relationship. My 15-year-old lies to me consistently, but not to his best friend. Do you see the point? Yeah, okay, so, but you know what I'm saying. You've got to be very careful. And what Miller and I shared then and now is that if you shift your style, this is the basic observation, the motivation to change improves in front of your eyes. And that shift in style is not just a technical matter, it's your attitude towards this person. And so associated with that style shift is a whole lot of things that you saw in Conversation B, which we'll have a look at in a moment, again. But I think which can be captured by this. Try not to judge, try not to blame, try not to label the person. Try and be respectful, reflective, as your colleagues have said. And the motivation to change can come from within them. They have the energy and the motivation and the good sense to change inside them, and much of the capacity and skills to make change happen if you give them the space to do that. And that's a very different approach to what I saw in that addiction treatment unit, and Miller had noticed in addiction treatment settings in the United States, where his stories were the equivalent of mine. I mean, there were some stories that he told me and still tells me that truly make me shocked.
Change is natural. It occurs all the time, and treatment and interactions can facilitate the change process. It occurs all the time, but it means shifting rather than suggesting, well, you know, why would you still want to smoke? Don't you know it's bad for you? Don't you understand the risks? It's, you're still smoking. Tell me more about that. What does smoking do for you? What are you worried about? Right? You're evoking and understanding the ambivalence. And it means, rather than saying, well, this person's pre-contemplative, which is another way of saying unmotivated. So, well, people are motivated for something. Rather than saying, why isn't this person motivated? It's, well, what is this person motivated? What does this person want? We've talked about change talk, but just for anyone that doesn't know, the definition of change talk is self-motivating statements. It's the things that people say in the direction of positive change. I could cut down my smoking. I could smoke less. I could start taking that medication for smoking and call that helpline or the quit line. The more we get it, the more we talk ourselves into things or out of things, depending on what the change is. This is what the empirical, if you're looking to study the impact of motivational interviewing, it's on this, change talk. You're listening for and evoking the change talk, and that's associated with actual patient behavior, is change talk, and it's what the patients say. It's not what we as interviewers say. It's what the patient says that seems to track empirically with behavior. So sane talk is just, I can't, I won't, I'm not ready, I'm not interested, no. You know, it's statements against, like, I love smoking, I want to smoke more, I don't intend to ever stop. You know, it's all sustained talk. And the more of that we get, the more someone's likely to continue the status quo. Motivational interviewing, and I did a lot of listening, but just to be clear, like, it's not, I wasn't like directing, right? I wasn't persuading, but I wasn't entirely following either. Like, I had a strategy. I was looking to evoke. I had an idea of where I wanted to head during this interview. And motivational interviewing is not entirely a following style, but it's not a directive style. It's a guiding style, right? You're pointing a direction, but the person you're talking to, the interviewee is the one who's walking. Part of motivational interviewing is maintaining a spirit. And the spirit of motivational interviewing is the spirit of compassion, acceptance, partnership, and evocation. This is, just to be clear, if we don't have compassion for the people we're talking to, you can use motivational interviewing to be manipulative. And if you've ever been to a used car lot and talked to a salesperson, they're very good. They accept that you could walk away from a sale at any time. They can accept, you know, they're very good at, hey, good to see you, friend, and getting people to talk about yourself. It's really compassion that separates motivational interviewing from manipulation or sales. The other, I guess, operational definition is motivational interviewing is like dancing. The interviewee says something, you say something, and you say something kind of in a different direction. It moves the conversation. It's like when you're leading in a dance. This is different than wrestling. You need to quit smoking, but I'm not ready to quit smoking, but it's bad for you. I don't care about that. It costs too much. I can afford it, right? Like, if you're ever in this you're saying something, a patient's saying something back, and you're pushing, and they're pushing back harder, that's a wrestling match. If you find yourself doing that, you're not doing motivational interviewing. Motivational interviewing is you get on the patient's page or the client's page, your interviewee's page, about what they're thinking, their ideas, their ambivalence, their values, and using reflective listening to guide. Here's a video. Here's a video about empathy that kind of captures a bit about the spirit of motivational interviewing.
So what is empathy, and why is it very different than sympathy? Empathy fuels connection. Sympathy drives disconnection. Empathy, it's very interesting. Teresa Wiseman is a nursing scholar who studied professions, very diverse professions where empathy is relevant, and came up with 4 qualities of empathy. Perspective taking, the ability to take the perspective of another person or recognize their perspective as their truth. Staying out of judgment, not easy when you enjoy it as much as most of us do. Recognizing emotion in other people and then communicating that. Empathy is feeling with people. And to me, I always think of empathy as this kind of sacred space when someone's kind of in a deep hole and they shout out from the bottom and they say, I'm stuck, it's dark, I'm overwhelmed. And then we look and we say, hey, you climb down. I know what it's like down here, and you're not alone. Sympathy is, ooh, it's bad, no, you want a sandwich? Empathy is a choice, and it's a vulnerable choice, because in order to connect with you, I have to connect with something in myself that knows that feeling. Rarely, if ever, does an empathic response begin with "at least." Yeah. And we do it all the time. Because you know what? Someone just shared something with us that's incredibly painful, and we're trying to silver lining it. I don't think that's a verb, but I'm using it as one. We're trying to put the silver lining around it. So, I had a miscarriage. Oh, at least you know you can get pregnant. I think my marriage is falling apart. At least you have a marriage. John's getting kicked out of school. At least Sarah is an A student. But one of the things we do sometimes in the face of very difficult conversations is we try to make things better. If I share something with you that's very difficult, I'd rather you say, I don't even know what to say right now, I'm just so glad you told me. Because the truth is, rarely can a response make something better. What makes something better is connection.
Before I move on, any reflections on the video? And sorry if it's out of focus. I get the classic, like, your system is slow or whatever. So sorry about that. We'll try to close some windows. Any reflections on the video?
I just like the way that she explains that.
Yeah. Yeah, it's a powerful explanation, and they are different, but the empathetic response, being with somebody as opposed to being over them, or, oh wow, that sounds awful, right? Like sort of in a praise position, is just, it's really important. You know what I mean? And I think she illustrates that in a way that is so beautiful and so helpful. So anyway, one question: what do you do about settings where somebody's not talking, right? So the first step in any motivational interview is engagement. Are we talking to each other? It's critical. You can't do other motivational interviewing without engaging somebody. And this is where, like with adolescents or with other folks, Mark and Norma, you can highlight Brene Brown empathy is good. I mean, I can find the link, but and actually in the slide deck, I think I included the URL. So that's where you can find it, or you can do it in answers. But anyway, you have to maintain a connection with someone. Shall we walk together? Are we walking together? And only then do you come up with a shared area of focus. So when I'm working with folks, adolescents, people with cognitive impairments, people that don't have a lot of, they're not a lot of verbal production. I spend a lot of time asking permission. Any thoughts about how I can help? Nope. Yeah. No ideas about how you got here, huh? Mm-mm. I have some ideas. Is it okay if I share? Sure. And then I might say some things about what I think is true and see if it inspires any reaction. But I'm spending basically my time being like, are we actually having a conversation together? And so just probing from different sides, rather than jumping ahead to like, okay, we're here to talk about your smoking. And then let me evoke a bunch of change shock and get right to the plan, right? That's the kind of the stepwise process. If someone said, if I'm not doing the dance, I don't get to focusing, right? I don't even get to pick the topic we're going to talk about because I'm busy orienting myself. And this, I used to work in the jail. This happened all the time, right? I would be assigned to go see somebody that needed to see psych. They would, I'd go up and have their blanket over them. I would knock. They're breathing. I know they're alive, but they're no response. And they're just furious about the fact that they're incarcerated. They don't want to talk to anybody. So, I remind them they don't have to, right? I emphasize autonomy. It's up to you whether you want to talk to me or not. I'm here for you when you're ready. Here's how to make the request, right? Like, just make it clear I'm here. I'm not judging. I'm not yelling. I'm not arguing. And then try again when I can. But once you have engagement, ideally, when you have somebody actually talking to you, then you get to focusing. We agree on a shared topic. Is smoking something that you're willing to talk about? Then evoking, what do you like about smoking? What don't you like about smoking? And then potentially get to planning. Now it's stepwise, right? You have to do engaging to focus to evoke, evoking, to planning. And as clinicians, or I'm a clinician, it's so easy to go, oh, you smoke, here's some nicotine patches, and call the 1-800 Kiki California, right? The Kiki California number. I was calling it Novas, but no, it's Kiki California now. So get right to the plan before you're well ahead of somebody's ideas and their intentions and their readiness. But we're always evoking. Evoking is actually part of engagement as well. And we can always test the water. You think you're ready to put together a plan on this? And it's the confluence of the engaging, focusing, evoking, and planning that defines motivational. Anyway, let's see. So I'm going to skip this next video. And what I don't mean to imply is that you have to spend all your time reflecting. Like, you can give information. And I actually illustrated this by asking, oh, thank you, Elizabeth, how to give information advice. You ask permission. I have some ideas about this. Is it okay if I share my ideas? Or you can say, what do you already know? There's a lot of people with tobacco use disorder. And you say, what do you already know? Well, I know that there's 5 forms of nicotine replacement therapy and 2 pills I could take, one called varenicline and the other called bupropion. You'll be surprised. And it can save you some time of needing to go through that if you already know what they know. Then you give a limited amount of clear, of information in clear language that's focused on what you see as like the core issue. And then say, so what do you think? What do you think what I just said? What do you think you'll do? Or, just so I was clear, can you teach me back what I just told you? And now you're getting the patient to verbalize the things that that you said. And they're much more likely. People are much more persuaded by the things that they hear themselves say. Okay, so the core skills, motivational interviewing, you heard me do some of this, open-ended questions, affirmations, reflections, summaries, and then informing and advising with advice or with permission. I'm not going to go into open-ended questions more than to say they are questions that can't be answered with a yes, no, or one-word answer. Affirmations are a very particular type of reflection, and it's important. Affirmations generally start with you and generally speak to something intrinsic. So rather than saying, like, I like the way you handled that customer, you could say, you take great pride in your work. Right? Affirmations go a little deeper. Rather than say, wow, that was a whole maelstrom. You made it. You might say, you're somebody that's steady in the face of chaos. Right? Affirmations, they speak a little more fundamental to somebody's capacities. Simple reflections, where you just repeat back to somebody what they say. Somebody says to you, I'm never going to give up smoking. You say you're never going to give up smoking. It's, you just literally repeat that. But the key and motivation on interviewing these complex reflections where you're making a guess about what might be true. Somebody says, well, I can't give up smoking. You might say, you're not ready to give up, but you're ready to do something. You're now using a reflection, right? It's not a question. You're not saying, what are you ready to do? It's you're ready to do something, which is a reflective statement in the direction of some action. And that reflective statement in the direction of some action can get the person to be talking about what they're ready to do without you asking a question, because questions are about your agenda. Reflections are about the patient's agenda. You can also reflect the feeling. You can use a metaphor. You can do something called continuing the paragraph, where you make a guess about what might be true for somebody. You can use an amplified reflection. One example of that would be to say, well, you're never going to stop smoking. Not because you want that to be true, but because you want the patient to say, no, I'm going to stop, right? To interrupt and defend. And then double-sided reflections. On one hand, you like the relaxation of smoking, but on the other hand, you don't like the health risk, you don't like the staining of your teeth, and you don't like the way it makes you smell, right? So reflecting the sustain talk and then the change talk. The way to think about it is if a patient makes a statement or a client makes a statement, what they say is on the surface, and you can just reflect that, but there's all of the stuff underneath: thoughts, emotions, beliefs, values, and those are all things that you can reflect using a complex reflection. So for example, somebody says, smoking is making me feel is making me feel worse now, right? It used to make me feel better, but it's not making me feel better the way it used to. I feel worse now. So you might say, well, smoking makes you feel worse now. Or you'd say, so you find that smoking is no longer helping you to feel better the way it used to. Or in the past, smoking helped you feel better. Now it makes matters worse. Right? In the past, smoking helped you feel better. Now it makes matters worse. That's a double-sided reflection. And then continuing the paragraph, and you want to find some way to feel better instead of smoking. Right? Double-sided reflection into continuing the paragraph. That's a way of moving the conversation forward without questions, but rather using reflective listening. Summaries are where we listen for change talk and then just kind of put it all together in a bow and present it back to somebody. And this is a great way to pivot in a conversation. So if someone's like, yeah, smoking doesn't help me feel better the way it used to. My grandchildren kind of wrinkle their nose when they come up to me because I smell. It's hard for me to walk up the stairs now without huffing and puffing, and cigarettes are getting so expensive. You might say, smoking used to help you feel better, but now, it's your grandchildren are recoiling. You're worried about your health and you're worried about your finances. So what do you think you're going to do? Right? It's a way of pivoting from that evocative process into the planning process, where you selectively summarize change talk. This is a great video. It's super fun, but we're not going to watch it, unfortunately. Change talk. Change talk, it goes by the acronym DARN CATS: Desire, Ability, Reasons, Need. That's the DARN. CATS is commitment, activation, taking steps. So desire, I wish I would stop smoking. I could cut down a little bit. If I stop smoking, my kids, would come visit more often. Or if I stop smoking, I'd have more money to be able to do X, Y, or Z. Or I gotta stop. And I'll tell you, I have yet to see a patient that loves everything about smoking. Not everyone's ready to quit, but a lot of patients are like, yeah, I really should cut down, right? That's in the DARN, the desirability, got reasons to. And the commitment, I've decided to stop. I'm preparing to. I went out and got the prescription for nicotine replacement therapy, the patches or gums, or, I called the Kick It California site, taking steps. Many of us are familiar with Protaskity Clemente, pre-contemplation, contemplation, preparation, action. And the MI Hill is sort of listening for preparatory change talk, this desire, ability, reasons, need, and then trying to evolve the conversation using reflective listening into commitment, activation, and taking steps. And how do we get change talk? Well, we ask questions that evoke it. We can use the readiness ruler. I use this actually for our persuasion exercise on a scale of 0 to 10. How important would you say it is for you to make this change? But that's only one half of the readiness ruler. The other half of the readiness ruler is on a scale of 0 to 10, how confident are you that you could make this change? Decisional balance, pros and cons of change, pros and cons are staying the same, like a 2x2 table. You can ask for elaboration. Tell me more about that. Was something I illustrated during our real play. Query extremes. It doesn't sound like you're ever going to quit smoking. You love everything about smoking. Those are amplified reflections designed to evoke from somebody, oh no, I will plan, I don't plan to smoke forever. Or, well, I don't love everything about smoking, right? It's a way of evoking change talk. Looking back when you weren't smoking, how did you do that? Or looking back when you quit for a while, how did you do that? Looking forward, if you were to stop smoking, what would that look like? So those are ways of trying to evoke change talk and exploring goals and values. So I mentioned this earlier, the importance ruler, again, 0 to 10, how important it is if you to change, smoking would be a perfectly reasonable change target. And then the confidence ruler, how confident are you can make this change? And when you get it, you elaborate it, you affirm it, you reflect it, you summarize it, you spend a lot of time engaging. And when you get sustained talk, right? Sustained talk is the opposite of change talk, right? It's directed against the direction of positive change, right? I want to smoke more. I'm not going to quit. I'm not ready. Those are all sustained talk. You generally ignore it. You don't argue with it. You don't amplify it. You don't reflect it. You're like, okay. All right. So what happens if somebody doesn't give you reasons to change, right? They give you sustained talk. You don't amplify it. And then, the general default strategy would be to just do a simple reflection, right? Somebody gives you sustained talk. You don't understand me, right? There's discord in the relationship. You say, you're concerned I don't understand you. It registers to them that they heard what you had to say. You could do an amplified reflection. You don't want to talk to me anymore. You're never going to talk to me again or something like that. Double-sided reflection. On one hand, you really like this. On the other hand, you don't. You can come alongside. I get it. I get that you like smoking. I'm not agreeing with your smoking, but I get that you like it. Or reframing. Smoking is really helpful to you. And if you could find something else that would help, you consider smoking less, right? It's sort of reframing. Agreeing with the twist, running head start, which is, okay, tell me everything you like about smoking. A to Z, like give it all to me, with the idea of then you understand the lay of the land and you understand where somebody might have some ambivalences that you could explore. And I always emphasize autonomy, and I don't control whether you smoke or not. You clearly are able to go do that. Here is a summary slide that goes over some of the core features of motivation and interviewing. So PACE, partnership, acceptance, compassion, evocation. Sorry, I have my camera on wrong. Engaging, focusing, evoking, planning, and then ORS, using your ears and using the readiness ruler. So the importance ruler, competence ruler, and then negotiating a plan. MI is demonstrated to be sort of effective across cultures. And there's increased effect sizes in studies with priority minority populations. The evidence really is that fidelity makes a big difference. So I think the comment earlier on the training is really important. Yes, fidelity makes a big difference. I know we skipped past one of the videos. I actually am thinking that we might get back to it. And this is a video about engagement. So we'll watch the video and then debrief.
It's just, there's all this pressure, and sometimes it feels like it's right up on me and I can just feel it, like literally feel it in my head, and it's relentless. And I don't know if it's going to stop. I mean, that's the thing that scares me the most, is that I don't know if it's ever going to stop.
Yeah. Well, you do have a nail in your head.
It is not about the nail.
Are you sure? Because, I'll bet if we got that out of there...
Stop trying to fix it.
No, I'm not trying to fix it. I'm just pointing out that maybe the nail is causing...
You always do this. You always try to fix things when what I really need is for you to just listen.
Yeah, see, I don't think that is what you need. I think what you need is to get the nail out.
See, you're not even listening now.
Okay, fine. I will listen. Fine.
It's just... Sometimes it's like there's this achy... I don't know what it is. And I'm not sleeping very well at all. And all my sweaters are snagged. All of them.
Yeah, that sounds really hard.
It is. Thank you. Ow!
Oh, come on. Ow. If you would just...
Don't...
Try to see things my way. What does this have to do with motivational interviewing? Thank you, Sophia. That's right. The writing reflex, right? We oftentimes pull to fix things, right? And we forget that the most important step in motivational interviewing is engaging, right? If we're not engaged and we're too busy getting to planning, we're too busy fixing things, we're gonna miss key opportunities to actually, like someone's gonna say, you're not listening, you don't understand. Even if you do, unless the person you're talking to really hears you. Yeah, validation. And you said roll with resistance. The new term from Miller and Rolnick is to dance with discord. Don't forget to dance. Roll with resistance is alliterative, dance with discord is alliterative. But yeah, getting to the real issue. She just needed to be heard, right? And once she has that, that can become the platform for, is it okay if we talk about the nail? Are there things that are on your agenda we could talk about, like sweaters or otherwise? And if so, can we evoke about what we might do, right? That doing that work before we get to planning substantially increases the chances that you're going to get to a plan that the person you're working with is going to adhere to. All right. So here's a review. Don't skip engagement, right? It's so tempting. I see an issue. It's so clear to me what needs to be done. This person just needs to stop drinking. They just need to stop smoking. If they just called KK California, if they just took some meds for smoking treatment, right? If they just, so we see it so clearly, but if the patient's not there with us, doesn't matter how clear our vision is if they're not on board. I do want to acknowledge Bill Miller and Steve Rolnick, who developed motivational interviewing. My patients have been my best teachers on this. And CSAM is going to be in San Diego, August 23rd. So if you want to come to the California Society of Addiction Medicine Conference, highly recommend it. ASAM is going to be in DC, Southern Maryland, actually, April of 2023. And then the Addiction Psychiatry Conference is going to be in Florida in December 2022. We have some time. What questions do you have? Oh, thank you, Victoria. And thank you, Emily. Thank you, Anya. What questions do you have is open-ended. Do you have any questions is closed-ended. And it actually depends on whether I want questions or not. If I don't want questions, I'll say, do you have any questions? Because it's a closing move as opposed to an opening move. Yeah, so motivational interviewing in groups, because in a one-on-one interaction, right, in a dyad, the interviewer in some ways frames the interview, and in groups, there's multiple drivers of it. There's a whole book on this, motivational interviewing in groups, that that I would recommend. What it involves is the group leader modeling motivational interviewing. And it oftentimes means them assertively inserting reflections during a conversation that an ordinary process group leader would just sort of like let go. But in motivation, you want to, the idea is you're inserting reflections during statements. So the interviewer is spending their time sort of validating and hearing what the group is saying, and that can shift the group towards a less like didactic approach and more towards an evocative approach. How do I help? Oh yes, Anya. How to help other providers use motivational interviewing? Yeah, it would be to motivate. So it would be to motivational interviewing them for sure. What if, imagine a future where health systems, clinicians, where we got paid by the amount of change talk we evoked from our patients, our clients. And so for every time we evoked change talk, we got a payment. And for every time we evoked sustained talk, we didn't. How would that change our clinical practice? First of all of our interviews would be recorded. and they would all be coded in order to be the basis for payment. And everyone would learn motivation interviewing. And those that weren't capable of doing it would be moved out of positions. Like I think of like that would be the most extreme scenario under which I would expect motivation to be widely adopted, is when there's financial penalties, right? Thank you, Mark and Norm. But let's assume we're not going to get to like that level of payment reform, because payment reform is really going to like pay for, you know, financial outcomes, lack of ER visits, lack of hospital admissions, right? That's the thing that tend to drive them. Then yes, we're kind of stuck with motivation anyway. Yvonne wants the URL for the nail, and I think I could find that. Just be a moment. I think I can find that video in just a second. How would they be transferred to the surgery service? So sometimes the interactions we have with patients are really brief, right? And I think that you know, even if they're really brief, they can still be meaningful. Like you could still attend to engagement. You can still, like I find, you know, when I'm in the ER, oftentimes that crisis, you know, I find something to reflect, even if it's only a few sentences in that setting, to evoke from somebody their ideas and values for changing. I just put the link into the video about the nail. Now, many surgery services, the most time they have with the patients when the patient's under anesthesia, there's not a lot of motivational interviewing if there's not a conversation. But I do think that you could, you know, talking to patients takes time. So if you have a limited amount of time, you are pretty focused around like evocative statement, maybe ask for permission, give some information and advice, evoke readiness, ask a key question. Like that may be all the time you have, but it's still going to be motivational interviewing informed, even if it's brief. And yeah, Anya, assuming no change in like the structure of our health system, using motivational interviewing on our colleagues is probably, and you know, demonstrating its effectiveness. Let's see, group settings. How did those that not get on board with MI be transferred to being orthopedic surgeons? I see what you're saying. Yeah. Although orthopedic surgery is not a universally acceptable landing point. Okay. Where to learn more? There's a website called motivationalinterviewing.org that has a lot of videos and resources and training opportunities that I encourage you to check out. There's Motivational Interviewing, the textbook by Millen Rolnick is in its 3rd edition, so that's you can purchase that. There's a whole number of videos. I mean, we could have spent all day doing videos. Are there any other questions? Norm, if I leave you with 2 extra minutes, would that be disruptive to the program?
I don't think so, because I think our next presenter is here and on tap and ready to start sharing her screen. But thank you so very much for taking time out of your busy schedule to be here with us to share.
It's good to see everybody.
Great job, Brian. Thank you so much.
Yeah.
Oh, Bruce said, what would I do about the next steps with a woman with a nail on her head? So just real quick. I'd say, yeah, that sounds really hard. And she would say, you know, oh, thank you. And then like we kiss and she like hits her head, and I would not react in a frustrated way. I would say, yeah, that does sound really hard. What do you think? And I would spend time evoking her ideas about what she's ready for. And then so when I heard ideas that were in the positive direction of change, I would selectively reflect them. So Bruce, I don't know if that helps. That's what I do. All right. Thank you, everyone.
Thank you again. Okay, we have coming up next our esteemed Tasha Dixon, LMFT, who is the facilitator for our Kick-Ash groups that we run with the project. And tell us a little bit more about yourself, Tasha, as you're getting started in the group. Take it away.
Hi, everyone. I'm so happy to be here. Yeah, so I am going to be talking to you all today about helping others. I am a licensed marriage and family therapist, and I am the behavioral health specialist on the TRDRP project in Los Angeles that's going on now. And within that project, one of my roles, my main role, is to help the different sites kind of run a cognitive behavioral therapy group directly specified smoking cessation. So what I'm going to talk to you today is about helping others. And I am going to go through the curriculum a little bit so you can get a chance to see what it's like. And start with the disclaimer. I kind of tend to talk fast. This is a presentation that is hours long that I'm condensing for you. So give me, go ahead and type in your questions in the chat as I've been doing. And then I'll try to leave some room at the end for questions as well. And yeah, so I'm going to share.
Okay, we've got an echo. I'm not sure.
Oh,
yes.
I asked that up front. It's me. I'll change it. Hold on.
Okay. Thank you, Catherine. I was hearing it too, but I didn't know if my ears were playing tricks on me.
Better?
Yes.
Does that sound better? Can you hear an echo still?
Yeah, you just have to talk a little bit louder now.
Okay, so I knew that would happen. Sorry about that. I meant to ask that up front. So I'm gonna go ahead and share my screen. Sorry guys, hold on.
De lejos nomás porque me pusieron una vacuna hoy y me ha caído re mal.
Oh, sí.
2 días jodido.
Ay, ay, ay.
Pero bueno, ya estamos.
Ok. ¿Qué hacemos cuando alguien no hace caso de nada? Ahí está una que no quiere moverse ni para atrás ni para adelante y no nos abre el vidrio.
I'm not sure where that's coming from. Okay, hold on.
Yeah, I think I took care of it.
Okay.
You have a problem sharing? You want me to do it?
No, I got it.
Okay.
Let's try it. Let's see. You may have to do it, but we'll see.
Oh, no. We got it.
Okay. Can you see the slides on the side too, though?
No.
Oh.
Just the normal.
Just the helping people quit slide?
Yes.
No, we can't see
We
the
can
slide.
see the slides.
I can. Oh, what's coming up next, you mean?
Yeah.
I just see her slide and her picture.
Right. Make it in display.
Oh, you mean that way. She meant, was she in presenter mode? She's not in presenter mode. Just go to slideshow.
Yeah, I did that. It won't let me.
Yeah. Oh.
Okay. There it goes. Maybe. thanks for being patient with that. I don't know why I didn't catch that up front. Anyway, so helping people quit is what we're going to talk about today in regards to smoking cessation. And we're going to get a little bit more interpersonal because we're talking about those of us who are really working with people who want to quit and people who aren't sure that they want to quit, but it's possible. And one of the things that why we help people quit is to help them improve quality of life, to increase healthy years of life, and to improve the effect of medications for mental health problems, decrease social isolation, save money by not buying cigarettes, and quitting smoking is a right and is important for recovery. Now, these are just a few reasons why we help people quit, but I want to tap into more of us as the helpers, because we have to come into something within ourselves as to why we help people quit. Is it just your job and that's what you've been assigned to do? Is there some type of connection that you have with smokers or cigarettes or anything within your life that leads you to this? I think that's important to tap into so that you hold on to your motivation in helping people, because helping people quit is one of the hardest things there is. Quitting is one of the hardest things there is to do. And it's not something that we can guarantee. And it's not something we want to tell people like, yeah, we're going to help you quit and you're going to do this. It's a process to help people quit. People quit multiple times and go back to smoking and using tobacco products. And so I want you to understand how much of a journey it is. So being in touch with yourself as a helper is going to be important, because it's not for you to become unmotivated or withdrawn from your clients when you don't see the success they want to see, but just so that you can also reassure them that this is a journey. And so looking at these reasons why we do what we do is important. And these are just a few of the reasons. So again, like I talked about, it's a tobacco-free journey. Understanding, and this is for helpers, understanding your own experience. And so I'm going to do a little share of my experience. You know, when I started this project, I didn't think I had any experience or any type of, not necessarily experience, but not any type of connection to smoking. And it was within this position, and it was within the trainings that I received and working with people that I realized, wait a minute, my mom smoked my whole life. And it's been a journey. I could see her journey through this journey that I'm working in, and seeing how, you know, the level of support from family, how we would say like, oh, it smells, or even as adults, we're cautious about taking our purse in her home because it would smell like, any gift she gave us smell like smoke, and actually making those comments. But also remembering when I was young, all the processes that she went through to try to quit. She tried NRT, she tried patches, she tried a lot of things that just she wasn't able to be successful in, but also just knowing that this was a journey for her. I lost my mom 3 years ago to cancer, and she smoked up until diagnosis, a little bit even after diagnosis. I think she quit when she lost taste due to chemo and other things. But again, processing and understanding what your journey is, what your connection that you can make. And it doesn't have to be super personal as such, but it can be with a client that you've had before, something that touches you and motivates you to want to do this work is really important. One of the things I want to start with and say is that the significance of change is through combined treatment. It works the best. It's something that I want to put out there, because what I'm going to talk to you today about is one form of treatment, but there are multiple forms of treatment. There's NRTs, there's group, there's individual therapy, there's support groups, there are hotlines, there are just different peer groups that people can join or people can come along with and on this journey. But I am going to talk to you about group treatment. So group counseling, this is just one part of the change, like I mentioned. What I like about it and what I think I've seen to be successful in it is that it's a specified structured counseling group for smoking cessation and tobacco use. So it's specified for smoking cessation. There are a lot of groups out there that can address anxiety and depression. There are a lot of support groups. There are substance abuse groups. But to have a group specified to smoking cessation is something that I think our smokers and our tobacco users could benefit from, because we're just targeting that and helping them see themselves in that. And then one thing too, for me, that's been successful is utilizing a cognitive behavioral approach to evoke the change. And we're gonna get really deep into that soon. So one of the ways that we're doing it within the TRDRP in Los Angeles is we are providing Kick-Ash, which is a cognitive behavioral approach for smoking cessation groups. This is the curriculum that we use. And it is something that really helps the clients to really focus in on themselves and really see themselves as non-smokers and help them along this journey to quitting. I'll tell you a little bit about it up front. It is a 6-week group counseling session. Anyone who is trained in Kick-Ash can run these groups. You don't have to be a therapist. There's no credential you need in order to run certain groups. So I want you to think of that too, especially for your own facilities. If you want to create your own curriculum or you want to implement something similar, that you want to make it where it doesn't put limitations on who can provide this service. Because if people are willing to help others quit, we want them to be able to do that. Also, so it's a 6-week open group. What open group means is that anyone is allowed at any time in the group. So there's 6 sessions, but they don't bleed over into each other necessarily. So if someone starts session 3, then that's fine. They can start in session 3 and loop back around to catch sessions 1 and 2. Also, what it means about open group is that if someone who is on this journey complete the 6 weeks, but they've had a decline in their smoking and haven't quit completely, they can come back around to repeat the groups. And the way that the curriculum, as you will see, is set up, that for the facilitator is to change the different activities that they do or to select specific activities that they do. So if they loop back around and have repeated people, they can do other activities as well. What else about the groups? Yeah, I think that's about a good introduction to Kick-Ash. So group dynamics, the purpose of the group is to help people make change in their tobacco use. The wording is very important. The purpose isn't to help people quit, but it's to help them along their quit journey. They may not stop quitting after 6 weeks. They may not want to repeat, but we are equipped to give them tools that they can lean on even after the 6 weeks on this process of quitting. They can repeat them. They are going to learn a lot about themselves in their smoking journey so that quitting doesn't have to end at the 6 weeks or even knowing how to. The content is important. The content is, again, cognitive behavioral, true and form, very, not necessarily basic, but it really hones into thoughts, feelings, and behaviors and their levels of control over all of that. And we're giving them the tools to recognize those levels of control so that they can put them in place to help them on their quit journey. And then again, I'm going to repeat this multiple times, even when I bring up the curriculum, it is a journey. Again, we want them to understand that it's a journey as well. We don't want to make promises that they'll quit, and we want to be patient with their journey, and we want them to be patient with their journey so that they don't feel like failures when change isn't as grand. And then the outcome. We're looking for outcomes such as maybe someone at the end of the 6 weeks has gone from 10 cigarettes a day to 6. Maybe someone has quit completely. Maybe someone has realized that they were smoking and never knew how much they smoked, but they were able to track it along the way and say, wow, like I know how much I smoke now. I'm ready to start making a decrease in that. So just some type of self-awareness about their tobacco use is going to be very important. That is what we're looking for in outcome. Some type of change in that. Whether it's mindset change, whether it's actual physical change of stopping or decreasing, we're just looking for change.
all of that is progress. So outcomes thus far that we've seen an increase in level of support that people get from these groups, and support from the facilitator, as well as support from, when we're in group dynamics, from each other. We've seen a reduction in tobacco use, and we've also seen people who have quit completely. Now, the people who have quit completely, there is no, they may have repeated the groups, they may have had the groups done in a different way than just the groups. This is designed as a group, but when COVID came around, we kind of made it more user-friendly to do on a one-on-one basis, phone call basis. We've made it for a virtual group. We've made it, and it's still an in-person group. So I don't know what the percentage is of how the person received this information that led them to quit. So, but they have received the kick-ass services. So there's some barriers to implementation. Recruitment, trying to get people to come to your groups, kind of finding out who those people are, referral processes, things like that is always going to be part of you running groups. It's going to be something that never ends. You want to keep people lined up to come to groups. Again, it's an open group. People can enter at any time. So the referral process that you use and the recruitment that you do to get people to your groups it doesn't end. That goes ongoing, and people can be invited in and join at any time. Consistency is important. If you're running 6 weeks and you want to loop back around for the next 6 weeks, because they don't have to ever end, you can give yourself a break. You can do 6 weeks, take a week or two off, and come back and do 6 weeks, take a week or two off, however you feel like it's comfortable for you and your facility. But being consistent as a facilitator is super important, that you are showing up regularly for them. So if 2 people come to your group, you're running a group. If 1 person comes to your group, you're running a group. Now, if 8 or 9 or 10 people come to your group, you're running the group the same. So being consistent in how you're doing it, it doesn't matter how many are there, what's there, you showing up in your consistency is going to help your clients want to be consistent in their change. And COVID-19 still is a barrier. Things have changed, things have opened up, but there are still people with anxiety and fear surrounding COVID-19. And again, getting them into group, getting them the buy-in. Another thing with COVID-19, what we saw was people were more shut in and at home. What is there to do but smoke? So kind of playing on behavioral things and making more behavioral change. Know your audience, know who you're serving in this process so that you can tailor the curriculum to them specifically to really help them. So behind the scenes, there's lots of training that we do here in LA County. So one of the trainings, we provide the kick-ass training to facilitators of LA County sites, clinics. We started off doing this monthly, then we went to every other month, then we went to quarterly as time progressed. Also providing refresher trainings, kind of refreshing any changes made to the curriculum or any just refreshers that the facilitators may need or questions that they have, providing that support to them and making sure that they're well-versed in learning the material. And then recruitment, again, that's something that's always in the works. Recruitment, referral processes, getting clients to buy into that change and want to quit and come into the groups. And then ongoing support. My role is providing ongoing support to facilitators that we train. And ongoing support is through multiple emails. Any questions you have, I can answer. Meeting with facilitators regularly, talking with facilitators regularly, just to make sure that I can be of any kind of support that they need. And I will tell you, a lot of the support I'm providing is in recruitment and referral process, and buy-in and getting people to come into the groups and making the groups well known at your facility and site. So that's it for my slides. What I'm going to do now is open up the actual curriculum and quickly go through it. so that you can see what it looks like, see how it's set up in case you want to create your own curriculum and implement something similar. And I will see if I can put my email back up. So let's see. So this is the actual Kick-Ash curriculum that we use. This is the, no, it's not, sorry. I will show you that in a minute. Sorry about that, guys.
Okay, that's what I was saying. There was just like deliberate. Just take them out. We'll find out. I have a lot of N95.
Yeah, that's true. How they different people keep getting on here somehow.
They're not hits. They're counties. So they're the counties. So they're not hits. So take a box.
Okay, got it up. All right, so this is the Kick-Ash Facilitators Guide manuals. It's the actual manual that I train. It's the actual manual that our facilitators within LA County are using to provide this service. And again, it's a cognitive behavioral approach for smoking cessation groups. And I'm just gonna follow up. So some of the things, I'm gonna be breezing through it, so you're not gonna get every single page of this because it's pretty lengthy, but I do wanna highlight some of the important things that I think are helpful. So this is just a session overview. It has for the facilitator what is going on in session 1, and these are the different activities. Now these are 1-hour groups. Now there are 4, 5, 6 or 7 activities in session 1. Now, remember when I said that when you loop back around, you can choose other things. All of these are not to be used in the first session. It is up to the facilitator of how they want to start. There are some activities in each group that are deemed to be mandatory or highly suggested that you actually do. But some of these you can go choose which one you want to do, and some of them overlap as far as what they're covering. And I did that because I want the facilitators to be to make it user-friendly for them and to also be very comfortable in what they choose to give. And making that change, being able to pick and choose when they loop back around, again, there's other things to pick and choose. So it doesn't get boring, it doesn't get mundane, and it doesn't get to the point where it's just this you as a robot repetitively doing this. You're actually engaging and involved as well when you have to make these choices. And so you can see that in every session, there are multiple activities and things to do. And then we move to the session overview. And this again is just for the facilitators, just what participants will gain from each session. And that's just written out for you to be able to get an idea, which is also helpful for you in choosing the activities that you decide to choose. But it is structured in a way that I will talk about which one of those are mandatory or that you should do. Each session also has an introduction. So again, it's just introducing the facilitators through what they're going to be giving them in the session. One thing that I want to point out, and I'll point out as we go through each session, is the name of the sessions. So session 1 is Living Tobacco Free, a dream for a lifetime. It is called this because it's literally a visualization or a dream where we take the clients through visualizing themselves as smoke-free. This is important because if they can visualize themselves as smoke-free, it makes a goal, it makes that dream something very motivating to want to attain. So we take them through different exercises and seeing themselves as smoke-free. One of the things that I say, again, this is a group overview and introductions for activity 1 it is group overview. This is something that's mandatory that I think you should do. It's your first group. You want them to introduce themselves. You want to do a group overview and explain why we're here, what we're doing. And again, the instructions to the facilitators is really spelled out and gives them specific instructions of what to say even on some of these and what Activity 2, establishing group rules. I highly suggest you establish group rules in that first group because you really want the participants to, the way that it's spelled out here in the instructions is that you engage your participants in there. So you can come as a facilitator with already group rules that you want to have, but I highly suggest that you allow them to create group rules as well. Again, very basic group content, group things that are covered, but I wanted to spell this out because remember what I said earlier is that anyone can run these groups. Even if you've never run a group before, this curriculum is written to help you figure that out and how to do it, and so that you feel confident in doing it. I offered an activity here called the group contract, which I have used multiple times and it works really well. Basically, it's a paper where there's 3 questions. How will you want to be treated by the leader of the group? How would you want to be treated by the other participants? And how will you treat others in the group? And then we create a list of all the answers that everyone in the group has put up. And we go by that. And that's the binding contract of what our rules are. And then this is just a form that they get to be able to answer those questions. Self-visualization activity. This one is where we're really having them close their eyes, getting comfortable in their seat, and really visualize them as smoke-free, themselves as smoke-free. Again, the instructions to the participants that the facilitator will be given is written to where if you get everyone to close your eyes, all you have to do is read this. And you're reading through this. This is the actual visualization that you will walk through. And it's having them ask questions like, how would you feel if you didn't use tobacco? How would your life be different? And you're walking through asking these questions for them to answer while they're in their visualization. Now, the purpose of this is so that they can get more in tune of what that life looks like or could look like for them. At the end, and you have them open their eyes and come back into the group, then you want to open up a discussion of what came up for people and have people share at that point of how they saw themselves as smoke-free and what that life looks like. Here's a dear future self. Again, I'm not going to go through every activity, but this is just them writing a letter to their future selves, their future smoke-free selves. If you choose to do this, then you're going to hold on to the letter as a facilitator. If you're virtual, you're going to ask them to put it away somewhere, have them tell you where they put it so you can write that down in case they forget, because in session 6, we're going to open up those letters and we're going to see where we are then from now. And this is where they will write it on. Now, this is one that I highly suggest that you do because the participants all love this activity. It is the health fact sheet and information. And basically what it is talking about the changes that happen from 20 to 30 minutes in the body, all the way around to 15 years if they stop smoking. So quitting smoking within 20, 30 minutes, already your blood pressure drops, things happen in your body for your health. And this is an outline of showing them what are the different changes. And the participants really get a lot from that because it helps them put a purpose to why am I doing this? Core beliefs, just walking through tracking core beliefs, what they believe about themselves as smokers. Again, asking questions about how you see yourself now in present day and how you see yourself in the ideal you smoke-free. So kind of similar to the visualization, but it's a more open dialogue and open conversation that you have with them. And then notes for the facilitator to jot down. So then we move into session 2. Again, another introduction for the facilitators. The name of this is called Embarking on a Tobacco-Free Journey. The first session was Dream of a Lifetime, envisioning themselves on this journey. And now we're about to embark on it. We're about to start this process. So from session 2 on, one of the things that is important is goal setting. There's an identifying triggers activity there for the facilitators. And there's this explicit information about goal setting, because this is going to be important for every session moving forward. We really want to teach our participants how to set goals in their smoke-free life, for their smoke-free life, to help them attain. And we want them to be attainable week by week. And we want them to be something starting off small, and we can add to that. And so in helping people figure out where they are, we give them this tobacco-free starting points. Do you want to set a quit date? Do you just want to reduce? Do you want to track your tobacco use? Do you need to increase support? So we are not pushing them to say, I want to quit. We're pushing them to set goals that make sense for them where they are. And we review this every week so new goals can be created. There's some blank spaces for them to fill in for themselves. More information on goal setting. Here are the actual goals and how we want to do it. Now, we talked about them creating goals for their smoke-free self. When we're making goals, we want them to create 3 goals: a self-care goal, a personal goal, and a smoking cessation goal. Because in this process of on the journey of quitting, they need to take care of themselves in different ways too, so that it helps support the quit. So creating goals, self-care goal could look like taking better care of myself, putting forth actions that allow me to be kind to myself. Personal goals could be financial health, fitness, career, education, wherever they are in their life in that. And then a quit attempt or reduction in use of whatever their smoking cessation goal. We have them write those 3 overall goals that they come up with, and they're very broad. They're not broken down at all. And we have them write them here. And this is what they get. They get this, they get to write it down here. And then the 5-week goal plan is, what do they need in order to meet these big goals? Because when they actually set the goals, this is what it looks like. Every week, they will write the big goal down, and then they'll break it down for the week, what they can do towards their self-care goal. So we broke down the self-care goal to improve my overall emotional well-being by paying more attention to myself. What they can do this week is meditate in quiet time at least 2 times this week, or put myself first at least 3 times this week. A personal goal is to be healthier and take better care of my body. This week only, we're going to drink 4 glasses of water at least 3 days a week. So we're not pushing them even in these goals to be overly grand that they can't meet them. Do yoga 4 times this week. Take a walk 3 times this week. This could also just say 1 time this week. And then their smoking cessation would be more aware of the thoughts and feelings before and after smoking, keeping track of that. So really slowly, we're taking them on a journey through their goal setting. And then they get this every session and write their goals out, and then write what they're going to do for it in the week. If they don't pass them, they can just repeat it the next week. If they do, they increase the frequency or move further along in that goal. So here's a cognitive triangle. We definitely want to discuss what this is for them for the next groups coming up. We know that our thoughts affect our behavior and our emotions, that they're all interlinked. And then we talk about how changing one of these can change all of these and change the pattern of how we operate in our day. And we give examples of what that looks like. And then there's another activity for coping strategies. This one I highly suggest that you do too. There are 3 basic coping strategies that I want to give them in this group up front, so that in the case they feel highly stressed through this journey, they at least have these 3 things starting off with being able to access. And it's just deep, slow breathing, deep muscle relaxation, and picturing a peaceful scene. And we teach them how to do those 3 things and how to access them and when to access them. Throughout this journey, we're giving them a ton of coping skills, but this is something up front in session 2 I highly suggest you give them, so that they don't feel like they have nothing when they start off. And then the notes for the facilitator. So session 3, now we're getting into the cognitive behavioral piece of it. We had Dream of a Lifetime, where we're envisioning being smoke-free. We had Embarking on This, where we're teaching goal setting in a specific way and empowering them to meet goals and to go there. And now we're going into Regulating Thoughts. So the cognitive triangle, thoughts, behavior, and emotions, will take up the next 3 sessions. So right now we're doing Regulating Thoughts. And again, every group in the beginning taking 5-7 minutes to write their goals down, what they're going to do for the week, review if they made them or not, and then move right into it. So we have core beliefs, again, wanting them to understand what that means. This is for facilitators to kind of get, adjust to what it is for them, what are automatic thoughts, little definitions for immediate beliefs, things like that, so they can have the verbiage to be able to converse with their participants through this. We're going to teach them thought stopping. We're going to teach them worry time. And so worry time is something I use regularly. If a client has excessive worries, I have them spend some time, maybe 5 minutes, to write it all down, set an alarm with a noise, and sit there and worry about it. Just sit and worry on this list. And every time you do this list, rewrite it. And some people need to do this 2 or 3 times, depending on how excessive their worrying is. And then once they're done worrying about it, they go about their day. So that at lunchtime, or even during the middle of a work day, they start worrying, they can retrain their brain to say, oh no, it's not worry time. You need to go over here until it is. So they're able to make that, rewire those neurotransmitters to have more control over their thoughts than they think they have upfront. And this is a process. This takes time to learn, but it's something that they can do. Reframing thoughts, we teach them how to do that. These are specific ways of reframing thoughts. One of the things that I say up front is to write down positive things about yourself, and write positive things about your life, because we can, once we write them down and get them there, this is something we can access whenever our thoughts get negative against us. So we now have this in front of us where we can actually pull from and think positive. We talk about mindset, going from a fixed mindset to a growth mindset. This is another activity. And then the notes for session 3. And then we have session 4, a tobacco-free journey, regulating feelings. So we did regulating thoughts. Now we're on regulating feelings. Again, the introduction for the facilitators, the goal sheet for the participants, and then we go right in. Immediately, I want to make sure participants understand their feelings and understand what they are. If you ask somebody like, how are you feeling? Oh, I had a bad day. Is that how they're feeling, or is that a thought? So we really want them to be able to access feelings. And so here's a feeling chart of different feelings. Usually if you do ask people how they're feeling, they say good, bad, or you get sad, happy, mad, the basic feelings that everyone can access. On purpose, I put things like disappointed, excited, guilty, something to help them dig a little bit deeper to really touch on how they're feeling or what's going on when they need to really be able to identify those feelings. And they're not the same. They're not the usual feelings, like understood. I feel valuable. I feel worthwhile. I feel relaxed. I feel hopeless. Good and bad, we want them to be able to identify feelings, because if we have to change any part of that cognitive behavioral triangle, they have to be aware of what the feelings are that they're experiencing. So I highly recommend that upfront. And then there's happy thoughts and pleasant activities. So with feelings, one of the things we talked about, reframing thoughts and stopping thoughts and having more control over thoughts. We can't really control our feelings. So these are things, something happens and our feelings come upon us. So we have to then do something different in order to put ourselves in a different mood. So I combined happy thoughts and pleasant activities. So this is just a list of activities they can do: solve a puzzle, take a nap, work, but it also determines what the feeling that they are feeling in order to find the exact activity that meets that and will help change their mood. And we'll talk about that in behavior, I think, a little bit more. And then one way to do that, to get a grasp of how to access that, is have them write activities I enjoy and why they enjoy them. And the reason for this is because if they have the activity of planning a trip, because it gives me hope of a dream or something that I can do. So if they're feeling like alone, or if they're feeling bored, then they can go ahead and plan a trip, because it's going to then boost their mood into hopeful things like that. So if they understand what activities they already like and can put with it why they like it, then they'll be able to access the activities they need to do to change their mood. Session 4. No, we're on session 4, regulating feelings. So this is another activity. It's another visualization process. And again, the visualization is right here, word for word, even if you don't get them to close their eyes, because they don't have to, everything is an invitation to participate. Then you can still read this word for word. And this is a visualization of kind of like their happy place, kind of visualizing a place that makes them feel good in. So again, one of those coping skills is accessing a peaceful place. And so this is what this is. So we have an activity called responding to feelings, talking about self-discipline and talking about how we act on feelings versus, really making sure we combine thought to feelings so that we aren't just acting on our feelings without thought. Like, we want to make sure we can have some depth self-discipline, that we can feel bad but do something good, because the cognitive behavioral triangle will tell us if we feel bad, we're going to behave bad. So we want them to be able to access how much control they have over themselves and what they're feeling, what they're thinking, and what they're doing. Note section. Session 5, regulating behaviors. So again, this is the introduction for the facilitator, the goals for the week. And then we talk about trigger behaviors into alternative behaviors, identifying some trigger behaviors that they have related to smoking. What is happening around their smoking before, what happens after, what is triggering you into that. And so that we can identify some alternative behaviors you can do to those trigger behaviors. So this is a list that is mandatory to give and mandatory to show them because it's super helpful. It's a list of alternative behaviors, and I've broken it down by need. So if they have craving busters, like these are the craving busters, if they're craving tobacco strongly, they can engage in these different activities: floss and brush, whistle or hum, run in place, chew gum, frozen snack. They're all kind of helping with the craving that the mouth even has and the taste that they get from cigarettes. We're going to replace that with eating a tart candy, something of such. We want them to avoid isolation. These are things they can do to avoid isolation: give hugs, write a letter, call a parent, spend time with kids, call a friend, go volunteer somewhere, write a grateful list. Just coming out of their room and engaging with other people in the home could be helpful. If they need a distraction while they're at home, washing the car, cleaning the car, organize photos, plan a vacation, things like that. Keep hands and mind busy. The reason why I want to talk about keeping hands busy, if we have smokers, they are so used to this, smoking is something that becomes routine. So it's so used to just doing the routine of like, oh, it's time for my cigarette. Oh, it's time, So we want to keep the hands and mind busy by painting, knitting, getting a new hobby, taking photos, things like that. Be active, get out and about. If they need to do those things, these are all activities they can do. Embrace relaxation and treat yourself. I'm all about the self-care in this, all about making sure that they see themselves and are taking care of themselves. Because we also know that smoking is highly related to anxiety or depression and things that, smoking soothes them. If they can find ways to soothe themselves in a healthy way, the more the better. And again, this is the cognitive triangle, because now we're going to bridge together everything, because now we're in session 5, regulating behaviors. So we talked about feelings, we talked about thoughts, feelings, and now we're in behavior. We just want to bring it back to them to be able to see what they've learned along the way. And this is a blank one to talk about in that present moment in group, what they're feeling, what they're thinking, and then what are they doing? They actually showed up to group, but what led them to show up to group? What's the feeling and thought behind that? This is something I highly suggest as well, recognizing their behaviors really quickly. It's like, if I'm happy, the thought that I have is, this is great. And the somatic response. So this is teaching them about the somatic response that automatically happens. I'm probably walking around smiling, and a natural response is laughing and smoking. If I'm happy, I want to smoke. I'm laughing or having a good time, I can smoke. But then we want to teach them helpful behaviors like laughing, sharing good news with someone else. So we want to replace that smoking piece with something else. And you'll see in SAD, it's smoking and crying. I put crying as a helpful behavior because I'm all about the crying and tears. It's a release. but we want to engage in present activities. So we want to kind of help them see what's automatically happening in their bodies so that they can put in place a helpful behavior to make change. Okay, so now we have session 6. This is an important session. Again, the goals. This is our last session, and yes, we're giving them the goal sheet because we want to teach them how to continue making goals every week for themselves. Even though we're not going to go over these goals that they set this week because we're done unless they come back, they can continue this on their own. In session 6, it's called Living the Dream. So now we've done all the things, we've embarked, we visualize it. Now we're actually going to live the dream, take everything that we've learned and implement it here. And this is where we talk about lapse versus relapse. Relapse prevention is all session 6. Giving them all of the necessary prevention strategies that they need, giving them statistics of what is really tied into how a relapse happens so that they can put things in place to avoid them. And then on this, we have them write down their triggers to smoking and different situations that they smoke in. We have them write down their levels of supports that they have and their strengths, because this is important. When they start to feel these triggers, they go down here to leaning into their strengths and their supports to prevent that relapse. This is just giving them more resources like the hotline, the quit lines, things like that that they can access if they again feel like they want to go back to smoking. And then this is where we review the My Dear Tobacco Self-Free letter that we wrote in session 1 and talk about it and see where their differences are. And then notes. Now this is set up to have a bonus session A and a bonus session B. I'm not going to go into those. Those are just in case, like people who have mastered it and continue doing the groups and how to utilize them as a help peer support in your group or things like that. One of them I will talk about is if someone has relapsed and returned to group and you know that they had already quit, then what do you do? No matter where you are, if you're in group 3 and you have a relapse participant coming back, you switch to group 6 because none of them are aligned to have to be in order. Once you get to sessions 3 and like the feelings, thoughts, behavior, and relapse prevention. And the relapse prevention session can be given at any given time. So if someone comes in and they've relapsed, then we can just go straight into session 6. And that is the Kick-Ass curriculum. I think I'm about over time, but I want to show you one more thing. And this is, so this is basically the workbook. That's still the, sorry.
Uh-oh, did we lose you, Tashi?
No, can you see me?
Okay.
Okay, so this is actually the participants guide workbook that they get. And in this workbook is all of those things that I talked about that we give them as handouts. And we also give them notes as well to be able to take notes in the groups. But everything that they need that we're talking to them about, how to do the goals, all the goal sheets, everything is given to them. And we repeat the goal sheets per session. So they already have the handouts ready for them. So that is my presentation. I hope it was helpful. I know it was super fast and I really breezed through that curriculum, but it's an intense, it's an in-depth curriculum. And when I train it to the page with interaction. So yeah, I had to combine all that in a small time. So if there's any questions.
Yeah, the main question that we get all the time is, when can I get the manual? When and where is it available?
Yeah,
so,
I do that. I don't know how to answer that. I know we're doing
Dr. Freeman, yeah, we're winding down the study that we're working on. And we're waiting until, we get the data in because we have some treatment as usual sites, as well as the sites that are actually getting this training from the manual. And there's a comparative piece in the research design. So it will be available. I have all of your emails, and I think that might be one thing that we can do is send a blast out when it is available. This is our last year, and we'll be stopping recruitment in the next couple of months, but the study actually goes until we wrap up everything in June, supposedly. So sometime between November and June, we'll be making it available. And I have your emails because you were on this training, so you'll be able to access.
But
you want to talk about the training that we'll be doing for other LA County?
yeah, so we're submitting a grant with Kath.
No, this year, like finishing up this grant, we're going to start bringing in other LA County sites to
Well,
be
what he's
trained.
talking about is the new grant.
Yeah.
We are providing Kick-Ass through that new grant as well. So that is an opportunity for other organizations and facilitators to kind of join, like sign up for that. And that's why I'll be offering that training across California versus just LA County. And that is—
Yeah, but I mean, right now, as we're finishing up this grant, aren't we inviting the other sites in the next couple of months or so after we start recruitment to see the curriculum and how it works? Is that correct or no?
Yeah. Well, there's 3 sites that are treatment as usual that will join us. But I think we're gearing up for our next grant, which is going to be with Catherine from UCSF Leadership Center to expand the training. And part of that's going to be distributing the Kick-Ass training to those people as part of the their session. So we'll see about it. I think we do want to help everybody out and give them the manuals as best as we can.
Yes, it's in the pipeline, folks. So like I said, we have your information. So if you happen to change emails, let me know, because that's how we'll be notifying folks what's happening going forward with the new grant, new activities and all. Thank you, Tasha. Very informative as usual.
Yeah, great job, Tasha. Thank you so much.
Yes. So we want to start our wrap up now so that we can be respectful of folks' time. And what we have, Dr. Friedman, can you put on the, let's see.
Yeah, I'm going to share my screen.
Brandy's here. Yeah, Brandy, yeah. And so we need to go down to the slide where Brandy starts talking about the CMEs. That it? You hear, Brandy? Oh, I need to give you access. Wait, hold on. No, you just need to be able to talk. Can you unmute yourself?
I am. Hi, everyone. Hi, Norma and Dr. Friedman.
Hi, Brandy. Hi, Brandy.
Hello. Nice to see you all. I always love these events. I'll be fast, everyone. So basically, if you do need continuing education credit, we have CMEs for physicians and nurses. We have credits for psychologists. We have credits for all our amazing counselors, social workers, you name it, we've got it. You will need to fill out a post test, and I'm going to put that link in the chat in a minute. So you'll fill out a post test. Once you pass it, it's 10 questions and it's all content that's been covered today. You'll get a link to the CE evaluation, and you'll just click the link that fits the type of certificate, license or certification that you have. And then you will get your CE certificate in about 6 weeks. You will need the start and end code. So earlier in the morning, if you could scroll up and look for it if you forgot it, we did post the start code. And then next slide. If you could advance to the next slide.
Okay, not sure what the problem is. There we go.
Oh, sorry.
There we go. Okay.
That's where just back on the CE credit, you just have to pass the post test and you can keep trying it. Next credit. We don't, Michael, do respiratory therapists, but what I do suggest is filling out one of them, and you can always submit it to your board and ask them for credit. All right, so here is the end code. I'm going to post a link in the chat with the end code and the post test. So that's the only link you need. Let me do that really quick. And then you can also use the QR code on the screen if that's easier for you. You can use your phone and just scan the QR code. You know, like I could take mine out right now, scan the code, and then it'll take you to the post test. And if you have any questions, like for instance, maybe you did miss the start code, just send me an email. I'm going to put my email in the chat. So you can email me directly, and you know, all we have to do is look up our Zoom attendee report and we can help you. All right, so don't worry. We know you've been here a long day, so I want to make sure you get your CE credit. So that's the process. Just scan that code or click the link. You'll fill out a 10-item post test. You can take it as many times as you need, and all the questions were covered in the content. And then once you pass, you'll get your evaluation. that's where you enter your start and end code, and you'll pick the basically the the type of evaluation you need. If you need CME credit, if you're a psychologist, or all the other professions. All right.
How long do we
And-
have to take the CME quiz or the quiz? Sorry.
I would love for you to do it within the next 2 weeks, just because
Oh,
it's easier, but we won't close it anytime soon.
Great, thank you.
And the end code is 4862. 4862 was the end code.
And what was the 7? Was it 7177? What was that code?
Well, we aren't resharing the start code because you had to be here at the beginning. So that might be the start code, except it's not. That's incorrect.
Okay. Well, I'm a little dyslexic, so.
Oh, it's close. But yeah, we can't reshare it. But if you scroll up or just email me, if you have any questions, we can easily send it to you. I just have to do a quick check to make sure you are on the full time.
Should we go on the chat to let people see it, or you don't want to do that?
Can't do that. That's not protocol. She's explained if
Yeah,
they, if they have an issue.
Yeah, and you can scroll up, like all the chat from the whole day is there. And I did post the start code quite a few times. So if you just scroll up, you'll see it. I know sometimes people do get bumped up from their Zoom. So that's, where I'm happy to provide it with you. If you are booted and don't have it anymore, you got to email me. Yes, I will post my email and the link one more time.
Did I not hear the word GIPRA this time?
Yeah, we aren't doing the GIPRA.
Oh,
just
okay.
the post test. Yeah.
Okay, super.
Yeah. We figured so many surveys, give everyone a break. We'll just do 2 this time.
Thank you so much.
Instead of 5 million.
Yes. We appreciate it.
Yeah.
Okay. Well, thank you.
So thank you.
everyone.
Thanks everybody. Especially thanks to Norma for organizing this and just having a fantastic day with great speakers and really inspirational talks. And Norma's video was really great. So we look for our next one's probably going to be in March. Probably a little bit more geared to providers, but everybody's welcome for that one too. And Norma will send out the slides and the recordings shortly in the next 2 weeks. And get those patients, those clients to stop smoking, please. That's the best thing you can do, or cut down.
That's the goal. Yes. Okay, everyone.
Okay.
We got
Bye.
great sun here in California, Southern Cal, so maybe I can soak up a couple of rays before it's all over today. Take care. Take care of yourselves. Bye-bye.
Bye.
For all of you saying thank you. It was our pleasure. Okay, so I am going to stop the recording. I think we're at that point. And that will